and gentlemen, welcome to the second day of the 44th Annual Academic Sessions of the Candy Society of Medicine. Starting off the day, we are moving on to the 7th symposium. This is on thyroid disorders. May I invite the two chairpersons for this symposium, Dr. Anuradha Aryavansa, Consultant Physician, Teaching Hospital, Pera, and Dr. Consultant and Head of the Anesthesiology and Critical Care, Faculty of Medicine.
Good morning, everyone. So, first of all, I would like to welcome everyone present in this symposium of thyroid disorder to sessions of Candy Society of Medicine. So, we speakers today, specialties of endocrinology and oncology, discuss some important aspects in thyroid disorders. So, our first speaker, Dr. Sonali Kumatilaka, consultant endocrinologist from Hospital Mera. Sonali Kumatilaka, she in 2008 from University of second class honors with 10 distinction during and she obtained her in 2015 Colombo. Her overseas training at Oxford University NHS Trust and Cambridge University NHS Trust, and her special interest both diseases and pituitary diseases. Her contribution to several guideline developments, both nationally and internationally. She is a several peer-reviewed article published in international journals and a book. So, he will speak in interpretation of thyroid function test. Dr. Sonali.
Thank you very much, Chairpersons, and I would like to take this opportunity to extend my thanks to the KSM and the organizers for giving me this opportunity. So today my topic is pitfalls in interpretation of thyroid function tests. And, we do thyroid function tests day to day, and thyroid functions are among the commonest of all endocrine assays or hormones done in routine practice. And if you see, if you take all the tests, majority are like normal, and out of the abnormal ones, majority are straightforward. But there's small but significant number of thyroid tests in which we need to interpret the thyroid functions properly, which could lead us to a very important diagnosis, and we can cure or control the patient's disease. So without further ado, let me start by just discussing about the hypothalamus-pituitary-thyroid axis. I'm sure all of you know, but in endocrinology, it's so important to know the physiology in order to interpret the test results. If we don't know, then we go wrong. So our master gland is hypothalamus and pituitary, basically both, and then hypothalamus secretes TRH. So I'm trying to get the laser. Yeah. The hypothalamus secretes TRH, and pituitary, in response to TRH, secretes TSH, thyroid stimulating hormone. Thyroid stimulating hormone tells the thyroid to secrete or produce thyroxine hormone, that is T4 and T3. Of them, majority will be T4, but in the periphery, the active form T3 will be formed. And according to the level of T4 and T3, the pituitary detects the level, and then if the level of T3 and T4 are high, pituitary detects it and reduces the TSH output from the pituitary to keep the homeostasis, keep the TF4 and T3 levels in a fine balance. But now that is the normal physiology. What happens in abnormal, if the physiology is abnormal? If the gland, due to many causes, if the gland secretes or produces more T4 and T, there are too many T4 and T3 hormones in the circulation, so I should not be sending too much of TSH to stimulate the thyroid. So when the T4 goes up, pituitary reduces the TSH secretion. So T4 up and TSH down, that is the normal physiology in the pathological state. And you can see in this graph, so this area where the TSH and T4 are in the normal range are the euthyroid population, whereas when TSH is suppressed and T4 is high, that is hyperthyroidism or thyrotoxic state. Similarly, when the peripheral circulation, if the T4 and T3 is low, what will happen? The pituitary detects, okay, the T4, T3 is low, therefore I should send more and more messages for the thyroid to produce more and more T4 and T3. Therefore, T4 and T3 becomes low and TSH becomes high, and that condition is hypothyroidism, where the circulation amount of T4 is not good enough for the metabolic demand of the body. So this is straightforward, from the medical student time. All of us, to the consultant professors, this is pretty basic and all of us know. So what am I going to talk about? Thyroid function tests. Among these abnormal thyroid function tests, there are some funny TFTs. I would call TFTs thyroid function test in short form. We call them funny TFTs, anomalous TFTs, puzzling, weird TFTs. We give so many names. But what are they? If a patient's clinical, or maybe patient is clinically hyperthyroid, but when we do the bloods, if the blood test results in some completely opposite or some funny thing, maybe hyperthyroid patient getting a blood test of hypothyroidism, that is discordant. So discordant from the clinical scenario to the blood test. Same way, thyroid function test can be discordant to each other. Like I told, when the TSH goes up, T4 is usually, we expect it to be low. But what if TSH is high and T4 is also high? It's difficult to interpret. So they are the anomalous TFTs that we need to pay attention to. So I'll go take you through in several case scenarios, but because otherwise it's going to be very boring, just talking about the physiology. So this 24-year-old female was evaluated for body weakness, and TSH is 0.01 and free T4 is 18.3. So TSH is low and T4 is normal. We expect T4 to be high when the TSH is low, but this is normal. So what can it be? So in this lady, she's in the reproductive age, and we found that patient is amenorrheic, and then to see that patient is pregnant, and during the early pregnancy, even in a asymptomatic patient, this is a classic normal phenomena that you get. So here, this is the hormonal profile in pregnancy. You can see during the early pregnancy, the HCG will rise markedly. So HCG is somewhat similar to TSH. They have similarity in their alpha component. Therefore, HCG mimics TSH action, and the thyroid thinks, okay, this is TSH, whereas actually it's the HCG which is around thyroid. But because of that, thyroid produces too much of T4, and in response, TSH is dropped. You can appreciate this is during the early pregnancy, and later on it gets corrected. And this condition does not need treatment. You need to observe and monitor. Same way, if the patient is not very well, if the patient is having some kind of an illness, similar thyroid profile as previous, but during recurrent illness, intercurrent illness, the thyroid, then similar kind of a thyroid profile can be achieved. So during intercurrent illnesses, the thyroid physiology doesn't work as we expect. So the TSH becomes quite low initially, and then reverse T3, which is inactive, becomes high, and total T3 and T4 goes down. And it's so bizarre, and it's difficult to interpret also. But we need to know mostly the thyroid functions go down during acute illnesses. That is as a protective mechanism to the body. So even in this condition, a similar profile can be seen, and this does not warrant any treatment. What if somebody is on steroids? Steroids directly inhibit the pituitary and also hypothalamus. So if somebody is on steroids for a short period, they will suppress the TSH, but there will not be enough time to get the T4 down. So they will have low TSH with normal T4. And if this goes for a prolonged period, even T4 will become low. And I told that TSH to become low, there must be something suppressing. But T4 is normal. What if T4 is normal but T3 is high? We call it T3 toxicosis. That T3 can inhibit the pituitary and cause low TSH. And this is seen in early Graves' disease and even toxic multinodular goiters. And what if this patient is normal, just body weakness and having this profile, and she persistently tends to have this kind of a profile, low TSH with normal T4. This may be an early stage of hyperthyroidism, or she may remain with this kind of a profile. If we repeat it in 3 months' time, if she remains with the same profile, we call it subclanism, and I think Naina Anjali will talk about it later. Okay, case scenario 2. TSH is 8.6 and T4 is normal. So previously we talked about low TSH, now it's high TSH, slightly high TSH with a normal T4. Is this patient hypothyroid? We come across this kind of profiles quite often. And she was evaluated for a dry skin. This, again, when the T4 is normal, we expect TSH to be high. Normal. If the TSH is high, then we normally expect from the physiology, isn't the TSH low? So in this scenario, again, any illness, I told illness can cause this kind of bizarre profile. If the patient is having kind of a non-thyroid illness, this can be explained. If you can see the latter part of the disease, where the TSH is high, but the T4 is normal in the yellow line, that can be seen in illnesses. What else? If this profile persists for about 3 months or more, then when we repeat, you would get the same profile, and that we call subclinical hypothyroidism. Patient doesn't have much symptoms of hypothyroidism, but it's subclinical. Patient may go into hypothyroidism, not all, only a certain percentage. And again, we will discuss this in the next lecture. Scenario 3. So in scenario 3, 28-year-old female evaluated for weight gain. Here, TSH is low and T4 is also low. Both are low. When T4 is low, we expect TSH to be high. But why is this low? Again, illness can cause this kind of a profile. It's easy. So all the abnormal results, check whether the patient is ill or having non-thyroidal illness. And what is the other thing? What if there's a lesion in the pituitary that will destroy the thyrocytes and reduce the TSH secretion? When TSH is not enough, thyroid will not produce enough T4. So any pituitary disease, tumor, radiation, infiltration, anything can cause central hypothyroidism. And if you do only TSH in this condition where the patient is hypo looking, but TSH is suppressed, you can't just say this is hyperthyroidism, excess hormones, unless you do free T4. So we see quite a number of patients coming with misdiagnosis to see that it is ultimately the pituitary disease. Okay, then I would move on to case scenario number 4. This is somewhat different to all what I have mentioned. Here, the TSH is marginally elevated and free T4 is also elevated. When T4 is elevated, we expect the TSH to be low. Now both are high. What can cause this? Again, same old non-thyroidal illness can cause this. And you can see at one point in this graph, you can find any of the combinations. And what if the T4 level is wrong, or what if the TSH level is wrong? We can have assay problems. So assay interference are very common, especially among patients who are having autoimmune diseases. So you need to keep an eye on those diseases and exclude assay interference. Otherwise, we will be treating unnecessarily. What if there is a tumor here secreting TSH? Then TSH will be high and then T4 will be high as well as a response. Even though high T4 levels are detected by the pituitary and try to suppress TSH, this is a tumor. It's autonomous. So it will continuously secrete TSH without getting suppressed by elevated T4. So this kind of profile, TSH-OMA should be kept in mind. And in addition, I haven't put that, but there's a differential diagnosis. I will talk about it later. Thyroid hormone resistance mimics a TSH-OMA. They are rare conditions, but can't miss. So this is all what I have talked about. The normal thyroid, hypothyroidism, and thyrotoxic status, which you and I are quite familiar with. And then all the other 4 scenarios where TSH, T4 normal and TSH is low, but T4, T3 are normal. TSH is high, where T4, T3 are normal. And then both T4, TSH are low and both TSH and T4 are high. So I've discussed all these conditions. I'll quickly take you through day-to-day life scenarios depending on the time. Case 1, 22-year-old female, primigravida, POA 12 weeks and has hyperemesis. I discussed this earlier as well. TSH low, T4 high, and this is early pregnancy. We get a lot of referrals and we need not to treat this because this is because of the HCG effect and this is transient hyperthyroidism of the pregnancy. Now, this same lady comes in the 3rd trimester. 3rd trimester, you see TSH is normal, 2.5. We have to take trimester-specific TSH values though in pregnancy, not the normal values. And you can see there's an elevated value. T4 is elevated. Why is that? If you carefully see, this is the total thyroxine, not free thyroxine. And in this graph, you can see thyroid binding globulin increases during the early pregnancy and remains high during the latter part of the pregnancy. That's due to the hormonal effect. And with that, the thyroid hormones get bound to these thyroid binding globulins. Therefore, when the protein is high, total T4 level will invariably be high and you get a high total T4 levels. But if you see the free T4 levels, that will remain in the normal range. So in pregnancy, total T4 will be high, although the TSH is normal, but free T4 remains normal if you measure. Case number 2, 70-year-old female evaluated for lethargy and heart rate is 68 and no other features of hypothyroidism. TSH comes as 5.8 and T with a normal T4. I told that this can be an unthyroidal illness, but patient is well apart from lethargy. And what can this be? So is it subclinical hypothyroidism? To answer this, we need to know some facts. She's a 70-year-old lady. With age, our normal TSH cutoffs go up. So for a 70-year-old lady, this level of 5.8 is normal because that is an adaptive method for the body to live longer or healthier than getting the TSH suppressed. So we see a lot of patients being treated even at the age of 70 and 80. This is a normal profile and you need not to treat. With the age, the TSH cutoffs, the levels, you can see the mean goes towards higher levels, 4.7, 7.1, 10, so likewise. And even this is a normal population. There are patients who are with 10, 16 also, and in the 95th percentile, maybe around 23 is also normal for some people. So please make sure that in elderly, you think twice before treating. And okay, this again, another lady, 70-year-old, TSH is suppressed 0.05 and T4 is high. So obviously hyperthyroid picture. But this lady's heart rate is 68 and she feels lethargic. Heart rate may not be very good indicator in the elderly, and she doesn't have this hyperthyroid picture which is seen in the biochemistry. So this condition, especially this happens in elderly, you think it is hypothyroidism, but to see that it's hyperthyroidism in bloods. This we call apathetic hyperthyroidism, biochemically hyperthyroid, but clinically that feature, the features do not manifest properly. So treatment is treat the biochemistry, treat hyperthyroidism. So case number 3, 40-year-old female evaluated for abdominal pain. Actually, this is a real case. Examination revealed a long-term goiter, stable, and during routine evaluation, noted following thyroid function tests. On day 0, this is actually during an admission actually. Day 0, it was normal. Day 6, the T4 level has gone markedly up. But the patient was walking around and talking and no features of hyperthyroidism at all. So what happened during this admission? Do we have to treat this? She was evaluated for abdominal pain and this patient had a CT scan. CT contrast contains iodine. This iodine can go to this long-standing goiter and stimulate to produce thyroxine. Similar thing happens in the amiodarone-induced thyrotoxicosis. So similarly, if these results are discordant, just think, look at the clinical picture. Okay. Next, 35-year-old female, 6 months history of tiredness, heart rate is 60, no goiter, and to see that the thyroid function test, TSH is more than 100. TSH is way, way high. Maybe it's hypothyroidism. But to see that T4 is also high. Is it a TSHoma? Usually TSHomas don't produce this much of very high TSH levels. And you can see anti-TP antibodies are positive. So she has some autoimmunity. Is it non-thyroid illness? Obviously, I told, but TSH of more than 100 is very less likely non-thyroid illness. Is it an assay interference? False TSH level or false T4 level? TSHoma or thyroid hormone resistance. With a TSH of more than 100, it's quite less likely the last two possibilities. But anyway, we'll go according to this plan. She doesn't have any non-thyroid illness. Is it an assay interference? So we plan to do these tests, the same blood sample in different assays. So when we do in different assays, assay 1 and 2 gives a low T4 level, whereas the initial one produces high T4. So with these assay 1 and 2, you can predict, okay, this is hypothyroidism. And this shows normal. So different assays act differently. And these are immunological assays where antibody play a role in giving the results. So two-step T4 assays are always better than one-step assays. And if you have these discordant results where you can't interpret, you always need to exclude assay interferences. And equilibrium dialysis is one of the best methods. You can ask the biochem department to do the tests for you. And this is T4 assay interference. This happens in autoimmune antibodies and rheumatoid arthritis. Even heparin causes this kind of assay interference. Similarly, this patient is diagnosed with hypothyroidism on treatment and TSH is repeatedly high, but T4 is normal. The compliance we have evaluated, it's normal and has autoimmunity also. Is it poor compliance? We said it's not poor compliance. And is it assay interference? We ran tests again, and then in assay 1, we gave the same results, but second assay, it was given as normal. So she actually quite suppressed because on at 250 mics daily thyroxine. So this came as, this is the assay, wrong assay for TSH. So this is a TSH assay interference. 2 more cases. So this is 20 diagnosed with hypothyroidism for 3 years and on thyroxine again high dose compared to his body weight and still having persistently high TSH over the years. So what can we do? We try to adjust the compliance. We tell how to take and storage and brands and everything. Then is it an assay interference? Then you need to exclude the assay interference, talk to the biochem lab. And then we need to exclude malabsorption. For this, if there are no obvious symptoms, the endocrinologists do something called a T4 absorption test, a specialized test under supervision. And then we can see whether there is any T4 malabsorption. You exclude increased metabolism by the liver or any other drugs, and then address compliance. For this, we sometimes for compliance, we sometimes give weekly T4 thyroxine under supervision, under direct supervision for suitable patients. And 26-year-old female found to have abnormal TFTs on routine medical screening and no illness, no drug therapy, and heart rate is 64. There's a small goiter. And assay interference has been excluded. TSH is marginally high and T4 is high. I told TSH is not suppressed by free T4. So there's something up secreting TSH. So we have to exclude, is there a tumor in the pituitary causing TSH secretion resulting in high T4 levels and TSH not being suppressed or responsive to high T4 level. So how do we evaluate? We do alpha subunit and MRI pituitary to find the tumor, and the differential diagnosis is if the receptor of the thyroid hormone is not responsive for T4, then there is no feedback mechanism, then TSH can be high. That is called thyroid hormone resistance. It's a rare genetic syndrome, and family screening and gene analysis can be done. Okay, last case, 18-year-old female on treatment for Graves' disease. So TSH, to start with, it's low. Second visit, we do TSH, it's low. Third visit, it's slightly improved, it's low. So in the clinic, we have given 40 milligrams of carbimazole, and as the TSH is still suppressed, we increase to 45. And then here also, as it is still low, we continue 45. Are we doing correct? Next time, when the patient comes, the TSH is 20C. Have we missed something? So T4, if you do T4, then in hyperthyroidism, you will understand what is happening. So in 65 comes down to 20. And here, you need to adjust the doses. You need to reduce this dose. And then in C3, patient is severely like going into hypothyroidism. You can predict this. So you may reduce the dose further here, and this high TSH can be avoided. Okay, to summarize, how do we avoid these traps of TFTs? We need pre-laboratory, we need to figure out the clinical condition and pay attention, age, pregnancy, thyroxine therapy, other medications, and non-thyroid illness. During the laboratory, always we need to think of, say, interference if the thyroid functions are not very explainable, not by the clinical scenario, and also it's repeatedly coming very high or abnormal. And post-laboratory, we need to think of if all the assay interference and clinical conditions are excluded, Remember, there are certain very rare but important conditions like TSHomas, resistance to thyroid hormone, and I haven't put some conditions as well, dysalbuminemic conditions and genetic disorders, which we need to diagnose, and timely referral is identification and timely referral is encouraged. Thank you.
Thank you, Sonali. So we'll move on to the second speech, which would be done by Dr. Nayananjali Karunasena, consultant endocrinologist from National Hospital, Kandy. So she is going to talk to us on subclinical thyroid disease. So Dr. Veronica Nayananjali Karunasena is consultant endocrinologist attached to National Hospital, Kandy. She obtained her basic qualifications MBBS from University of Colombo in 2005, Doctor of Medicine in 2012, again from University of Colombo. Then she obtained membership in Royal College of Physicians 2013 and obtained a specialty certificate in endocrinology and diabetes MRCP in 2015 and obtained another qualification in as a clinical densitometrist in 2019. And she has done multiple publications, many presentations in many fora. And over to you, Nayananjali. Thank you.
Thank you very much for those kind words of introduction, and good morning, everyone. So I think my task was made quite easy by Sonali because I think she talked a lot about the subclinical thyroid disease as well. So I can mainly focus on to answer the question whether to treat or not to treat subclinical and debated the area, because it's not clear whether you should treat this entity or not. So what is the definition of subclinical thyroid disease? So the definition itself says it is abnormal serum TSH level, which could be either high or low, with a T4 or T3 level, free T4 or T3 level within their respective reference range. And the important point here is subclinical thyroid disease is a biochemical definition or a biochemical diagnosis. It is not a clinical diagnosis because obviously the patients would not have clinical features of hypo or hyperthyroidism. So why does this happen? So I think you already went through this, the hypothalamus-pituitary axis in your body. The thyroxine production is under the control by the pituitary and hypothalamus, driven by the TRH and TSH. And there is a negative feedback inhibition of thyroxine on pituitary, TSH and TRH when there is high T4 and T3 level. So, but why this subclinical thyroid status or biochemical status of subclinical thyroid disease happens? Because it's mainly what you have to understand is the relationship between even though we talk about this negative feedback inhibition and the axis and all that, you have to realize that this relationship is actually what is known as a log linear relationship, is the relationship between the TSH and T4. That means when the T4 increases, it doesn't change the TSH just at the same level. So when there is a mild change in T4, which is either rise or a decrease of T4, it actually causes a much greater or much higher change in TSH. That's why you get this biochemical disease. So let's first look at the subclinical hyperthyroidism. Of course, that means the subnormal, that is suppressed TSH level with normal T4 and T3 level, which you often diagnose when with a report. So probably you may have done it most of the time. You probably have done this as a routine investigation. So what are the causes of subclinical hyperthyroidism? Just as the overt hyperthyroidism, common causes are the endogenous causes like multinodular goiters, toxic solitary nodules, Graves' disease, even early pregnancy, as Sonali explained earlier. And also, the thyroid hormone replacement is the commonest exogenous cause for subclinical hyperthyroidism. That is the overzealous treatment of hypothyroidism. So what is the prevalence of subclinical hyperthyroidism? In this study, which was done in USA, of course, it shows that out of the TSH suppressed to less than 0.4 and 0.7% had a TSH less than 0.1. And the same study also showed that just like overt hyperthyroidism and Graves' disease, as you all know, there is a twofold rise in prevalence of subclinical hyperthyroidism among the smokers. And also this study showed, as is shown in this graph, you can see when you advance in age, the prevalence of subclinical hyperthyroidism also increases. So having said that, talking about the prevalence, do we really have to treat this condition, subclinical hyperthyroidism? If we don't treat, what happens to it? So let's look at the natural history of the subclinical hyperthyroidism. So they have looked at the patients with subclinical hyperthyroidism and categorized them as non-nodular disease, that is multinodular goiter or toxic nodules, and the non-nodular disease, which is predominant Graves' disease and the diffuse goiters, and non-nodular disease, which is multinodular goiter and toxic nodules. And then they followed up them with treatment and without treatment. And as you can see here, the TSH reverted to normal in majority of the patients with non-nodular thyroid disease. That is probably there is no nodular goiter or anything, but if you look at the nodular disease, that the patients who had some sort of a nodule in their thyroid, TSH reverted only in 17% of the time. So again, from the same study, they have also analyzed whether the degree of TSH suppression has any effect on the normalization of TSH in the long term. So here you can see that if the TSH is less, here you press to less than 1, or whether the TSH is 0.1 to 0.4, both groups had the same percentage of normalization with the time. So the take home is that even though the subclinical hyperthyroidism actually can become normalized without treatment. So you don't have to treat the subclinical hyperthyroidism all the time. So you can probably observe some of these patients. So, still there are guidelines saying that you have to treat. So why do we have to treat? So why we are so worried about this subclinical disease? So the main reason is the physiological effects. Because of the elevated, even though it is not reflected in the biochemistry, there is slight elevation of T4 levels in these patients. So they have physiological effects mainly on bones as well as the heart. And there are others. So according to this study published in JCM 1993, they have shown that average heart rate of patients with subclinical hyperthyroidism was 84 beats per minute compared to 70 beats in control. So there was an increased heart rate, and apart from that, there was increased atrial incidence of atrial extrasystoles in those who had subclinical hyperthyroidism. And the same study, they showed that there was no increased risk in ventricular extrasystoles in the subclinical hyperthyroidism. Also, the same study, they have looked at the cardiac the cardiac thickness and all that to look at the structural changes, and found that there is increased LV mass index as well as the intraventricular septal thickness and posterior wall thickness in patients with subclinical hyperthyroidism. But the good thing was that these effects could be prevented by use of beta blockers. And again, from this before, they looked at the risk or the prevalence of atrial fibrillation in patients with subclinical hyperthyroidism. Not only subclinical, they have looked at the overt hyperthyroidism as well, which is seen here in the straight line, the dark line. But again, you can see that there is marked increased risk of developing atrial fibrillation with overt hyperthyroidism, but also here you can see that the subclinical hyperthyroidism was also associated with increased risk of atrial fibrillation. And again, in this study, they evaluated the risk of atrial fibrillation in hospitalized patients and found that only 2.3% among the euthyroid patients, only 2.3% had atrial fibrillation. And those who are subclinical hyperthyroidism, the atrial fibrillation rate was about 12.7%. And you can see it was almost closer or equal to the overt hyperthyroid patients. So that means that the risk of atrial fibrillation is almost same as in patients with overt hyperthyroidism. So this is probably the most important cardiac effect of the subclinical hyperthyroidism, that is the development of atrial fibrillation. And apart from that, there is potential risk of exacerbation of congestive heart failure and ischemic heart disease as well, but these are not well studied and not good enough evidence. So let's move on to the effect on bone in cycle, where there is the bone undergoes continuous bone remodeling, that is the balance between the bone formation and the bone resorption. So in patients with subclinical hyperthyroidism or even hyperthyroidism, due to the changes in T4, T3, there is increased bone resorption, or there is shortening of the bone remodeling cycle, which lead to the reduced bone mineral density and osteoporosis. And apart from that, there are various other changes. That is because of the increased bone resorption, there is increased calcium mobilization from the skeletal. And then the increased calcium lead to suppressed PTH, and suppressed PTH lead to the increased urine calcium excretion and gut calcium excretion. So the subclinical hyperthyroidism has a significant effect on the bone as well by increasing density and increasing the osteoporosis risk. So this could be a particularly a problem among the postmenopausal women if they are not on estrogen and or bisphosphonates. So how can this be prevented? So how can these adverse effects on the bone and heart can be prevented in these patients? So one way is, of course, as I mentioned earlier, the cardiac effects can be prevented by using beta blockers, and skeletal effects can be prevented by the use of estrogen and bisphosphonate, of course, based on the suitability, whether there is osteoporosis on premature menopause, etc. So let's look at the guideline. So there is a dilemma whether to treat the subclinical hyperthyroidism or not. So what does the guideline say? I think, what they suggest is the patients has to be categorized based on the TSH, age, and presence and absence of other comorbidities. So if you look at the patients with TSH less than 0.1, that is more suppressed than the other group, what they suggest is if the age is more than 65, or you can treat always with antithyroid medication. But if the age is less than 65 years, and there are other comorbidities, like the ones that I spoke to you about a few minutes ago, that the heart diseases, osteoporosis, and menopausal, not only estrogen or bisphosphonate, and also presence of hyperthyroid symptom. In that set of patients, you can treat with antithyroid medications. I'm not going to go into details about the antithyroid medication, predominantly carbimazole. So those who are with the TSH less than 0.1, but the age is less than 65 and no symptoms and no comorbidities, then probably you don't have to treat this group of patients. You can just observe or consider treating if you really think that the patient is going to benefit. That is an individualized decision there. So those who have a TSH just marginally suppressed, that is a TSH between 0.1 to 0.4, that is considering the 0.4 is the lower limit of the normal reference range. You can see that again, age, even though the same clinical scenario with TSH less than 0.1, where I told that you can treat, if the TSH is 0.1 to 0.4, you don't have to always treat. You can consider treat, but you can also observe and follow up with the repeat TSH and TSH. So if the TSH is between 0.1 to 0.4, if the age is less than 65 years and asymptomatic, then you can just monitor the thyroid functions, because as I said earlier, these patients are more likely, or they can revert back to normal with time, even without any treatment. Okay, let's move on to subclinical hypothyroidism. Again, it's the same biochemical definition, that is elevated serum TSH with a normal T4 and free T4 and T3 level. So again, the causes are, I think you heard earlier also. So it can be most commonly the Hashimoto's thyroiditis, or it can be any thyroiditis in the recovering phase, or it can be following the ablative therapy for hyperthyroidism, or following surgery. And again, one of the common cause, because this is a biochemical diagnosis. So what they say is, so the inadequate replacement therapy in patients with hypothyroidism, in this particular study, 37% of patients were under-replaced in hypothyroid patients. So inadequate replacement therapy in clinical hypothyroidism. It is again a common in women. You can see it is quite common, 7.5 to 8.5 when compared to men. But this prevalence can increase up to 15% when they are over 60 years. So what happens to the happens to this subclinical hypothyroidism if we don't treat? So in this particular study, what they did was 82 patients with subclinical hypothyroidism were followed for within a period of 20 years. And they showed that only 28% of them became overtly hypothyroid in the next 10 years. But having said that, you have to focus attention that the overt hypothyroid definition was TSH more than 20 with a low T4. This is a bit higher than the current guideline where we take if the TSH is more than 10 as overt hypothyroidism. And again, they categorize these patients or stage them as stage 1, 2, 3 based on their TSH 6, that is just above the normal. None of these patients revert back, none of these patients convert into overt hypothyroidism even within the next 10 years. So obviously, you don't have to treat those patients. So, but if you look at this 6 to 10 and more than 12, the development of overt hypothyroidism rate was quite high. So, so we have to look at, have to keep these numbers in mind. So those who had the TSH 4 to 6, nobody actually became overtly hypothyroid. Okay, according to the same study, they showed that the degree of TSH elevation was a predictive value, had a predictive value on the conversion of to overt hypothyroidism or reverting back to normal. And the other factors that were associated were the degree of thyroid reserve and the presence of anti-TPO antibody. Those who had the anti-TPO antibodies, of course, had more risk of developing into or going into overt hypothyroidism with time. So again, we come to the question whether this subclinical hypothyroidism needed to be treated or not. So this is, I think, it's still a controversial point, and it's still debated. So we'll just look at some of the evidence. This, I'm sorry about this, not a very good slide, but this study gave a treated hypothyroid, subclinical hypothyroid patient with thyroxine, and look at the 4 parameters, that is the quality of life improvement, thyroid-related symptom improvement, fatigue and tiredness, and depressive symptoms, which are known to be the associated features with subclinical hypothyroidism. And according to this progress plot, you can see that none of this actually improved with the treatment of hypothyroidism. So is there really a point in treating this subclinical hypothyroidism? Because most of the time we see in our clinical practice, we do this test and find or diagnose the subclinical hypothyroidism because they come with this sort of symptom, which is related, probably we think, which is related to hypothyroidism. But according to these studies, you can see that they really don't improve even with the symptoms. And but having said that, what happens to the cardiovascular system, or what are the cardiac effects of the subclinical hypothyroidism? Just like the subclinical hyper, this subclinical hypothyroidism also has some cardiac effects. So it has been shown that this is associated with arterial wall thickening and stiffening and endothelial dysfunction, which means there is increased cardiovascular risk among this patient. And this study, which was done in Taiwan, they have showed that The all-cause mortality and cardiovascular mortality was high among the patients with subclinical hypothyroidism when compared to the control study group. And also this meta-analysis congestive heart failure in those patients with subclinical hypothyroidism, and the risk also increased with the degree of TSH elevation. So there is plenty of evidence to say that subclinical hypothyroidism is can affect your cardiovascular system and increase the cardiovascular mortality. So there is a mortality benefit. So shouldn't we treat? And does this apply to all the patients? Probably not all age groups. It is the benefit is there, but not in all age groups. Why? Because in elderly patients, that is between 85 to 89, according to this study, the elevated TSH is actually associated with lower mortality rate. I think Sonali also mentioned with the age, you can, the slightly high TSH is actually beneficial. They showed that the elevated elderly, elevated TSH was associated with better mobility and improved cardiorespiratory fitness as compared to normal TSH levels. And also, there are studies to show that the treatment of subclinical hypothyroidism actually increased the mortality in the elderly. One of the reasons is because when we overtreat, we make them thyrotoxic sometimes, and there is increased risk of developing atrial fibrillation. And so there is increased risk of mortality or increased mortality in elderly patients when you treat subclinical hypothyroidism. So to summarize, there is increased cardiovascular mortality in non-elderly patients when the TSH is above 7, and there is reduced mortality and improved fitness in elderly patients with elevated TSH. So in elderly, the elevator slightly above patient, but in younger groups, it might increase their cardiovascular mortality. So how do we treat, or do we treat or not treat? So this is from the European thyroid. I think this is again, most of the guidelines are not really telling whether you should treat or not. This is from the European Thyroid Association guideline in 2013. So what they say is, so they categorize the group, the patients according to the age. That is, if the age is less than 70, and serum TSH is more than 10, you can of course treat with the thyroxine. Age is less than 70 and TSH less than 10, that means the subclinical hypothyroid group. If the thyroid hypothyroid symptoms are there, you can give a trial of thyroxine and then assess the response to the treatment. And if there is no response, then you prop off patients. And if no symptom, of course, you don't have to treat, and you can just observe them in every 3 to 6 months. But in elderly patients, more than 70, when the TSH is less than 10, you are going to observe and you're not going to treat. And even when the TSH is more than 10, what they suggest is consider thyroxine if clear symptoms of hypothyroidism or high cardiovascular risk is there. So in elderly patients, more than 70 patients, even when the TSH is more than 10, and if the T4 is normal, then you have to consider whether look at the patient and see whether it is really going to be beneficial for the patient or not, and take a decision whether to treat or not. So I think here I have not touched on the pregnancy and subclinical hypothyroidism and fertility and those things. I think that is a different entity which takes much longer time. But you have to keep in mind those who are in the reproductive age and fertility issues, you have to treat the subclinical hypothyroidism. And of course, they are younger, you come under the younger category, so you can still treat. Biochemical diagnosis and treating or not treating mainly depend on the cardiometabolic risk factors and the age of the patient. And when it comes to subclinical hypothyroidism, elderly patients, you might not treat or better left untreated. In a young population, subclinical hypothyroidism has a mortality benefit. Thank you. I would like to answer if there are any questions.
Thank you, Dr. Anjali. I think more question for the end of the symposium. The third lecture on treatment of thyroid says, so Dr. Senaka Kandagidra will talk to us on this topic. So Dr. Senaka Kandagidra, consultant endocrinologist, National Hospital, Kandy, 1998, postgraduate of G, University of Colombo, 2008, overseas training, 2011 to of Cancer Center, Glasgow, and under clinical fellow. Experience in clinical oncology as about 16 years by now.
Thank you very much for your kind words, Dr. Anurudha. Good morning, everybody. First of all, I would like to thank the President and KSM to give me this valuable opportunity to address you. My task today is to briefly go ahead with treatment of differentiated thyroid cancers and get some points where we can avoid over-treatment. So the differentiated thyroid cancers has become one of the most frequently diagnosed malignancies, especially among women and young adults. The outcome are generally very good. Disease recurrence rates are low. Survival rates are excellent. So according to 2019, the latest data available in Sri Lanka, the incidence in females, the thyroid cancer comes to second place. First is the breast and second is the thyroid. And in age group of 15 to 34 years of female, the thyroid cancer is the top in the list. It's around 49.5%. So you can see how common this thyroid cancer is. So just outline the malignancies thyroid. Differentiated thyroid cancers top in the list. Then the medullary carcinoma and aplastic carcinoma. And the lymphoma, sarcoma, melanomas are very rare. Secondary causes again very rare. Differentiated thyroid cancers is derived from follicular epithelial cells. It accounts for over 90% of all thyroid malignancies. DTC can be subdivided in papillary thyroid cancers, which account for 85 to 90%, and the follicular thyroid cancer, which account 5 to 10%. Hurther cell or the oncocytic variety, which is again a subtype of follicular thyroid carcinoma, is a rare subtype which account 2 to 5%. Some of the risk factors, it is increase in age and the female gender, exposure to ionized radiation, especially the neck irradiation during childhood, the family history of and the personal history of thyroid adenomas, endemic goiter, and it associates with certain syndromes like Cowden, Gardner, and Turcot's, and it has an association with familial adenomatous polyposis as well. Genetic and environmental factors are being increasingly recognized. So the diagnosis, the ultrasound scan of the neck is the mainstay, followed by the fine needle aspiration of cytology. Follicular and Hurther cell carcinoma, they are rarely diagnosed by fine needle aspiration because their diagnostic criteria, requires vascular invasion. But a suspected follicular carcinoma, the suspected follicular carcinoma, if you can offer the 7-gene molecular panel, you can safely categorize whether it is more likely to be the follicular carcinoma or not. So what they say is, together with fine needle aspiration cytology, the diagnostic sensitivity for FTC is around 60 to 80% and specificity more than 90%. So if you can offer the 7-gene molecular panel for the suspected follicular adenoma, you can safely avoid the unnecessary interventions. A preoperative risk stratification avoids overtreatment in differentiated thyroid cancers. So predicts the response to the initial treatment, and this categorizes the patient at the time of diagnosis into the 3 risk groups. Basically, the low intermediate, and high risk. This low, intermediate, and high risk category based on the TNM classification and the WHO classification based on the histological appearance of the FNAC and resected tumor, and as well as the molecular biological parameters. So the TNM classification, the WHO classification for resected differentiated thyroid cancer with morphological parameters and molecular markers. So there in the WHO classification, this non-invasive encapsulated follicular variant is a novelty. Based on clinical evidence of their low-grade behavior during long-term follow-up, this encapsulated non-invasive follicular thyroid neoplasms with papillary-like nuclear features are, as I told you, this new entity. So it accounts for about 15% of cases in Europe. It eliminated the term carcinoma from the definition of this PTC variant, which underscore its excellent prognosis. So this NIFTP is associated with minimal cancer-related deaths and an estimated risk of recurrence. RS mutation characterized in this category, and correct identification of this group should reduce the unnecessary use of radical surgical procedures and the needless administration of radioactive iodine after completion of thyroidectomy. So identification of this category, we can, by identification, we can reduce the unnecessary interventions. So as I told you earlier, the risk stratification mainly we divide into low risk, intermediate risk, and high risk category. The low risk category, it estimated risk of recurrence rate is less than 6%. So the NIFTP come into the top in the list. And papillary thyroid carcinoma, by definition, if these features are there, they will fall into the low risk category. And follicular thyroid carcinoma, if these features is there, it will fall into the low risk category. So this risk stratification is very important in view of correct management of differentiated thyroid cancer. So the intermediate risk group, estimated risk of recurrence is 6 to 20%. By definition, if one of these following are there in the papillary thyroid carcinoma, they will fall into the intermediate risk group, and this things are there in the follicular thyroid carcinoma that will fall into the intermediate risk group. So the high risk group, estimated risk of recurrence is more than 20%. By definition, in papillary thyroid carcinoma, if these features are there, they will fall into the high risk category. Follicular carcinoma, if these features are there, they will fall into the high risk category. So this categorization is very, very important in view of definitive treatment. So what are the management options that we can offer for the differentiated thyroid cancer according to the above risk categorization? Active surveillance, which is a little bit uncommon in Sri Lanka. Surgery, either lobectomy or thyroidectomy. Radioactive iodine therapy. TSH suppression. Radiotherapy. And systemic therapy with kinase inhibitors. So the active surveillance, as I told you, in differentiated thyroid cancers, active surveillance now coming into the picture. Even though our practice is not that great, this is the category where we have to look forward. So what are the indications for the active surveillances? The microcarcinoma, which is size of the tumor is less than 1 centimeter. No radiation exposure in childhood or adolescence. No family history. Not posterior recurrent nerve or the esophagus or adjacent to the trachea. No aggressive features of cytology like tall cell, hobnail variant, columnar, squamous differentiation. unifocal tumor, no extrathyroid extension. The high-risk surgical candidate, relatively short life expectancy. Intrathyroidal well-differentiated follicular thyroid carcinoma with capsular invasion and minimal, which is less than 4 foci, or no vascular invasion. So if the differentiated thyroid cancer fall into this category, we can safely continue the active surveillance for this patient without unnecessary interventions. For the follow-up of this, the patient who are on active surveillance, the ultrasound scan neck is currently recommended every 6 months for the first 2 years and yearly afterward. The optimal timing for surgery in progressive cases are detected by the precise radiological tool, so the ultrasound neck. So what they say is the rescue surgery if size increases 3 millimeter annually. So with this ultrasound scan follow up, if the size of the tumor increases by 3 millimeter annually, those are the patients who are tend to go for the surgery or the thyroidectomy. And then the change in ultrasound appearance, if there's lymph node metastasis, and patients demand, again, those are the places where we offer the surgery. Just a few words about the surgical management. So primary tumor management will be determined by the results of the preoperative risk assessment, as we discussed earlier. Lobectomy alone is a possible alternative for the selected low-risk tumor with similar survival rate. Earlier, we know, for each and every patient who was diagnosed with the thyroid cancer, differentiated thyroid cancer, they indefinitely went ahead for the total thyroidectomy. But according to the risk categorization, some of the low-risk patients, we can offer the lobectomy. Again, the total thyroidectomy is still considered the standard surgical treatment for all other tumors. Total thyroidectomy, we know it carries risk of recurrent laryngeal nerve palsies and post-surgical hypothyroidism. The use of prophylactic central neck dissection, it varies with center to center, and the evidence of prophylactic central neck dissection is conflicting. So a few words about lobectomy. So if we can offer this lobectomy for the differentiated thyroid cancer patient, we can avoid the unnecessary side effects or the unnecessary problems which can arise by total thyroidectomy. So who are the patients which can offer the lobectomy? So the T1A lesion, that being less than 1 centimeter lesion, if it is posterior to the or adjacent to the trachea, we can't offer them the close follow-up. We have to go for the lobectomy. The tumors which are 1 to 4 centimeter or T1B or T2 tumors, if there's no radiation exposure in childhood, adolescent, no family history, no aggressive features of cytology, unifocal ones, and no extrathyroid extension in ultrasound scan. So those patients, we can offer the lobectomy safely. But with postoperative histopathology, sometimes these lobectomy patients might end up with total thyroidectomy. For example, if the tumor size is more than 4 centimeter, or on resection, nodal resection, or node positive, the patients, vascular invasion. So the following the lobectomy, with this finding with the histopathology, they might end up with total thyroidectomy. So radioactive therapy. Radioactive therapy again is the one of the common treatment option for the differentiated thyroid cancer, but not like in olden days. In olden days, most of the thyroid cancer patient, we offered the radioactive iodine. But now, according to this risk categorization, we offer the radioactive radioactive therapy only for the needed or the high risk or the intermediate risk patient. So as I told you, radioactive treatment with I-131 is not generally recommended after lobectomy. following the total thyroidectomy, radioactive iodine could be used for 3 different purposes. First thing is the remnant ablation. It will eliminate any thyroid tissue left behind following the surgery. So we can get a good idea about the serum thyroglobulin in view of persistent and recurrent disease. So we can use this I-131 treatment for adjuvant treatment as well, where we can eliminate the potential foci of thyroid cancer and destroy small volume microscopic lymph node metastasis. And again, we can use this I-131 treatment for the non-disease or the residual diseases. So RAI administration must be followed up with I-131 whole body scan to stage it and get the idea about the avidity. And the radioactive iodine normally we given following withdrawal of levothyroxine or the recombinant TSHA administration. And the important factor with regard to the I-131 treatment is now the amount of I-131 we can select according to the risk categorization. So the thyroid differentiation thyroid cancer following surgery, if there's no residual diseases with low risk category, and especially the T1A lesion for the less than 1 centimeter lesion, we can safely avoid radioactive iodine. Other low risk patient, we can offer low dose iodine. Earlier we have, nothing called this low dose iodine. Now, this low dose iodine is coming to the picture. So which says the low dose iodine compared to the high dose iodine for the low risk cancer patient, the effect is same. So normally, generally we use the 30 millicurie as the low dose iodine. The intermediate risk group patients, those are the microscopically involved, aggressive histology, vascular invasion, and extrathyroid extension. So that intermediate risk group, we can go for the 30 to 100 millicurie of the iodine treatment. So earlier, there's no 30 to 100. Straight away we went for the 100 millicurie or above. The high risk patient who are having the gross extrathyroid extension, positive margins and distant metastasis, we can offer the high dose iodine 100 millicurie or more than 100 millicurie. The residual disease patient, we can go for again higher doses of radioactive iodine with repeated doses. So this risk categorization again come into picture in view of radioactive iodine treatment, where you can select the low risk patient and where you can give the lesser doses of the I1 treatment. So as I told you, there is an introduction of RAI 30 millicurie for 100 millicurie, which reduce the unnecessary side effects of higher doses of I-131 treatment, like salivary lacrimal gland dysfunction, gonadal dysfunction, and rare secondary primary malignancies. And again, this low dose treatment can be given without prior hospitalization. For the higher doses of I-131 treatment, the patient need to be hospitalized. But for the lower doses, the patient can come in the morning, have the treatment, and evening they can go home. So dynamic risk stratification. This is come into action when you're talking about the TSH suppression. So this TSH suppression is again a gray area for our management. Still, the gut feeling is to go for the higher doses of thyroxine and maintain the maximum TSH suppression will give rise to the better disease control, but it is not like that. So what is this risk categorization? This initial risk assessment is revised during follow-up to reflect the evolution of the disease and response to the treatment. So the treatment response are defined as the excellent, biochemical incomplete, structural incomplete, indeterminate, based on imaging findings, mainly the neck ultrasound scan, serum thyroglobulin level, and anti-thyroglobulin antibody levels. So after the lobectomy, the risk is after the lobectomy, we can categorize the risk: excellent, indeterminate, biochemical incomplete, or the structural, depending on the thyroglobulin and anti-thyroglobulin antibodies and neck ultrasound scan. So identifying these, the risk stratification is very important in vivo TSH manipulation. So after the total thyroidectomy, plus or minus radioactive iodine treatment, again, it categorizes the risk: excellent, indeterminate, biochemical incomplete, structural incomplete, depending on the thyroglobulin, stimulated thyroglobulin, anti-thyroglobulin antibody, and neck ultrasound scan. So the patients who had an excellent response, the TSH goal is 0.5 to 2 milliunits per liter. The indeterminate response group, we can maintain the TSH 0.5 to 1 milliunits per liter. The biochemical incomplete response group, we can maintain the TSH group 0.5 to 1 milliunits per liter. The structural incomplete response group, you have to maintain the TSH level below 1 milliunits per liter. So, I mean, basically, still, what the practice is for each and every patient diagnosed differentiated thyroid cancer. Following initial treatment, we have to keep this TSH level below 0.1. So that is still we are practicing, and I mean when you are going through the patient, still we can see, but it is not like that. So depending on this dynamic risk stratification, we can achieve the TSH goal, and we can reduce or we can cut down the unnecessary usage of the levothyroxine. So the oversuppression of TSH by prescribing higher doses of levothyroxine would carry symptoms of frank hypothyroidism and manifest cardiac arrhythmias and bone mineralization, osteopenia, etc. So those things can be safely reduced for some of the low-risk patients by giving low doses of levothyroxine and maintain the TSH described as above. So just a few words about the radiotherapy. So the radiotherapy, again, in the good olden days, for each and every patient of the thyroid cancer who are having intermediate risk or high risk, we offered the radiotherapy. But I mean, now it is not like that. We use the radiotherapy very rarely. So the main recommendations are the patient with gross residual or unresectable local regional disease, and the EBRT should not be routinely used as adjuvant therapy after complete resection of gross disease. After complete resection, the radiotherapy may be considered in selected patients more than 45-year-old with high likelihood of microscopic residual disease and low likelihood of responding to the radioactive iodine. Cervical lymph node involvement alone should not be an indicator for adjuvant EBRT. So earlier, I mean, not even earlier, the current days also, if the cervical lymph node positive for the differentiated thyroid cancer, some of the institute, they use the EBRT, the radiotherapy, which they say there's no obvious effect on disease recurrence or disease-free survival. So the intensity modulated radiotherapy is the preferred technique of EBRT delivery, as it relies on 3D technology to precise delivery radiation beams to the clinical target while sparing surrounding structures. Just a few words about metastatic disease as well. So the distant metastasis occur in fewer than 10% of patients with DTC. are present when the tumor first discovered. Metastases are observed most frequent in patients with aggressive histology type, the vascular invasion, large primary tumors, macroscopic extrathyroid extension, likewise. So this metastatic differentiated thyroid cancer, again, the radioactive iodine has a good place, and RAI or the radioactive iodine can be administered every 6 months for about 2 years, and then less frequently. Imaging is recommended to assess the response for the treatment. And for the local regional therapies, for the bone mets, you can offer the surgery, again, radiotherapy, biphosphonate. For the lung mets, you can offer the metastasiectomy, the radiofrequency ablation. The liver mets, you can offer surgery, ARFA, or the test treatment. Just a few words about systemic therapy. Systemic therapy considered after surgical and radiation and radioactive iodine options have been exposed. So if there's a place for the surgical intervention or the radiation or radioactive iodine, so those type of patient, there's no place for systemic therapy. Chemotherapy, earlier we used the doxorubicin, now there's actually no place for, still we are using for the chemotherapy for some of the patients, but according to the newer guideline, there's no place for, the chemotherapy. The kinase inhibitors like lavatinib and sorafenib are currently approved for the metastatic or the systemic treatment for the DTC. So it carries disease-free survival around 18 months. There are some other agents under investigation, and the systemic therapy is not recommended for patients with increasing serum thyroglobulin levels in the absence of radiological evidence disease. This just again, this is the systemic presentation of the same thing. So the summary: avoiding over-treatment of DTC. Evidence-based management is crucial to avoid over-treatment of DTC. 7-gene analysis with FNAC for Bethesda-3 for enable identification of follicular thyroid carcinoma with high specificity without active surgical interventions. Active surveillance is recommended for micro-invasive thyroid carcinoma and NIFTP category over surgical management. Lobectomy alone is a possible alternative for selected low-risk tumor with similar survival after total thyroidectomy. RAI or radioactive iodine is not indicated for all DTC, and low doses can be given for low-risk patients with less toxicity. TSH suppression need to be adjusted according to the risk stratification. Radiotherapy is given to the selected high-risk patient only. No obvious place for chemotherapy. And kinase inhibitors is indicated only for macroscopic metastatic disease and for the radioactive iodine refractory disease. So there's no place for prophylactic treatment in before the TKIs. So some practical issues may be in common for Sri Lanka setup. Poor compliance and poor understanding of the disease in our patient is a barrier for active surveillance of low-risk disease. Practical issues that are arising during regular follow-up on the serial ultrasound scan, thyroglobulin assay, monitoring TSH, whether we can do it, the time that is required. Lack of genetic molecular investigation, like 7-gene analysis, it is difficult for us to do. So, those pitfalls are there when the management of the differentiated thyroid cancers in Sri Lankan setup. Thank you very much.
Thank you, Seneka. So with that, we have finished all three speeches. Now the session is open for questions. Do you have questions from the audience? All three speakers are here seated in the front.
May I ask one question from Dr. Nananchal? This is regarding subclinical hyperthyroidism. You mentioned that there is significant risk of atrial fibrillation, polyparoxysmal. Is there a guideline emphasizing on considering test or 7-day halt track atrial fibrillation?
The guidelines on actually the endocrine guidelines of thyroid disease, I think they don't talk about the halt monitoring and all those to diagnose. It's just, I just wanted to highlight the risk of atrial fibrillation. So because of the risk of atrial fibrillation only, they have categorized these age groups and suggested treatment. Other than that, they don't recommend actively surveilling for the atrial fibrillation by halt monitoring or things like that.
Thank you.
I think we are on the dot. Yeah, one more question. Okay.
One question from Dr. Sonali. You mentioned about this interpretation pitfalls. Is it a very common occurring in clinical practice? Do you commonly see false reports?
Actually, no, we don't commonly see. Commonly, the TFTs are pretty straightforward, but the abnormal ones that are rarely seen or less commonly seen are quite important. So we can't afford to misdiagnose because we may be missing an important diagnosis which we have treatment for and we can help the patient in. So it's not so common, but if you get a abnormal report, just think again and we have to analyze it more.
We are on time. We need to finish the session now. Right. So thank you very much, all three speakers, Dr. Sonali Gunatilaka, Dr. Nananjali Karunasen, and Dr. Senika Kandegedara for your wonderful speeches. And I would like to ask my co-chair, Dr. Anuruddha Arivansa, to distribute the certificates for them. Token. Dr. Sonali Gunatilaka. Dr. Nananjali Karunasen. And Dr. Senika Kandegedara.
Thank you, sir. I would like to invite Dr. Harit Vimalratna to hand over the tokens of appreciation to our two chairpersons. Dr. Samal Nanaikara and Dr. Anuruddha Arivansa. Thank you. We are now moving on to the fourth plenary lecture of the sessions. I would like to invite the two chairpersons of this session, Professor Roshan Pires and Professor Chandrika Jaisingha.
Morning, ladies and gentlemen. Our next speaker is Dr. Sanjeev Boatta. He's a consultant physician by profession, and he is the head of the Department of Medicine at the Wayamba Medical Faculty, Department of Medicine.
and he's the present Dean of the Wimber Medical Faculty and also at present the acting Vice Chancellor of the Wimber University. His topic is something different from our usual topics. He is going to tell us about how the evolutionary story of mortal human. Without taking much of his time, I would like to invite Dr. Sanjeev Bowatta to present his presentation.
Thank you very much. A very good morning to all of you. I'm really glad to speak in front of my supervisors and teachers and some of my colleagues. Thank you very much. This is, as Madam correctly told, this is something different from usual medical topics that we discuss in this type of forums. This is my childhood hobby. I have been reading and collecting items related to human evolution for a long time. It goes back to 1980s. So now I have come to a certain level where I feel I am in a situation to disseminate some of the knowledge that I have. It is really interesting, as well as in today's medical world, there are some inputs or insights are coming in, which are most likely will be useful in the coming number of years. Without taking time, I'll proceed. So we all know Charles Darwin and the very famous, I think, page from his collections. He did the literary work 160 years ago, 1959, even before any fossil of any of the human ancestors were noted. It's remarkable and amazing how he, as a scientist, identified the evolutionary passage. And we are all aware of this notion. I'll take you to a different stage. Now, just a question. How did one animal species out of all the number of animals of different phyla came to this level of advancement? Now, we are now going into the outer space. We have a smartphone in our pocket. Like that, we are amazing stage of evolution, development after all these millions of years. Let us see how this happened. And at the same time, to appreciate that the next king, closest relative is chimpanzee, far behind us. And a chimpanzee with Jane Goodall, the activist who's preserving chimpanzees in Africa. And also to tell you that humans are now living in all continents, and in fact, usually none of the other animals are living in all continents. There are a few maybe, but not to a success to our level. And recently, this is coming from Worldometer. We are reaching 8 billion, and of course, it's an amazing number. I do not know how we are going to cope up with it as well. I have been given 30 minutes. It's a really a challenge to talk about. So I'll be going on these lines to tell you something about how things happen. Actually a difficult task. We have months or weeks worth of knowledge. How everything began, you must be a little aware about Big Bang. Something took place 13.6 million years ago, or billion years rather, sorry, or 13,600 million years. That's a long time actually. And that was initially, it was a hydrogen and helium collection which expanded, and it is expanding as the geologists say. Stars are born and go up and die. All stars are born from the material came from the Big Bang, and they, there you can occasionally hear nebulas. Then they go into a red giant. Then they slowly disappear over millions of years, billions of years. White dwarfs, black holes are remaining. So the stars are born, they break into pieces, and the star dust is collected. And the star dust look after everything. We are everything that we have, or rather 90% of our mass comes from the elements created in stars under massive, immense temperatures. So we are all materials, all plants, everything. The majority comes from stars over billions of years. And just a breakdown of the makeup of a human being. Oxygen, carbon, hydrogen, nitrogen predominate, as you're aware. So that is how everything started. So stardust is the beginning of all materials, all life on Earth and all other galaxies and solar systems. Our Earth is about 4.6 billion years ago, billion years old, or 4,600 million years. That's a massive cloud of dust initially condensed into planets, and now we are fortunate to be born in a planet which is correctly positioned in the correct time distance from the sun, and there is other requirements. And tell you one important requirement: the water appeared on the Earth about 4 billion years earlier. On the other hand, immediately after the Earth was born, water is there. How the water came in? There are two theories. One hypothesis is that this is coming from extraplanetary sources like asteroids and all. Very recently, a Japanese satellite landed on an asteroid, took a sample and found that there is water in that asteroid. So that theory is also holding. The other one is geochemical synthesis took place in this immense heat initially, could as a side effect, there water was generated, was another theory. Anyway, we have water, and the water allowed for the initial life in the puddles of water, different chemicals, different temperatures, lightning, and many other activities are supposed to have generated the first life on Earth, and that life then slowly progressed. And the first living organisms are supposed to be cyanobacteria, anaerobic bacteria, and these are the solidified forms of these bacteria. Stromatolites apparently are found in somewhere in Australia, coastal areas, and they are some of these cyanobacteria, and they are also found in the deep seas. These are also supposed to be cyanobacteria from all those initial life creation. And that initial ancestor is our ancestor as well. And thereafter, bacteria, the different life forms evolve, and eukaryota, and we are somewhere under animals. So all of us have a common ancestor of a bacterial origin as well, 4 billion, rather 3.5 billion years old. Thereafter, about 500 million years earlier, about 500 million. Now this is about 4 billion years later from the beginning of Earth, much later from the beginning of Earth. We see the first fauna. Initially, they are a very famous group of like insects. They are called trilobites, and then initial early fish, all were the initial very notable life forms on Earth. What happened to them, I'll tell you in a few minutes' time. Then about 250 million years earlier, the well-known dinosaurs roamed the Earth, and there were many dinosaur forms. In this initial phase, I am going a little quicker because I am coming to the most important part of human material in a minute. So there were hundreds of thousands of dinosaur species roamed during this period. You know, the Jurassic World, Jurassic Park, all these are coming from the stories, scientific evidence. And then, of course, about 150 million years earlier, the first birds have appeared, Oronyx, some of you may remember. Sometime earlier, we thought Archaeopteryx is the first bird, but it is now being identified as a separate one. This science is also evolving all the time. New information is coming in. So sometime later, what I talk to you here might be redundant as well. Then an significant event took place. There's enough evidence, research evidence and geographical evidence that a meteorite struck the Earth, large meteorite struck the Earth somewhere in Middle America, the Yucatan province, this place, and it is something like 8 or 9 kilometer radius, and that has created a massive impact on the Earth, and that impact has covered the Earth by the dust and other the soot particles covered the entire globe apparently for hundreds of years, and that has wiped out most of the larger plants, so that the dinosaurs had no option, but they have disappeared. That's the event. There is there are a lot of evidence. My idea today is not to give everything, but I'll give one evidence. At all over the globe, if geologists study the 65 million year old strata, there is a iridium-rich layer all over. It has been very well observed. And this iridium comes from this impact. And it is not iridium, apparently, has not been there in the globe at that time, and that asteroid has brought iridium. So there are evidence. Now, these might otherwise appear as fancy stories, but it is actually, there is hard, very heavy evidence. And this 65 million year old Chicxulub event has given rise to a mass extinction. And in the geological time scale, that happened to be the fifth mass extinct. And this took place in this Cretaceous period, 65 million years ago. But there have been four mass extinctions, again, from the geological evidence. So the one of them has totally cleared the trilobites I told you. These are like some cockroaches, the size of about one plate. And just imagine cockroaches of one plate size walking around under the chairs and all would not be really happy for us to live today. So there were 5 mass extinctions, and the last mass extinction has given opportunity for small mammals. In fact, we are here today thanks to the asteroid impact in Chicxulub. So those are the geological events. So small mammals started apparently in this dark period. Small mammals, 10 kilogram, 15 kilogram mammals could survive apparently eating the necrotic, whatever the tissues, and they have slowly established on the globe. With that came the other different mammals, but at the same time, our primates could hold onto the globe around 50 million years ago. So the monkeys and lemurs and then the apes all slowly established, and apparently most of these took place in Africa and some of them Asia, but very few in American continents. Why these things are happening, of course, geology, the surface of the globe was not the continents that we see today. There was Pangea, Gondwana, different things. About 95 million years Chicxulub event, the globe was complete with the geography that we see today. So that the geography is going separate line and details. Monkey and the ape, the difference are their brain to body size is actually in advantages for a bigger brain. They don't have a tail, and they have the grasping hand with the opposing thumb. There are some of these features identify the monkeys and apes separately. Happening, the apes or the ancestors of apes living in Africa faced a significant change. East Africa went into a drought. The forests disappeared and savannas appeared. So that forced the apes or ancestors of humans to climb down from trees. This is one of the first and very important events that took place, which made way for us today. We call it terrestrialism. In evolutionary talks, terrestrialism. They had to come to the ground from their tree-dwelling life pattern of life. So it became terrestrial. In fact, even now, today's apes also, they can slow for a brief period with some difficulties. They can walk, but not the best. So that is the beginning. And with that, we identify the first ancestor. These are tongue-twisting names. It's Sahelanthropus jadensis. Sorry for the tongue-twisting names. I have one sample. The entire globe has only one of them. This is a resin 3D printing. And this one is giving some information that the foramen magnum is more in front compared to chimpanzees today. So in that case, this Sahelanthropus also may have been walking a little with some difficulties. That is understanding. So some recreations, you can see there are different recreations. We never know how it was. Nobody was there to take a photograph. So that is the first human ancestor. As of today, we understand 6 to 8 million years old. Then came another one. Again, very sorry for the different difficult names. Australopithecus afarensis. There have been a number of Australopithecines, Africanus, Barel Gassari, like that. Many. In fact, total identification is about 23 species. The Australopithecines lived on the Earth about 2.3 million years ago. And we have the famous Lucy. This is a very famous skeleton, Lucy from Africa. And she's supposed to be, this is a female, she's supposed to be a direct ancestor in the human line. And this is the very same one that is appearing here. And this is a recreation. And there is, interestingly, at the same time, after a volcanic activity, some of those afarensis people, they are actually not humans. They have been walking on fresh ash, and they later on solidified. So we have footsteps, a range of footsteps in Tanzania, which is giving us enough information about the walking ability of this Australopithecus afarensis. So this is called Laetoli. This is in Laetoli in Tanzania. It is Laetoli footprints, giving us an insight into their walking. And I'll try to show a video. I'll see whether it is working. It will be 1 minute worth of video. And the first one is a chimpanzee. The other one is Lucy, Australopithecus. The chimpanzees will walk in a minute. Lucy is little comfortable, but later we will see how the Homo sapien walks, where at that point you will understand the Lucy is not best at walking. The chimpanzee finds it really difficult to walk. If at all, they will not be habitually walking, but apparently Lucy has been walking. And you can see the elegance of walking by Homo sapiens, and Lucy is slowly approaching the elegance, but not that brilliant anyway. Right. With that, some of the pictures, some of the drawings by people thinking how the livelihood of Australopithecus afarensis. Then comes the first human. About 2.5 million years ago, there was Homo habilis, the first human. Homo genus means human. So that is the first one, coming from, again, Olduvai Gorge in Tanzania. This is the skull. It's not yet still small, about 1/3 of our brain size. These are all resins. This is only one in the entire scientific world having this skeleton. And how he may have appeared, why he is called Homo habilis. He's the first man to utilize tools, apparently. So that is why habilis, handyman. And he is the first one supposed to be eating meat. Usually the chimpanzees do not eat meat. They are predominantly depend on plants. Very occasionally they might eat meat, but the same is applied for early ancestors of humans. But this Homo habilis is supposed to be one of the pioneers in starting eating meat, and that provided the encephalization. Another very important milestone in human evolution, encephalization. The brain started growing. The initial, the Sahelanthropus, the afarensis, they had very small brains, almost equal to a chimpanzee brain. But later, habilis and all, they later went on increasing the brain size. With that, the intelligence appeared. So that is the one of the turning point. Terrestriality, bipedal walking, the encephalization, all important. Then came another human, Homo erectus, who lived from 2 million years to up to about 75,000 years. Actually speaking, this is the longest living humans, the longest lived humans so far. Homo erectus. This is again an early Homo erectus. Later on, they had a bigger brain case and a recreation by some of the museums, and they were using tools. And some of the tools I have with me, and these are actual tools used by them. And these are actual tools our ancestors used in eating, and these are from sites, and occasionally they sell these tools, that is, I could purchase them. For the first time, humans came out of Africa. They started inhabiting other areas. The first humans came to Europe. First Europeans are Homo erectus. First Asians are Homo erectus. And they apparently tamed fire. Homo erectus apparently tamed fire 50,000 years ago. And then came the Homo neanderthalensis. They of course evolved in Europe. They evolved in Europe from the earlier Exodus Homo sapiens, Homo erectus. Apparently, they are quite big. Homo neanderthalensis is quite big. In fact, bigger than us, our brain. So that is it. And they must have had a life very close to us. And if one of them lived today, that is Mr. Neanderthal. And there is an interesting story I'll tell you, because Neanderthal is still living. They predominantly lived in Europe and some part of the Central Asia. They apparently have had a bit of art, not very 100% confirmed yet. Then there was another man, Denisova, in Asian areas, lived in mountainous areas. Still, the research is going on. That's the Denisova. Then came the highlight, the Homo sapiens, appeared about 200,000 years ago in Africa. And initial ones, this is the recreation, the tool user, and the East Asia became the cradle of mankind. I don't need to show because all of you are medical professionals, have seen the human skulls. So interestingly, all humans living today are Africans. We all have come from Africa. So irrespective of who you are, we all have our great 3,000 times great grandparents in Africa. And this is how we might have, our ancestors might have lived. One interesting finding about Neanderthals, they were larger. Their brain case was larger, but it doesn't mean that they were more intelligent than us. You will understand that they were not successful as Homo sapiens. They were stocky built, small. Now this one is shorter and very muscular and stockily built, but the humans were lean and tall and little less muscular. The Homo sapiens started exodus from Africa about 70,000 years earlier. There are different stories coming in as to the exact dates, but they came out of Africa and populated all over the continents thereafter, reaching Americas in about 15,000 years earlier. These are the Red Indians, Inca, Maya, Aztec, all these civilizations. The Aborigines in Africa, all these were exodus from at that time. When Homo sapiens was coming out of Africa, there were a number of human species on this globe. There were several human species living at the same time, interestingly. Neanderthals, Denisova, Erectus, there's a Homo floresiensis, Homo heidelbergensis, there are a lot of names. All these were living. So just imagine, today we think we are the only species, but there have been several species at that time. This is a National Geographic study where I participated. This is my maternal line. The mother's ancestors started in East Africa and went into all over the world. So they came here and then came down to Sri Lanka, and they populated everywhere. And this red and yellow shows the ancestors where the current cousins are living. And similarly, a paternal line, it was not very extensive, started in East Africa and populated Central Asia and came down. And the population is little limited. So that is the story from National Geographic study. It's a great study looking at genomic studies. Destiny of Neanderthals. What went wrong? Because they were almost like us. They disappeared around 35,000 years ago. But they didn't disappear. They were incorporated into us. The Neanderthal is living with us, or we are Neanderthals, in other words. So about 1 to 6% of genome of all non-Africans are Neanderthal in origin. If you want pure Homo sapiens, you have to go to Africa. The native tribal Africans are the only Homo sapiens, pure. All others are hybrids. So these are done in Max Planck Institute in Germany, an extensive place. Studies are being done there. And you have an example of a hybrid human, 99% human and 1% Neanderthal. You can meet him. So that's my findings. And you can compare with 100% Neanderthal from a museum. This is through a National Geographic research that has identified a lot of information. So that human family is not a line, it's a tree or a bush. There have been many branches from the beginning in East Africa. Now we have somewhere here is the Homo sapiens. And we had the very close cousins, Neanderthals, Homo erectus and all, but you understand Neanderthal didn't disappear. They incorporated into humans, and we are both Homo sapiens and Neanderthals. Origin of human behavior. I'm coming to the last few slides. Now, all this evolution is going on, but today's behavior apparently has taken place about 50,000 years earlier. Now, I told you the Homo sapiens, the history is about 200,000 years, but the behavior is about apparently 50,000 years. Supposed to be genetic mutations that take place. Even today, some of the genetic mutations taking place. Now, I told you the tools, the humans started preparing different types of tools, fishing tools. All these are hand axes. They all came from the intelligence they gathered slowly. Homo sapiens started doing art about 32,000 years earlier. They started art in France. Now, one might ask why it is only in France or some other countries. These were preserved in deep caves they were in cold areas, no bacteria or fungi. So that is one reason why it is so. In tropical countries like ours, we hardly have anything of that age. But apparently in our country, there have been tools used by Homo erectus have been identified. So we also have a history, but we don't have because of the tropical nature. So there have been very deep in the caves, 1 kilometer deep in the cave, there is art. So these are coming from, to draw an art 1 kilometer deep in a cave, you want light, you want many other facilities. So they have had facilities apparently. So these are animals, their only world is animals and trees at that time. So they were mainly drawing animals. This is from Lascaux in France, the very famous cave. And these are art. And they had music about 35,000 years ago. From bones, they have had flutes. If you do the YouTube, some people are playing these flutes and they are not very bad. Man had ornaments, very old ornaments, and just showing you the most valuable archaeological finding of the old time, Tutankhamun's one. It's a little out of place anyway. Agriculture started 15,000 to 12,000 years in the Mesopotamia apparently, but their evidence are changing very slowly. The drawings in caves suggest that they did animal husbandry. These are Egyptian, well, 5,000 years earlier there's been agriculture thereafter, which gave rise to the first cities. Çatalhöyük is the first city as of today, 9,000 years old in Turkey. That is as of today. Maybe later on we might find further places. Civilizations came thereafter: Mesopotamia, Egypt, Sindh, Greece, Machu Picchu in Inca. All these came in later. The dog came to the society about 15,000 years earlier, because the hunting and all accompanied and then lived. Unfortunately, the dogs now, today's dogs cannot live without humans because their physiology has changed to live on cooked food. So these unfortunate animals from grey wolf cannot go back. So we have to, unfortunately, dog is a creation of human beings. Cat found a place with the agricultural activity. The grains were there in the stores, and the stores attracted mice. Cat came in and settled with man. And today, I'm coming to the last few slides. Today, the closest cousin is chimpanzee. We are sharing 98.5 coding genes. That's a remarkable finding, but the regulation genes are the differences. There is chimpanzee, pan troglodytes, there is paniscus, paniscus is bonobo, again another close relative, and our population has grown exponentially high because of our technology. I'm rushing at the last few slides. So this is not a very good finding. Because of that nature, our advanced evolution having, now we are seeing repercussions. We have exceeded the carrying capacity of the globe. We have been the reason for extinction of 85% of the animals, and we probably are the reason for 6th extinction. And the human story of success is not apparently a brilliant one, though it has been advanced, but we are the reason for disaster of the globe as well. Summary: the East African climate change forced the ancestors to walk, became bipedal, hands became free, started eating meat, they tamed fire, their teeth became smaller because the cooked food is easier to eat. The brain grew out of proportion with the meat eating, with that intelligence came in. One thing I didn't mention earlier, we have a shorter pregnancy comparatively. Human partus is the most painful because of the large brain. The humans have a long childhood, and whatever it is, the intelligent man today was born out of all these issues. That takes me to the end of the presentation. Thank you very much.
Thank you, Dr. Bowath, for the very interesting presentation, which allow us to think about human evolution at a different angle. So if time permits, I would like to give a very small comment. As you correctly said, the elements came from stardust everywhere within us, within animal and plants. So in recent paleoanthropology research, anthropologists extract these elements from prehistoric skeletons, both bones and teeth, in the form of stable isotope analysis, proteomic analysis, and so on. So these elements tells us the way the life pattern, food pattern, and especially disease pattern of those prehistoric people, what the type of diseases they have had. So they are getting very interesting outcomes from those. So with that, I ended up. So thank you very much again. And there's a certificate of appreciation to the presenter. So I would like to ask Professor Chandrika Jayasinghe to present the certificate.
Thank you, sir and madam. With that, concluding the session, I would like to cordially invite Dr. Arinda Dharmapala to present the tokens of appreciation to chairpersons of this session. Professor Roshan Piris. Professor Chandrika Jayasinghe. Thank you, sir. With that, concluding this session, I would like to invite you all for tea arranged in the ground floor, that is Hall B. And you may please visit the trade stalls there as well. And also, again, I would like to remind you kindly to return to halls within 15 minutes for the smooth progression of this session. In Hall A, there's a symposium on update on emergency medicine. And in Hall B, there's a symposium on rehabilitation in pediatrics. Thank you. Ladies and gentlemen, now we are about to commence the Symposium 9 of 44th Annual Academic Sessions, Candy Society of Medicine 2022. As honorary chairpersons, I would like to cordially invite Professor Vasanthi Pinto, Dean, Faculty of Medicine, University of Peradeniya, Dr. Duminda Herath, Consultant Emergency Physician, National Hospital Kandy, to conduct this session.
Good morning to all of you. We have come to one of the biggest program, or rather most attracted program for this KSM sessions in 2022, which is the Symposium for Emergency Medicine. And if I just recapped my knowledge for the last 10 years, I think this is one of the biggest developments of the health ministry, including all the other specialties. It's not any lesson attitudes of the other specialties, but truly to improve the emergency medicine in the country is one of the biggest jump the country has done for the last 10 years. And I'm so proud to be a part of that program. I think Duminda can introduce the first speaker.
Thank you, Madam. And it's an honor for me to be the co-chair with my mentor in 44th Annual Academic Session of Candy Society of Medicine. So let me introduce the first speaker. He's not a stranger for emergency medicine training in Sri Lanka. Dr. Nick Taylor, a fellow of Australian College of Emergency Physician. He's a director of resuscitation, senior emergency specialist, and co-director of emergency medicine training, Canberra Health Services. Dr. Taylor is a senior emergency specialist and co-director of emergency medicine training at the Canberra Hospital. He's the director of resuscitation for Canberra Health Services. He's the associate dean at Australian National University Medical School and has a passion for medical education. He has an interest in curriculum innovation and interactive education. He's the creator of Time Critical Medical Education, ticme.com.au, a free critical care education website, and multiple other e-learning websites. He has a great love for Sri Lanka and is a close connection with emergency medicine in country and cannot wait to visit it again. He continues to advocate for support and progression of emergency medicine in Sri Lanka as a member of ASM, Global Emergency Care Committee, and the ASM Foundation. Let me introduce Dr. Nick Taylor. So he will be talking about ECG made hard in emergency department. Usually we hear talks about ECG made easy, but he'll be talking on ECG made hard in emergency department. It's over to you, Dr. Nick Taylor.
Hello, everyone. I'm Dr. Nick Taylor. Thank you so much to Professor Ahigalara and Dr. Jayathalaki for the invitation today. I'm currently the Director of Resuscitation and Senior Specialist and Director of Emergency Medicine Training at Canberra Health Services and the Associate Dean of Australian National University Medical School. Today, I want to talk about some difficult arrhythmias that present to the emergency department or could happen in a ward environment, depending on where you're working. So we're going to go through a number of cases today. Case 1, there's a 19-year-old male in your emergency treatment unit. He had palpitations and nearly lost consciousness this morning. Had a previous episode when he was 15, but no one made a diagnosis. He has no significant past history, doesn't take any medications, doesn't use any drugs or alcohol. When you see him, he's pale and he's lying in your resuscitation area on a monitor. His pulse rate is variable between 170 and 215, and he's hypotensive, saturating normally, afebrile, and you don't think he's got COVID. So what do you think could be going on? What do you want to do next? You ask one of your staff to get a venous blood gas, and you can see on this that his lactate's mildly elevated at 3.8, and he has a metabolic acidosis, but his electrolytes are normal, and his hemoglobin is normal too. You're given a 12-lead ECG, and it's worth just having a little bit of time to look at this and see what you think's going on. So if you look at this ECG, it's definitely an irregular rhythm. It's tachycardic and the rate varies between about 170 and about 200. One of the key criteria here is this broad or narrow complex? And I think it's fair to say that this ECG has a mixture of broad and narrow complex QRS complexes. The standout feature of this ECG is that in a single lead, such as V1 or V2, you can see that there is a significant morphology variation from beat to beat, i.e. no two beats look the same. So this is clearly pre-excited atrial fibrillation, which is found in patients with the Wolff-Parkinson-White syndrome. Let's just have a look at why that happens. Just as a revision, Wolff-Parkinson-White syndrome has an accessory pathway or bundle of Kent, which connects the atria to ventricle. They can conduct in either direction. If it never conducts from atria to ventricle, then you don't see it. So it's called a concealed pathway. You can set up multiple sorts of arrhythmias in Wolff-Parkinson-White. The most common are the AVRTs or atrioventricular reciprocating tachycardias. More commonly, you get a narrow complex rhythm where the signal goes down the AV node and re-enters via the accessory pathway. This is called orthodromic AVRT. You can get the reverse of that, where the signal then re-enters from atria to ventricle, causing a broad complex regular tachycardia, or an antidromic AVRT. Both these arrhythmias can be terminated using AV nodal blocking drugs safely, even adenosine, because interrupting a point in the circuit will cause the arrhythmia to cease. But pre-excited AF is much more dangerous because you have multiple signals bombarding the AV node and the accessory pathway at once. And that leads to a chaotic ECG with variable width QRS comprised of narrow, fusion, and broad complex beats. And we know that blocking the AV node here can be extremely dangerous because it will allow all of those signals to just come straight down the accessory pathway with no rate control whatsoever. So how are you going to manage this young male who has hypotension and pre-excited atrial fibrillation? So because we weren't going to use AV nodal blocking drugs and we don't have procainamide easily available in Australia, we chose to do a DC cardioversion. Now, as you can see here, something's gone wrong during it. We used 70 joules, we synchronized the patient and then delivered the shock But now the patient has moved into a rapid tachyarrhythmia. It looks a bit like torsade de pointe, but it probably turns out to be just ventricular fibrillation. What will you do now? And why did this happen? So this is clearly quite a worrying scenario. So what do you do now? Well, the reality is because it was atrial fibrillation, we had synchronization on. And in this setting, what you need to immediately do is turn synchronization off and then increase the power on your defibrillator from the 70 joules you're using for atrial fibrillation cardioversion up to 200 joules. So that's what we did. And as you can see, we immediately changed sync off and then put him on 200 joules, immediately shocked him again, which thankfully reverted him to sinus rhythm. So what happened here? Well, the patient had a defibrillator R on T and got put into ventricular fibrillation. So why did it happen? Well, as it turns out, when I investigated this, the defibrillator R on Ts are much more likely in patients with Wolff-Parkinson-White. And this is for a number of reasons. Firstly, it's because they have a longer relative refractory period in WPW, which leaves longer period of vulnerability to getting a supramaximal stimulus, particularly on the back half of the T wave, which is the most vulnerable period. It's also more likely because the WPW rapid AF is usually very fast and machines are more likely to make an error when there is a much shorter RR interval. It's also more likely when the machines have difficulty recognizing the R waves and therefore can't synchronize properly. And that's more likely when they are trying to analyze an S wave dominant lead. So that's what it was doing in this situation. And it's also more likely to cause a perpetuated R on T arrhythmia if you deliver a lower initial energy. And we used to be in the habit of delivering, you know, a 70 to 100 joules as the first dose for atrial fibrillation cardioversion. So how to avoid a defibrillator R on T, particularly in Wolff-Parkinson-White? Make sure you use a high initial energy, so greater than 125 joules. You need to manually check when you are synchronizing that the arrows are correct and they have actually identified the R waves. So you can do that on the monitor, or you can print a rhythm strip from the defibrillator and just check it is accurately syncing. If you're having trouble, you should change the monitoring lead on the defibrillator to a lead that's a dominant R wave as opposed to a dominant S wave. And you should try and press the button for the shock when you're in a slower phase, so closer to the 150 than more than 200, where it's much more likely to make a mistake. So there's only about 3 cases reported in the literature of defibrillator R on T in Wolff-Parkinson-White syndrome. My case is the only one where the patient survived. The other 2 cases, unfortunately, the patient died. So I do think this is an important, although uncommon, situation to recognise, and some simple steps can mean you protect yourself against ever causing this yourself. Let's move on. So case 2, you're in the ETU and a 50-year-old man with severe chest pain comes into your resuscitation bay. This is very common in Sri Lanka, as you know. He has no significant past history as a non-smoker, but father died from a heart attack at age 47. He has an ECG on and he promptly arrests. The ECG shows a broad complex regular tachycardia. Question is this VT? So not only does he have morphological criteria, it's very supportive for VT, it's monomorphic, it's regular, it's got concordance in the chest leads. He's also a 50-year-old male with chest pain. In 2 large studies, if you're over 50 and you're male with chest pain, you're more than 98% likely to have VT when you have a broad complex regular tachycardia. Morphology by itself is unreliable at very high rates, but even if you don't know what it is, if you call every regular broad complex tachycardia VT, you're more likely to be right 80% of the time. What is VT? Well, it's a reciprocating tachycardia of the ventricle. Ventricular rhythms divided into 3, a ventricular scope rhythm or idioventricular rhythm, which are less than 40 beats per minute. The AIVR, or accelerated idioventricular rhythm, which you're familiar with as a root perfusion rhythm at 40 to 110. And then VT, it's usually greater than 110 and less than 200 beats per minute. So 1 minute after return of spontaneous circulation from your shock, you get VT again. So what do you do? Well, because it's witnessed and because you're resuscitating the man, you then give him 3 more stack shots. And this time he reverts very briefly and goes straight back into VT. So where do you go from here? We're now in a patient who's getting resistant ventricular tachycardia, and we know that the longer he stays in this rhythm, the less chance we have of cardioversion. Let's take this opportunity to briefly look at the causes of ventricular tachycardia. So essentially, there's 2 main groups: structural VT or patients with an abnormal electrical substrate. Structural in this instance is likely because he's got a ischemic heart disease, almost certain. But you can also have VT in the non-ischemic cardiomyopathy, such as HOCM or dilated cardiomyopathy, and then any other form of cardiomyopathy. Then you can have abnormal electrical substrates. A lot of these patients have inherited conditions such as Brugada syndrome or early repolarization, long QT, catecholinergic polymorphic VT. And then you can get VT because there's a acute problem such as thyroid storm or hypokalemia. So what to do in recurrent VT depends a fair bit on what you think the cause of. Working out the cause can be really easy, like in the situation of this gentleman with crushing central chest pain, but it can be quite tricky, and you need to be able to take the known past history and combine that with any family history you've got. If you do a bedside echo as soon as possible, particularly if they're in sinus, it might help you diagnose one of the inherited cardiomyopathies. Doing a blood gas to rapidly rule out electrolyte abnormality is important. And if an ECG can be done in sinus rhythm, that might give you some help as well. So the further treatment of VT really depends a little bit on what is the pathophysiology. Now, it's important to understand that VT is usually caused because of 2 electrophysiological mechanisms, either early after depolarizations, which is a secondary depolarization happens before you fully repolarize, and that usually happens when the action potential is very prolonged. And then there's delayed after depolarizations, which is the most common type of extra beat that happens. And this usually happens if there is a tachycardia or beta adrenergic stimulus. And if you get a big enough extra depolarization, then you will get a new action potential and you will perpetuate a abnormal rhythm. And this idea of spontaneous action potential generation is known as automaticity. And we know that beta sympathetic stimulation causes increased automaticity. To re-enter and to cause ongoing VT, you need a vulnerable substrate and a trigger combined. So in this patient, you have ischemic heart, which is enough of a trigger. So in this ischemic situation, then you've got delayed after depolarizations initially, and then a vicious cycle of delayed after depolarizations continuing. And because they're promoted by beta sympathetic activity and high intracellular calcium, the idea to try and treat VT storm is predominantly about trying to block this sympathetic activity to reduce the chance of DADs perpetuating. The times when you should not use sympathetic ablation to try and treat VT storm is in long QT syndrome and Brugada syndrome. So what did we do in this patient with the recurrent VT? The first thing I do is avoid adrenaline in a rhythmic arrest after the first 1 to 2 doses. And this is because this is a very strong beta sympathetic agonist, and I don't think it makes any sense to provide beta agonism when the goal of management now is to cause sympathetic reduction. Prioritize revascularization. In the setting of recurrent VT arrest, when you can't get to a cath lab, then I think providing thrombolysis is the right treatment. And then aggressive beta blockade. In this setting, what we gave was esmolol as a 500 microgram per kilogram load. We also gave the patient a high dose of fentanyl, so about 400 micrograms of fentanyl, and intubated the patient, and then ran sedation with fentanyl to cause further sympathetic blockade. And in this instance, the combination of those things terminated the VT, and we were able to get the patient safely up to the cardiac catheter lab. If you were to fail in these measures, then you can try overdrive pacing. So ideally, you'd have a transvenous temporary wiring. You could try with external pacing, and you would start at a rate just above the VT rate to try and get capture, and then slowly wind the rate back down to decrement it back down. Obviously, in very large centres, some of these patients can go straight onto ECMO or get a stellate ganglion block. Case 3. Well, you get a phone call from someone from a small peripheral hospital and they say, well, Doc, I had a lady with rapid atrial fibrillation this morning and I spoke to her cardiologist and they said, give her some extra sotalol. Well, we did that and it didn't work. And we rang them back and they said to give her a shock. So we gave her a sedation and then we cardioverted her and that seemed to work for a bit, but then she keeps going in and out of this awful rhythm. And so I'm going to send her up via ambulance to your ED if that's okay. Instead of just saying yes to the transfer, you ask them to send you a text message with the rhythm strip. And this is what they send you. What do you think's going on here? Well, that rhythm is slightly irregular with very different morphology. So it's polymorphic, it's irregular, and it's a tachycardia. So it's a polymorphic tachycardia, and it's broad complex, so it's probably a ventricular tachycardia. So the question is it a torsade de pointe or polymorphic VT? When the patient drops into sinus, you record an ECG, and when you look at this ECG, you discover there's a major abnormality on it. And that is that the QT interval is very prolonged. So it's about 580 to 590. So the sinus rhythm ECG is bradycardic, probably from the sotalol, and it has a very long QT. Remember that polymorphic VT is only called torsade de pointe when it's associated with a long QT. It's interesting to note that sotalol causes VT in about 2 to 4% of patients per year of therapy, and that is very similar to flecainide, which is another commonly used drug for this disease. But a lot of people feel a lot better about giving sotalol than flecainide because they usually do an echo when they're giving someone flecainide, but don't worry about that with the sotalol. Sotalol will commonly increase the QT in doses of 160 milligrams or above. And this patient had 160 milligrams as a loading dose. Amiodarone will also increase the QT, but almost never causes torsade de pointe, probably because it's also a calcium channel blocker. Just as a revision, you should know a couple of different ways to measure the QT yourself and correct it for rate. So you can use Bazit's formula or the Framingham formula, depending on what the heart rate is. Remember to try and measure the longest QT in V5 or V6 and measure it where the tangent from the T wave intersects the baseline. So unless hypokalemia or hypocalcemia is the cause, magnesium is the treatment for torsade de pointe. You should give 2 grams IV stat and then repeat it as required. You should give magnesium regardless of what its measured level was. And remember that slow rates have a higher absolute QT than fast rates. So speeding up the heart during sinus rhythm will shorten the effective QT. So my personal choice would be to overdrive this patient with electricity if they were intubated and they could tolerate it, if magnesium did not work. But you can also use isoprenolone to increase the sinus rhythm rate. You could try lignocaine to try and revert the rhythm, and you should avoid amiodarone. You only need to turn the rate up to about 90 beats per minute or so, which should reduce the QT enough to stop extra torsades. In this case, we just gave the patient some magnesium and they didn't get another ray of torsades. Final case is a 40-year-old male who's got an automatic implantable cardiac defibrillator for ventricular tachycardia. He comes into your ETU because he feels terrible. He's had multiple shocks today from his AICD and he's hypotensive. A 12-lead ECG shows an intermittently paced rhythm, AV pacing, followed by short runs of non-sustained VT. Whilst in front of you, the patient has further episodes of sustained VT, followed by what looks like faster VT caused by the pacemaker. So what's going on here? The patient then has further VT and then even faster pacing, followed by what looks like a shock, which then followed by more VT. So we've got a patient who's basically in resistant VT with an AICD. So what do you do from here? So remember, AICDs are put in usually for VT or VT risk, and they have anti-tachycardia protocol built into them. What they try and do is terminate your VT using birth overdrive pacing, and they usually have at least 3 attempts at that. On the third attempt, they tend to shorten the R interval of the pacing, which is slightly riskier at causing an R on T, but more likely to revert. And if the patient does not get reversion to sinus rhythm, the device will then deliver an internal shock. So if the patient is well despite having runs of VT, then you should treat them with the usual antiarrhythmic therapy if you believe that the device is correctly interpreting the rhythm. If the patient is in cardiac arrest, regardless of their AICD, then you need to externally shock them, and you put your pads in an AP orientation, so anterior-posterior, and then deliver an unsupervised shock as normal. There is no harm from continuing CPR if the AICD is internally shocking, so you should let it continue to do that. And you shouldn't use a magnet unless you think the AICD is abnormally shocking the patient and causing the problem, because the magnet in this situation will cause the AICD to stop its anti-tachycardia protocol. Because of the repetitive shocks this patient was having, we externally cardioverted them and reverted them to their AV sequential pace rhythm. So what should you do if you see a patient who's had a shock with an AICD? Usually, if there's just one shock, they could be seen the next day by their cardiologist and have the pacemaker interrogated. You need to ask them if they've had symptoms before or after, such as ischemic symptoms. Do an ECG and check their electrolytes. If the patient's had more than one shock, you have to decide whether the shocks are appropriate because they're actually having VT or inappropriate because the machine's making an error. If it's inappropriate, it's often because it's trying to shock flutter or SVT, and you should give medicine to treat the rhythm as normal. And if the patient is being inappropriately shocked often, you can use a magnet to try and turn off the anti-tachycardia protocol. And these patients need urgent pacemaker interrogation. Remember that a magnet for a normal permanent pacemaker will put the device into asynchronous fixed pacing mode, such as VOO or DOO. And this will only work for over sensing. So it will stop the pacemaker sensing and just revert into a fixed paced rhythm. For an ICD, it will stop defibrillation temporarily and thus is used for inappropriate shock. Thank you so much for your time today. I've got lots more cases, which I put up on my website. It's been a real pleasure to speak to you. I hope you have a good session at the Candy Academic Sessions. Goodbye.
Thank you, Nick, for that wonderful presentation. And we all know your love towards Sri Lanka. We know that you have already joined through Zoom, and we will wait for your questions till the end of this, the whole symposium. We have 2 eminent speakers from the emergency medicine in the country to speak to you all next, and the 2 giants, I would say. And it's my pleasure to introduce, even though little small to look at, a giant in his heart with his humble attitudes, Dr. Indika Lanarol, who has graduated from the Faculty of Medicine, University of Colombo, and he got his MD Emergency Medicine, and he was our first consultant to this country, and he has made a history proud. And he was the batch top in the very first MD Part 1 and Part 2 examinations in emergency medicine. And he won the ACEM PGIM gold medal for the best performance. And he was the first to get both certified as an emergency physician in Sri Lanka. And now he is attached to the ETU National Hospital of Sri Lanka. And he was the past president of the Sri Lanka College of Emergency Physicians. And he has been doing a yeoman service to the country by being a member of the National Guideline Committee for COVID-19 and Technical Committee for COVID-19, and then the member of the COVID-19 Mortality Review Committee. And Indika is going to talk to us about the trauma resuscitation, how to get it right. Over to you, Indika.
Thank you, madam. I'm indeed honored by the invitation received by the Candy Society of Medicine for this prestigious symposium. I must be thankful to Professor Article and my good friend, Dr. Nandana Chaudhary, the co-secretary, And indeed, madam, for the enormous service that you have rendered to the emergency medicine. And thank you for that kind introduction. So the topic which I have been given, or I had chosen to speak about is trauma resuscitation, how to get it right. So I thought that I would be speaking to, for the next 25 minutes, about two patients whom we received during my foreign training. The first one, a 63-year-old female, a pedestrian, is struck by a car. We got a bad call by the emergency medical services. A bad call is something which is actually from the Batman movies in 1960s, where the Captain Gordon has a special access telephone to the Batman. Just like similar to that, the emergency medical services in foreign countries, they do give a call to the emergency department before coming to the, before sending the patient to the department in order to be prepared so the patient outcome will be in place. So it is good that it is happening in Sri Lanka in certain emergency departments which have been manned by ED physicians. So this is our version, and this is the primary survey. He was maintaining the airway with some bloods on the lips. Respirate is around 26, saturation about 92, breathing on an unrebreathed mask with a 15 liters of minute oxygen, and there was a reduction in the air in the right side. Blood pressure was okay, 102/80, rate was around 110, and there was some free fluid in the right upper quadrant. GCs is around 10, sugar 90, so on and so forth. So as per the protocol, the management done was, because in those countries there's no issue with ICU beds, we thought that the patient is going to crash. So we intubated the patient. He was roughly about 60 kilos, 50 to 60 kilos. So we used about 100 milligram of ketamine, 100 milligram of succinylcholine, and intubated. Just after the intubation, this is what happened. Patient crashed. Blood pressure dropped to 53/430. So as per the guidelines, fluids were given, plus requested, tranexamic acid given as per the crash trial. And this is the outcome after that. Patient's blood pressure marginally improved, received 3 units of blood, stabilized, sent to the CT room. But again, patient crashed. Systolic blood pressure dropped to 70. So patient had to be rushed back to the emergency department. And these are the CT findings. There was a small subdural hematoma and right-sided pneumothorax. Grade 3 liver laceration. So what happened actually? We successfully managed the airway. We thought the patient is going to crash. We intubated, no issue. But unfortunately, we could not manage and prevent the hypotension. As we all know in trauma, especially when it comes to the traumatic brain injury, even a single measurement of low blood pressure has a detrimental effect in the long term. So hypertension is improved. Is there a different way to manage this patient? So that is what I'm going to talk about. This all stems from this landmark paper which was published in America in North American Emergency Medical Clinics, where they proposed a resequence approach. In the same year which the ATLS new guideline was published, but even now they are taking note of what they are going to speak about. But I'm going to ask a very primitive question in front of the professor of anesthesia, radiology and intensive care here. So pardon me for that. So what are the indications to intubate a patient in emergency department? So if I ask this question, there are about so many indications, but I try to categorize them into these 5 main topics. If one is unable to maintain the airway, obviously, and if there's a failure to ventilate or oxygenate, and if the projected course of the patient, right, if the patient is going for a respiratory failure, we probably try to intubate beforehand. So this was the case that we intubated our patient originally. We thought that the patient is going for a respiratory failure. And the fourth one, which is not being very used commonly in Sri Lanka, the take control of the situation. In countries where ICU beds are not of a short supply, say a patient comes with intoxicated, shouting, and there's history of trauma, and you don't know what you're dealing with, and you can't miss anything, and you can't control the patient. So sometimes you intubate the patient temporarily for a short period of time till you get entire investigations done, and then once everything is done, you extubate the patient. So to take control of the situation also, you intubate the patient. But in trauma, most of the patients do not need immediate intubation. Instead, most of the patients, because they can be intoxicated, they can be intoxicated with alcohol. How many patients we have seen that people are totally intoxicated with alcohol? They sometimes vomit, but they don't aspirate. So you can wait a bit more. So we can, instead of just rushing and intubating a patient, you can wait, you can manage the airway temporarily, while the physiological risks of post-intubation hypertension are at risk, which if occur has a detrimental effect for the patient. Why? Why? What is the problem? Intubation without resuscitation may lead to dangerous hypertension, and that can at times lead to cardiac arrest also. This happened with our patient. Especially so in trauma, a patient, say a patient with tension pneumothorax, a patient with cardiac tamponade. If they jump and intubate, you're asking for trouble. In the next minute, you're probably resuscitating a patient who is in arrest state. So that begs the question, what are the indications for immediate intubation in patient with trauma? So in this paper and in subsequent literature, they have proposed two scenarios where a persistence of dangerous hypoxia. Unfortunately, they haven't given us one single saturation value for obvious reasons, but dangerous hypoxia is defined in most papers as a persistent hypoxia which endangers the life of a traumatic patient, despite their normal airway maneuvers and use of oxygen delivery devices, obviously not the invasive methods. So that's one indication. The second indication is if there's a presence of dynamic airway injury. The dynamic airway injury is any injury to the oropharynx where you have been putting your ET tube, or the air is flowing through, that has already blocked, or there is a real chance of blocking the airway imminently. So if those two indications are there, yes, you need to intubate this patient. But all others, you can wait for some time. Next, let's discuss a second patient. A similar patient, but managed differently. So this is also a patient with after road traffic accident. He came with these parameters. He was maintaining the airway respirator was 26. Blood pressure was 100/80. GCS was 10. So there was no dynamic airway injury. The patient was maintaining the airway with a saturation of 90. I know it's low, but he was maintaining it in a persistent level with the non-rebreather mask. So team leader decided not to intubate. Instead, he thought, okay, probably we should resuscitate rather than jumping into intubation. So what to do? In resuscitation, what are we looking for? We are looking for two important clinical conditions. One is called shock. Obviously, we know what is shock. It is defined as a circulatory failure resulting in insufficient cellular oxygenation. But the important thing in profound shock patients, there will be hemodynamic parameters that will indicate you that the patient is in shock state. But the issue is with the occult shock. Occult shock, there is persistent tissue hypoperfusion. But hemodynamic parameters are not deranged to the extent that you may not take a notice of. If you see our two patients were maintaining 100, 110 rate, with tachycardia, saturation is okay, right? Now, one might not, if you are not objectively assessing this patient, one might think, okay, the patient not in danger. So how to identify shock? The classical teaching is the ATLS shock classification, where they have 4 shock classes according to the vital signs, basics, and the mental states. But it's been widely debated that there are a lot of problems with these rigid classifications. I'm not trying to criticize ATLS. It has done wonders to the trauma management. Until such time, there was no proper way of doing trauma resuscitation. So to all credits, kudos to the ATLS team, but always we question certain. Right. How to identify the occult shock in trauma resuscitation? Simple ways, clinical and laboratory indicators. But as you may all appreciate, there's no perfect indicator. Each indicator has its benefits and pitfalls. Few words about vital signs. Still the central element for the trauma management. Trends are important than single measurement. Hypotension. If you ask what is the cutoff level for the hypertension in shock, a lot of people would say it's 90. But this cutoff is debatable, and research has proven it sometimes misses an important proportion of trauma patients who are in shock. Now there is an argument that we should take this systolic blood pressure less than 120, persistent systolic blood pressure less than 110 as the new cutoff. The second one is shock index. A very simple mathematical formula. You divide heart rate by systolic blood pressure. Generally taken as 0.9 as the cutoff. One drawback is still the researchers are not in agreement what is the exact cutoff value is. But a value of more than 1 is very easy to calculate. Say in a patient with anyone with a heart rate more than systolic blood pressure, then the shock index is more than 1. There's no calculation need to be done. In a complex trauma management scenario, that is a very simple thing to do. Shock index of more than 1 is associated with poor outcome. But there are certain drawbacks. It is unreliable in certain age groups, in the presence of untreated hypertension, and if the patient is taking certain medications. The third one, which is incorporated in the ATLS new guidelines, is also base deficit of more than 6, which has been correlated to increased transfusion requirements, injury severity and mortality, and help to identify people who are in shock, also occult shock. If the ATLS, the class 3 shock, the base deficit is more than 6. The new marker, which is not a new marker, but new thinking which they are trying to incorporate in trauma management, is the presence of high lactate level. The surrogate predictor of blood loss, shock and mortality in patient with trauma. Should we do multiple or single value? There's no difference in the predictive value, even though you single value or multiple value. So in summary, if you use lactate and base deficit, they may be probably the only indicators that will tell you the patient is in occult shock. Our issue is with the occult shock, not the shock. Shock, we know that the patient is in shock state. So case number 2, so second patient, different approach. So the team leader didn't intubate the patient. Instead, he chose to resuscitate because he thought the patient is in occult shock stage. So what to do? He used this term called targeted interventions. So there are very few things that you can do. There are so many things, but there are very few important things in the initial phase. So these are the things which can be done if the patient is in occult shock state. You can give blood, you can use to decompress the patient, if there's the evidence of pneumothorax, control the bleeding, so on and so forth. So in our patient, there was the second patient, there was reduction in air entry in the right side. So we did the pharyngothoracostomy, saturation improved to 95, blood products were transfused, and the patient remained hemodynamically stable until he goes and coming back to the ED after the CT scans. But still, this patient is at risk of losing his airway. Now it's time to intubate. Now we are resuscitating the patient. Right? We know that patient will not crash, hopefully. So how to intubate is the next question. Pardon me for doing all these things, madam. So when you intubate a patient in an occult shock state, there are certain modifications that you need to do. This is not only in trauma, but any critically ill patient when we are intubating. So first thing is you think of your induction agent. You can use whatever you like. You can use thiopentone, whatever you like, but the important thing is you need to reduce the dose. So in trauma, people with a shock index of more than 1, they advise to reduce the induction dose to the 25% to 50% of what the normal dose should be. You can use whatever you like. And the muscle relaxant, no dose reduction is needed. You just can use the normal doses. So with these techniques, we intubated our patient using ketamine, a reduced dose with the full dose succinylcholine. And actually, we didn't have any post-operative hypertension. So it was successfully managed at that stage. He remained hemodynamically stable during the transport to the CT and during the CT scan and after coming back also. So take home points. The number 1, strict application of ABC paradigm in trauma management at all times are being questioned. People are proposing a resequence approach where you identify your priorities. Say, for example, if there is threat to the imminent threat to the airway, like dynamic airway injury or dangerous hypoxia, you address that. Otherwise, you try to identify whether the patient is resuscitation before intubation. That's the first message. The second message is inability or delayed identification of shock or occult shock in trauma. I'm sure the occult shock is the problem. So the mitigation strategy that is being proposed is apply evidence-based indicators to identify shock and occult shock. The two laboratory indications, which are the point of care test, we can get as a point of care testing, is base deficit and the lactate levels. Third message is intubation is before resuscitation in patients with trauma with evidence of shock and occult shock. You should not do that. So as I have already mentioned, unless critical hypoxia or dynamic airway problem is identified, resuscitate before induction. The final slide is administration of full dose of induction and agents. I'm sorry, the paralytic agent, that word should not be there. Induction agent, regardless of the pre-intubation hemodynamics it appears for. So if you identify shock or occult shock, you need to resuscitate the patient and give a reduced dose of induction agents, which is about 25 to 50% of whatever the agent. People think that the ketamine is the best, but there are arguments against that also, but you can use whatever the agent, but reduce the dose, please. That is for any critically ill patient, even in a medical ward if the patient is crashing. But administer the full dose of paralytic agent. Thank you.
Thank you, Indika. I'm going to rest you for the questions till the end of the symposium. Thank you very much for elaborating how to, or trauma resuscitation, how to get it right. Thank you.
Thank you, buddy. Thanks.
I promised you that I will invite for another giant from the field, and let me invite Dr. Ganija Samarajiva. He has enormous ability of organizing things and unmatchable ability to organizing things. That is why they have selected him as the president of their association now in the year 2022. Dr. Ganaja Samarajiva is a board certified emergency physician currently working in Teaching Hospital Kalutara. He chose to work in Kalutara because he improved Kalutara into a level almost to an international standard. So that has made him to be so bound to Kalutara, I believe. He obtained his MBBS from University of Ruhuna in 2007 and a postgraduate diploma in critical care medicine from PGIM University of Colombo in 2013. He has completed his MD in emergency medicine in 2016 of the same year as the previous speaker, and he obtained the membership for the Royal College of Emergency Medicine. He has 2 years of experience in emergency medicine at the Canberra Hospital, Australia. I know for sure that you came with very flying colors, with very good remarks from your trainers. Ganaja is interested in teaching resuscitation to healthcare workers and also an ALS2 instructor for the Australian Resuscitation Council. He's going to talk on a topic which is very close to my heart too on a personal note, ethics in resuscitation. Over to you, Ganaja.
Thank you, madam. And thank you for inviting me for today's talk, Professor Artigal and Dr. Jayatilaka. Thank you very much for inviting me. So today my topic is regarding the ethics in resuscitation. So the objectives of my talk is to discuss about the importance of ethics in resuscitation as well as in general, the basic principles of ethics, but I'm sure you all know that, but how it affects on resuscitation. And of course, 2 case scenarios, which was quite interesting. Okay, so what are ethics and why they're existing? So the ethics are made by the professionals on that field by themselves, for themselves. These professional ethics are dealt with more of moral duties, and it is not necessarily will be questioned in the court of law, but of course they can be, but it is not necessarily questioned in the court of law. So these ethics will be governed by the professional bodies in medicine, as it's a Sri Lanka Medical Council in Sri Lanka. These ethics are very important. Why? It is to look after the profession. And of course, in medicine, it will certainly look after the patients, and same time, it will look after the profession, which is equally important. But when it comes to emergency, these facts are not that straightforward because it is time critical. So the time is very important. You may not have enough time to sit and think and act. So it is challenging. And same time, in resuscitation, as well as in ICU, the same, when it is withdrawing the care. So these different principles might overrule each other, or sometimes it might contradict each other. So we'll see a little bit on history first. So these ethics in medicine were first introduced in the Hippocratic Oath, as we all are given. But in 1948, the Geneva Declaration have identified this medical ethics as important fact, as there were a lot of human right violation during the World War II, especially in Germany. And after that, in 1960s, the science is developed more, and they have started using ventilators quite oftenly and routinely, unlike in the polio epidemics. By 1960s, it's more freely available, though not in our country. And of course, using the feeding tubes to prolonging the patient's life has been increasingly being used. That has questioned, or that made the professionals to think about the ethics more in patients prolonging their lives as well as the resuscitation. Earlier, the doctors were having more paternalistic approach and they are more duty bound. So the doctors made the decisions on behalf of their patients. And when the time comes with the evolution and with the modernization, the patients have given more opportunity to make decisions on behalf. Okay, so what are the basic principles? We all know there are 4 main ethical principles. They are autonomy, beneficence, null maleficence, and justice. But of course, people do talk about the patient's dignity as well as our honesty. So I have included 6 here, but mainly there are 4 principles. Autonomy. Autonomy reflects the right of a person to make his or her own decisions without external control or undue pressure. So for that, we have to select the competent patients. So the competent patients may participate on their own healthcare planning. So they may accept they may refuse their treatment. But however, they may not receive all the treatments they expect. We will discuss it in little later. And of course, the patients cannot demand resuscitation or even any treatment modality. Of course, the patients can request, but the patients cannot demand a treatment modality, especially resuscitation. So with the autonomy, so the concept is the informed consent has developed. So the patient should be informed well in advance about the possible benefits and risks of a certain procedure or the resuscitation, and then get the patient involved in the decision making. Same as in the advance directives, either patient can make or the patient surrogate can make an advance decision well prior to a certain incident happens. So what will happen when the patient becomes critical or when the patient sustains a cardiac arrest? Of course, the patient loses the competency. So it is not the time for us to sit with the patient and talk. So what will happen in that case? Doctors are duty bound to treat the patients. And of course, we have a duty of care. So in that case, in doubt, we may initiate the resuscitation. But there are other basics or other points in ethics that we need to think about. The second thing is the beneficence. So the following an assessment of relative risk and benefit. So the interventions are selected to their potential benefit of the patient. So obviously, resuscitation as well as CPR is obviously benefited. Because if we don't give CPR, for sure the patient is going to die and we will declare the death. But on the other hand, it all depends on the successful resuscitation. So what is successful resuscitation? When the individual is not cognitively impaired and reports an acceptable quality of life and also not significantly deteriorated relative to their pre-morbid state. Right. So though this providing CPR or resuscitating a patient is clearly seems to be benefited, if our resuscitation is partially successful, then the question arises. So the non-maleficence comes in this point. So it is a very old term which is coming from the Hippocratic Oath. These resuscitations, though there are so many advances in the medical field, as Dr. Lanroy talked about these ECMOs, new agents, tranexamic, you name it, immediate surgeries, crimson codes, trauma codes, still the survival rates are very, very low. Overall, out of hospital cardiac arrests, there are only about 3 to 5% of overall survival. And of course, in best centers in US, in hospital cardiac arrest, maximum is 20% of survival. So that means every 100 patients we resuscitate, who get in hospital cardiac arrest, 80% will die ultimately, and they won't go home. So though we say it's benefited, but making a decision, it may not so. So most of these guidelines, because of this case, even the European or the UK Resuscitation Councils and American Heart Association or the International Liaison Committee of the Resuscitation, they all made clear guidelines when to terminate the resuscitation. So one of them are non-shockable rhythms. After excluding all the reversible causes, if the patient is sustaining non-shockable rhythm for 20 minutes, we can terminate the resuscitation. And of course, zero ABGA for 20 at the 10th minute of a baby, we may call off for the resuscitation. The same applies in the withdrawal of care, and I'm not going to talk about it more. I think there is a separate session about that. So discontinuation of the ventilation, probably at the moment in the country, it is only for the brain dead patients are allowed. Okay, the fourth one is the justice. We all want the justice. When we go anywhere in the country, even if you go to the law, court of law, all what we need ultimately is the justice. So all patients should have equal right to health care. So the WHO has identified right to emergency health care as a basic human need. But at the same time, we all know in the worldwide, there is a resource limitation. So providing justice to the one patient might hinder the justice for few other patients. Extensive allocation of resources to the one person may lose two or more other patients for the opportunity to live. So the clinicians should be carefully weighed the risks, benefits, as well as the outcome of the particular patient, as well as as a whole in the unit or the department when you provide the justice. So the justice should be provided irrelevant of age, ethnicity, or gender, and so on. But does ethnicity matters? The studies have shown, the one study which has done in Chicago, overall chances of survival of a Black American is about 0.8%, and similarly the whites is about 6.3%. But they have calculated there was no difference from call to 911 to the duration for the defibrillation. But of course, maybe the epidemiology of cardiac arrest may be different from the Black as well as white, but this shows there is a significant variation among the ethnicity, which should not be happening. Does the age matter? We all say age is just a number. What matters is whether the patient has comorbidities or how his pre-arrest functional state is. But there was a study which has undergone questioned emergency physicians about their perception on while making the resuscitation about the patient's age. The majority of emergency physicians thought they have to consider the age before making the decisions of resuscitation. Okay, the fifth one is the dignity. So the dignity is actually, it overlaps with the patient's autonomy too. So it is intrinsic moral worth of people. So it is multidimensional. So it includes patient's autonomy, spirituality, meaningfulness, physical comfort, as well as interpersonal connectivity. They all come to it, and it is more subjective. My dignity might not be your dignity. So it highly personal. But of course, as basic principle, we all have a right for a dignified death. But in US, some movements are there, even for not only for a right for a dignified death, there are some movements for right for death. If you want to die, we should have a right to die. So honesty. So increasingly, though from old age, the paternalistic approach where the clinician decide on behalf of the patient has given more chance or more opportunity to make their own decisions. But at the same time, the clinicians are expected to involve in the patient's decision making when it comes to critical conditions. So the doctors are expected to facilitate their decision making by being honest as well as being transparent with regard to their opinion. So the patients expect us to be honest as well as being transparent with regard to the explanation what we give regarding the possible outcomes as well as the risks. So the ultimate, when the patient takes the consent, of course it is the patient's will ultimately, but we will be modifying by using our knowledge as well as our experience. The final decision will be modified, but of course towards the best interest of the patient. But when it comes to the emergency situation, the serial discussions talking little deeper into the possible risks and benefit may be challenging, but of course, as much as possible, we need to reveal the possible outcomes as well as the risks of the certain procedures, not only performing the certain treatment modality, but of course not treating this condition, the outcome as well as the risks. So you may have seen this DNR as well as DNA CPR. There are some other terms we use, NFR, not for resuscitation, and so on. So these DNR as well as DNA CPR, they are overlapping because providing CPR is again a mode of resuscitation. So these DNR orders will be given by the competent patients or sometimes by the physicians. But in Sri Lanka, the law is not that entertaining and it is not clear and not been modified, is having little problems. But DNR means that can be arranged to withhold a certain specific resuscitative measures. That doesn't mean or not necessarily mean the stopping all the care. So probably it may be continuing the patient's feeding, maybe making the patient's, keeping the patient's hygiene, maybe sometimes keeping the patient's oxygen or IV fluids. But of course, we can provide a certain level of ceiling care. But on the other hand, you may see a patient who comes with a DNR orders which has made during his or her previous hospital visit, which is not valid for the current hospital, because you never know, that old man is now, his daughter is expecting a child, now he wants to see his granddaughter or grandson and he doesn't want to die anymore. So you never know, the patient's wishes may have changed. So if it is a DNR order, it should be a fresh order or a fresh decision made in each time. So the respect for the patient's autonomy may be irrelevant when it comes, when there is no potential benefit. So the no potential benefit is zero benefit. So the physicians are not meant to continue the futile treatment. So though there are advances in medicine, where we have the ECMOs, we have more sophisticated ventilators, we have number of inotropes, we may have intra-aortic balloon pumps, which can prolong their living. But of course, if it is futile, so what is futility means? Futility means zero benefit. It's not 5% benefit, 10% benefit. The futility means the zero benefit. So the doctors are meant to withhold or withdraw the care when there's a zero benefit. Of course, it is not going to benefit the patient. most of the time in these situations, the patient or the surrogate or the patient's family will be involved in the decision making. But of course, even if it is not being involved, the court of law, most of the times, it will uplift the medical decision unless in exceptional situation. I must emphasize the exceptional situation, because we are meant to make honest decisions towards the best interest of the patient. Okay, little bit about the perception of resuscitation in anesthesia and critical care. So they have questioned in the anesthetics, if a patient who is with a DNR order comes to an operation and if they get a cardiac arrest, what would you do? The 35% of anesthetists will say, if they get a cardiac arrest, I will resuscitate them, though they have a DNR order. And 68% said they will perform CPR if the cause is iatrogenic, not due to the patient's original cause. In critical care, the 83% of these critical care specialists, they were favor of making unilateral decision of withdrawing of the life support. Okay, so we will move to two interesting cases. I'm sure you must be knowing these. First one is this Teresa Chiavo's case. She was born in 1963 and expired in 2005. In 1990, she has sustained an out-of-hospital cardiac arrest due to hypokalemia. She used to drink green tea, 10 to 15 glasses of green tea per day, because she wants to lose some weight. So she has sustained a cardiac arrest. The husband called 911 and the paramedics have started CPR and successfully, within brackets, resuscitated, but she went into persistent vegetative state. So in 1993, her husband sued her gynecologist for failing diagnosis of bulimia, because she went to see her gynecologist because she has stopped her cycles, but her gynecologist has failed to diagnose she is having bulimia. And the husband won about 6.8 million of US dollars, but ultimately it has reduced to 2 million, I think. In 1998, so 8 years after she has become to a vegetative state, husband said the Teresa doesn't want to be feeded and should be removed her feeding tube, and her parents were against. And the parents have challenged it, and it went on and on and on, and even the Republicans as well as the President George W. Bush was involved. There were about 14 appeals and several legal motions, and ultimately the final decision was given in 2005 to remove her feeding tube. So it was removed in March 18th and she died on March 31st. It was quite distressing to let a patient who stayed with the medical team for about good 15 years to let the patient to starve to death. But the study shows if you remove the feeding tube and let the patient die, of course, they do die peacefully. So that are the evidences. So it was a landmark case of right to die. But of course, I think the husband side as well as the parent side, they both wrote books with regard to their side of the story. The second case about this gentleman who was born in 1908 and died in 2008. He was a legend in vascular surgery, lived for about good 99 years. In 2005, he was diagnosed with aortic dissection. And I think you all know his own classification on aortic dissection. So he resisted on surgery and he said, I'm 95 or, sorry, I can't get the age, but of course I'm very old, so I don't want the surgery. And ultimately, he was deteriorated and he lost his consciousness. And then the vascular surgical team in his hospital went into the ethical committee, and the decision of the ethical committee was to overrule his autonomy, where he made the decision of DNAR when he was competent and approved to go ahead with the surgery. So his aortic dissection was repaired with a graft, which he has to the method which he has discovered to the world. And he was the oldest patient who has undergone an aortic repair ever at the age of 97, I think. So he stayed in the hospital for 9 months, which cost him $1 million US. But afterward, he lived 2 more years. And after he gained the consciousness, he thanked his team for saving his life. In summary, ranking of different ethical principles in each scenario is very special. So you need to take case by case and make the decision. So the CPR is a treatment modality. So that should be carefully chosen to consider the long-term benefit. So involving the patient in the decision making as much as possible. But making the decision in the emergency department may be challenging. On the other hand, saving the patient's life only should not be the final goal. But of course, if there's any doubt, you should initiate the resuscitation. Thank you.
Thank you, Manager. Thank you for a wonderful lecture. So we would like to thank all 3 lecturers, all 3 speakers for delivering their lectures efficiently, and it's an eye-opener for the audience and also keeping the audience alive. So now it's time for the discussion. So the questions are open for the audience. So if you have any questions, you can raise from the other speakers, 3 speakers. Yes. I think I'll start with one question.
Fresh DNR, how fresh it has to be? So imagine that he has documented for this DNR for 1 year before, but he's expecting his daughter is having the child. How fresh you intend?
Even in practice, the previous admissions DNR orders are not being considered. So always in these admissions, we take a fresh DNR order if it is so. Because sometimes you may get a patient who comes in a cardiac arrest, you open up the chest to give CPR and it says, do not give CPR. Are you going to give CPR? Oh my God. So this is kind of, but this tattoo could be a permanent one, which he may have changed his mind maybe a week ago. So always DNR order is going to expire if the patient has been discharged from that hospital stay. So after the new admission, we take a new DNR order.
This DNR, you said it expires once the patient is discharged. Now, supposing how do we now, in the state of mind, if the patient is conscious and he may have informed the relations DNR, or what is the legality? Because it is, for example, if we want to, if a particular person wants to DNR to be implemented, how to set about it?
in the setting in Sri Lanka, it is honestly, it is not so clear. I must, but of course, on the other hand, what they say, even the family have no right to make a decision on behalf of patient. Or if you get the daughter comes with a father who is very sick, he's not now competent to make a decision, but we ask from the daughter. But technically, daughter cannot make a decision on behalf of the patient unless the patient has legally given the authority for that daughter to make the decision. But of course, it is a combined decision we make. We get all these ethical principles together. So we might ask from the daughter, what did your father thought about getting a resuscitation? So the daughter might say, no, he loved to stay for another 2 years. He wanted to go to Somavati next Vesak full moon day, whatever it is. But of course, on the other hand, we will take everything into account and make a fair decision. But finally, one term comes that is towards the best interest of the patient. But the best interest might not be just prolonging his life. So it includes quality of life, dignified death, as well as living more years or days. So it comes all together and making the final decision.
Clarification. Now, supposing patient, the written conscious when he's normal in a written form, two relations with the signature, is it valid?
As I said, that the written document says about the perception of the patient at that time, which he may have checked his. Of course, it is helpful. I'm not saying you just throw your previous DNR orders away. It certainly helps to get an assumption what the patient's wishes are. But of course, my point is you cannot solely rely on that paper, because simply patient may have changed their mind. Patient may have a new hope and they want to live. But it could be one thing, but it is not a sole document that you can use while making a critical decision of life and death. Yes, of course you can say. The patient can say, so the patient has right to refuse a treatment. Patient has right to accept as well as to refuse a treatment. But it's not euthanasia. Patient doesn't have right to die up to now. But patients have right to reject a treatment. So the resuscitation is a mode of treatment which a patient can refuse. But at that time, patient has refused, but today patient
not in a position. So at that point, he is unable. But beforehand, when he is healthy, he has decided firmly that I should not resuscitate it, then suffering is more. So what is the position in that regard?
As I said, you can use it. It will help, but it is not the document, because we don't know whether the patient has changed their mind afterwards. So that's why if the patient wanted to live, if you not resuscitate, that is again the patient's against the patient's will. So certainly you can get the help or aid of that document, but it is not the document. Once you sign, you are not resuscitated, because they can change their mind.
There will be a very there are going to be a very energetic discussion in the evening as well regarding the same topic with a participation of a lawyer. And I'm sure you may have to ask these questions by him as well, madam. And I'm sure this you can have the same discussion at that time too. And thank you so much for all three speakers and with the time constraint, and to Nick as well, who has joined through Zoom. Let me invite another very legendary figure in Kandy to give over the certificates to you, who has been and is involved in so much of teaching in resuscitation and very silently doing a great job and a great service to this country. And that is my friend, Dr. Siddharshi Kirivattuduwa.
Dr. Indika Dilenaral. Dr. Ganaj Samarajiva. I would also like to thank Professor Nick Taylor for joining us. Thank you, Vanda. To hand over the token of appreciation to our chairpersons, Professor Vasanthi Pinto and Dr. Dominda Herat, I would like to invite Dr. Siddharshi Kirivattuduwa, a consultant anesthesiologist, National Hospital Kandy. Dr. Dominda Herat. Professor Vasanthi Pinto. Thank you very much, Madam, for chairing this session. You are considered as the mother of emergency medicine in Sri Lanka. Thank you, Madam. Ladies and gentlemen, up next, we have the 5th plenary lecture. To chair this session, let me cordially invite Professor Udaya Ralapanava, Professor in Medicine, University of Peradeniya, Dr. Ravi Veerakoon, Consultant Anesthesiologist, National Hospital Kandy. Over to you, sir.
Good afternoon to all of you. And we now move on to the plenary lecture on sepsis. We have an eminent speaker and exciting topic. Let me give a brief introduction of our Lady of Emergency Medicine and Anesthesia, Professor Vasanthi Pinto. She's Vasanthi Gertrude Pinto, who actually passed from Peradeniya University and got an MD in anesthesia. A special and moved on to the UK, got the fellowship in anesthesia, and then the fellowship and the Ireland exam, and got board certified in 2005, and been a consultant in anesthesia and critical care for almost 15 years now. And currently Dean of the Faculty of Medicine at Peradeniya. What could I say about her? Loads of things. There are loads of papers that I have been given, but I'm not going to go through all of these. But there are some special things that needs to be told about her. She's, someone said she's the mother of emergency medicine. She's the mother, grandmother, and the bride of emergency medicine, I think. So great appreciation to her to have pulled this field up from the doldrums and brought it into a field that is exceptionally useful in this country. And on the other part, making the Peradeniya University as a teaching center for anesthesia, which didn't happen for ages. And today it's a center of excellence. We bring out so many registrars and senior registrars coming out from Peradeniya because of the initiative given by her. Going back to her credentials, what she has achieved over the last 15 years or 20 as a consultant, exceptional academic career. She got the gold medal in anesthetics at the MD Part 2. A unique feat of having the free paper Ganeshamurthy Award for 7 consecutive times. Being the fellow of the Royal College of Ireland in the first 3 in the world to get a prize is another great feat. She has got the National Award, the Presidential Award in 2019 for research. So loads and loads. She has 2 orations to back her, the B.S. Pereira oration and the SLMA oration. So lots of things, and I'm not going to talk more about her because everyone knows who she is. Moreover, the lecture that she's going to deliver, new sepsis guidelines, why did they need to be changed? And this is a person who has actually lived with sepsis from the day she has been a doctor, figured out the guidelines, saw to the response to treatment, whether they were good or bad, and were in the making of the guidelines in the country. So we have a great presenter with loads of knowledge to deliver this lecture. And to get some points on me, just to pass on to say that she was my first registrar 20 years ago. So at least to pick up something for myself. Thank you. Over to you, Vasan.
Thank you, Ravi, sir, for the lovely introduction. Good afternoon, ladies and gentlemen. Okay. I was entrusted by the KSM to talk to you about a current topic, and I've selected this topic, and thanks to the KSM and the organizing committee for inviting me for this plenary lecture. The new Surviving Sepsis Campaign guideline, we all know it's just out last year, and why did they need to be changed? Sepsis, as we all know, or septic shock, need to be attended in emergency department ICU or any other acute care settings, and you just heard and witnessed how important the emergency department even on this topic. But very often we hear this, when you have laid down guidelines, we hear to say, or listen, this approach will harm my patient. Even though they said it in black and white, it will harm my patient. Or somebody might come and say, my patient has diabetes, my patient has heart failure, and therefore this is not going to be applicable. This is the problem with the stiffness between the population and the precision-based medicine approaches, commonly spoken about the guidelines. So the scope of the SSC or the Surviving Sepsis Campaign guidelines is to aim was obviously to provide the evidence-based recommendations, and the guidelines provide a systematic approach to patient evaluation and treatment decisions. And the target users for this guideline is clinicians who are managing the adult patients in sepsis or septic shock in the emergency department, ICU, or any other acute care setting. And if you just move to the timeline of the Surviving Sepsis Campaign timelines, guidelines, they started by saying 2002, when Dr. Veerakun was also probably a registrar, I believe. And it was told Declaration Barcelona. And then from there, if you just see the timeline, every 4 years' time, there was a new guideline in 2004. Even though they meet in every year, or rather meeting once in every 2 years to renew it, as guidelines, it was out 4 yearly. So in 2004 and then 2005, we released the first set of performance improvement bundles. And in 2008 guideline, 12, 16, which was popularly known as Sepsis 3 guideline. And in 2018, our one was very hard, spoken about very well. And 2020, the SSC released the SSC COVID-19 guideline. And here we are in 2021 guideline, even though the timeline was supposed to be 2020, obviously for reasons we all know, it was only released in 2021. But having said that, the stiffness between the precision-making guidelines, many discussions went on, so many petitions, so many discussions to say whether they should retire from the Surviving Sepsis guidelines. But the generic issues raised in controversies were the lack of appreciation for evidence-based medicine approaches, which is sometimes around the corner, and the general confusion between the guidelines and the performance improvement bundles, because these two, some people felt is not tallying to each other. And of course, the lack of diversity in the panel. Why do I say that? If you just take the development process of a guideline, what they do, they meet as panel constituents, and then the evaluation of the evidence, and they develop the recommendations and the completion of the guideline. So a common question, or the question today, is what is the difference in 2021 guideline then? Of course, one such is the greater emphasis on panel diversity by the gender, the geographic, and the economic. If I just show you, this is how the panel was comprised of. As you can see, they have subject matter experts, society representatives, methodologists, and lay members. And I love to see this gender balance, which is male and female. I simply believe it should be upside down. And then the geography, of course. And again, just note, Asia has contributed, Africa has contributed, Middle East contributed. So it's not only Europe or North America or America, it's right around the country. So this is one of the big difference in 2021 guideline. And when they prioritize the questions, the systematic approach was selected to prioritize the topics for the guidelines by incorporating the practical variability based on the international surveys results and the expert inputs which they have collected, and the inclusions in previous restatements of the guidelines, which we call evidence gaps. So all these were put in to prioritize the questions. And of course, the evaluation of the evidence was done by a survey of the current practice, development of questions, prioritize the outcomes, literature search, systematic reviews, meta-analyze, development of evidence profiles, grading of evidence, and all such things. If I just show you the identification of the practice variations and uncertainty, they question almost everything you and me are having by now. as if that I started off telling, I could have done better with this, my patient who is having heart failure, if not this guideline. I should have done better with diabetes who are having, my patient having diabetes, having this infection, if not this guideline. So they went on to ask almost all this, like what criteria do you use to determine an adult patient? What is your initial crystalloid? What is the solution you want and what time you are going to give? What are the strategies of using albumin in your practice? What mean pressure are you going to target in? What vasopressor will you use? And do you use dobutamine? Do you use antibiotics in what way? And what is your empiric choice? What, do you use procalcitonin? Do you use corticosteroids? What dose and what level? Aren't these the questions you and me had when we had the guideline? So the rigorous management of conflict of interest need has already looked into, and the completion of evidence to decision framework, which is the normality of making a guideline, and grading and drafting of recommendation and the consensus of agreements were made. And the Surviving Sepsis Campaign International Guidelines for the Management of Sepsis and Septic Shock was released in October 2021. And we traditionally target the guideline towards the high and upper middle income countries, you and me, we all know. And in 2021 guideline, particularly, it was focused on the ensuring the LMIC or the low middle income country interest. So that is something that is different in this guideline. And also they touch on the increased emphasis on improving the care after discharge from the ICU as well. And we all know the strength of recommendation because even though we think we know, are we using it to manage our patients? So when you say strength of recommendations, there are two major ones we talk about. What is being told as strong recommendations and what is being told as conditional or weak recommendation. Of course, we have three stakeholders, the patients, the clinicians, and for the policymakers. So don't forget about it. It's not only clinicians, the patient, the clinician, and the policymakers. And if I just say the strong recommendations about the patients, in that situation, most patients would want the recommended course of action and only a small proportion would not. That is what is called the strong recommendation on the patient's point of view. And for the clinician's point of view, when you say strong recommendation, most patients that you treat should receive the recommended course of action. And for the policymakers, of course, this, if you say strong recommendation, that can be adapted as a policy in most situations. If somebody to talk about the conditional or the weak recommendation, and for the patients, it is majority of patients would want the suggested course of action, but many would not. You need to be careful on wording. And for clinicians, you are free. Different choices are likely to be appropriate in different patients. That is what is called the weak recommendation. And for policymakers, policy is like to be variable in different situations. So you don't forget about it. When you read a paper, when it says the recommendations, just don't read it. Read with this notation in your mind. So in 2021 guideline also has strong recommendations and weak recommendations, and strong recommendations for, strong recommendations against, and weak in the two as well. And also they have what is called the best practice guidelines without having much evidence. It's from the practice guidelines they used to do things. And even though I'm just putting this as one slide, I'm going to go by one. So I have only taken the immediate management of surviving or rather sepsis and septic shock only. And it says use of performance improvements and programs and the screen for sepsis in acutely ill, when you have this green with two dots, is the strong recommendation. So the use of performance improvement programs and screening for sepsis is and use of standard operating procedures for treatment are very strong recommendations we should do. And are we doing it? Yes. Use what we meant by performance improvement programs are the education, the screening, the measurement of bundle performance outcomes, checking outcomes and action outcomes, things like that. So you need to do that for sure. And we have taken it as a medical emergency still, and we tend to tell them start the treatment and resuscitation immediately, even though it is a best practice, it is also in line. Identifying sepsis early for timely intervention is definitely a need, because we need to apply the screening tools, in other words, in the EDs and the wards and the ICUs. And of course, we know many scores behind this, designed to promote the early identification. They are given beautiful names, QSOFA, SIRS, like systemic inflammatory response syndromes, and NEWS, like national early warning scores, and MUSE, say, modified early warning scores, and many, I'm sure, if we all remember, chairpersons, if you all remember in your career, we have heard all these words coming in the guidelines, and the results but have been inconsistent as to its usefulness. We all know in 2016 guideline in surviving sepsis 3, this fashionable word QSOFA came up, and that to be used as a screening tool. Is it still valid? Can we use the QSOFA as a screening tool for sepsis? Although it could be applied as a diagnostic technique to understand the condition, it is not useful as a screening tool. Remember that. So we tend to give this as like a better to all the medical students. Remember to talk about the screening tool QSOFA. If you don't say QSOFA, I will or we will fail you. So no more, ladies and gentlemen, you can be spoken about the QSOFA score. Come and sit. And the other standard techniques like SIRS, NEWS, MUSE, probably better in terms of sensitivity and specificity profiles. Haven't you thought about this, Nandana, when we were doing ICUs? Don't you think the SIRS is better? How many times you have asked that from us? How many times we have thought about it? So they all have found it out. Sepsis screening, like all these things, may be better. But given the poor sensitivity of the QSOFA, the strong recommendation is against the use of QSOFA only as a screening tool. Remember that. So this is new. Neither SIRS, NEWS, MUSE, or no QSOFA are ideal screening tools. This was found in 2020. Can you see? So many literature had come out on this. This is one of these example. This is why collecting all these evidences have made this guideline change this time. So we all know about the hour one bundle. We have been telling, look here, you have to manage the patients in the first hour. We call it an hour one bundle. That includes early identification, use of lactate, doing the cultures, take all the cultures, start antibiotics and fluids and vasopressors to keep the blood pressure above 65. This is your hour one bundle. If you walk to your wards, all the wards are now being, there's a hanging poster about the hour one bundle. Unless you have not put your schedule or nurses roster on top, it must have been there in your wards. But is it a time to change this? What about the hour one bundle? Let's talk about one by one. Measure blood lactate. Yes, for adults suspected of having sepsis, the suggestion to measure the blood lactate early and repeat measurements might give a prognostic value. But however, lactate alone is neither sensitive nor specific enough to be used to diagnose sepsis on its own. So you've got to be very careful when you say when you use lactate to diagnose this devastating disease. You can use it maybe as a prognostic tool. But there is a weak recommendation also favoring the use of serum lactate as an adjunctive test to modify the probability of sepsis in suspected but not confirmed sepsis. What about the fluids? Yes, resuscitation should begin immediately. No doubt we are all held to that, salute to this. But what's the volume and what's the fluid? The previous guidelines said use of 30 ml per kilogram of IV fluid, which should be given within the first hour. It never said for how long. How many times when we do the ward rounds, the registrars or maybe the house officers come and ask, during what time do you want me to give this fluid? And we say, go for the dynamic measures, you check the blood pressures, you go by the dynamic parameters. But this guideline in 2021 very clearly says, at least for the, if you need, you might have to give it faster, but that has to be for the first 3 hours of resuscitation. And they too recommend, just like the previous one, the use of crystalloids as the first line of resuscitation. They didn't specify with the last guideline which crystalloid. they mostly given, we all know we are having the normal saline in our backpack to give it at any time. But this guideline suggested the use of balanced crystalloids instead of normal saline. By the balanced crystalloids means Hartmann's or the sterofundings, which you have acetate instead of bicarbonate. So it's a time for us to give this message to the government to have the balanced solution stored in the wards because it's in the guideline. And they too suggest the albumin in patients who receive large volumes of crystalloid over the use of crystalloids alone. If you need a large volume, it's better to go for albumin. Okay, so then resuscitation targets. So what's the target? And this is also one such paper I'm going to show you. They did have evidence. One of these studies, I just picked this only one, and they were using in the resource limited regions more than 15% of the increase in pulse pressure. That could indicate a good outcome. Like that, there were so many reports coming from the lower middle income countries, and they have taken all these things in action. All of you might remember yourself or your trainers, when they walk to see patients, how do we know the adequate perfusion? We touch the patient. I always say, touch the patient, gives so many, touching gives you so many inputs to your management, aren't we? So your simple capillary refill time has given us so much of validity by this guideline. It suggests using this capillary refill time to guide the resuscitation as an adjunct to other measures of perfusion. So students, don't be surprised if this may be your passing or failing point at the exam. Don't think it's so minor. It is an important tool that we use to manage patients. And this is new to the guideline. And again, some of the studies like this Andromeda shock study and all these things, we're talking about the capillary refill time. And it is not new on the point of the sepsis, but putting into the guideline, it is new. What about the antimicrobials? We all know, we said fastest as much as possible use the antibiotic. Just get the empirical antimicrobial and use it. Do some cultures and use. That's what we were told. Is it true? Confirmed high likelihood of sepsis patients who are having a potential shock, administer antimicrobial immediately within 1 hour, again is changed. Why and how? We need to take the possibilities of the patient who we are wondering or rather managing about, whether the patient is easily identifiable with shock or there can be sepsis query but no shock. So the situation is changed. And the patient may be easily identifiable with shock and a definite evidence of sepsis could be possible with evidence of infection. In both these situations, you need to administer antimicrobials immediately, just like your previous guideline, within 1 hour of recognition. True. But if there is no shock, but if definite evidence of sepsis is there, again, they come to the same basket, administer antimicrobials immediately, ideally within 1 hour. But if sepsis is only possible, no shock, sepsis is possible, rapid assessment of infectious or non-infectious etiologies could be there. And administer antimicrobial has moved from the 1 year to the 1 hour to the 3 hour if concerns of infection persist only. This is also new from the previous. And for adults who are with low likelihood of infection and without shock, suggests differing the antimicrobials while continuing to closely monitor the patients. We all know antimicrobial resistance has become the worldwide problem to us. You need to have roadblocks like this anyway. Diagnosis of infection, because there is no gold standard test to diagnose sepsis in a patient with organ dysfunction at the bedside, cannot have a differential diagnosis of sepsis alone. And suspected sepsis but unconfirmed infection, recommend continuously re-evaluating and searching for alternative diagnoses. He could be having a heart failure, he could be having something else to drop his pressure, and discontinue the empiric antimicrobial if an alternative cause strongly suspected. Don't load him on with so many antibiotics if they come out, your evaluations come out with a different cause. Procalcitonin, we all know that we use it so freely. For suspected sepsis or septic shock, the guidelines suggest against using procalcitonin plus clinical evaluation to decide when to start antimicrobials as compared to clinical evaluation alone. So trust on your clinical evaluation more. And high-risk patients who are having fungal infections, if they are in a high risk of fungal infections, the guidelines suggest using empiric antifungal therapy over no antifungal therapy. And in this elite audience, as well as the chairpersons, we have managed sepsis patients a lot. How many instances you had to use the antifungals? You wait the antifungal to grow. When you see the antifungal is growing and the patient is really bad, you start antifungal. Now that has been changed in this guideline. If your patient is having a high risk of antifungals like immunocompromise and things like that, fungal infection, they suggest empiric use of antifungal as well. And if low risk of fungal infection, they suggest against the empiric use of antifungal therapy. Of course, please use your microbiologist expert knowledge on this. They were the cream to diagnose this. They will be definitely helping you, and they will be happy to know the new guideline will save them of getting the antimicrobial resistance unnecessarily. What about the vasopressors? So many discussions, so many arguments, and so many debates are going on the use of vasopressors and initial targeted mean arterial pressure. And the previous SSC guidelines targeted the mean pressure greater than 65. They never said how great, 65, 90, 95, 100. So we keep on adding the vasopressors just to keep it up. And we never said what's the target of it. So the target mean pressure of 65 or high mean pressure targets never spoken about. But we all know just by adding vasopressors, trying to achieve a higher blood pressure, the patient might end up of having atrial fibrillation, everything round the clock, and you might lose the patient. So use norepinephrine as a first line, as we all do, agent over the other vasopressors. And if CVP or the central venous access is not available, consider initiating it peripherally and don't delay it because no CVP. And consider the invasive monitoring of arterial blood pressure. And the patients who are having septic shock on norepinephrine or NORAD with inadequate mean pressure, consider adding vasopressin instead of escalating the dose of Noref, which we knew. And for septic shock and inadequate mean pressure, having the NORAD and vasopressin, add adrenaline or epinephrine as well. And if the cardiac dysfunction is very evident and persistent hypoperfusion, even with fluid volumes that you have given adequate quota, consider using or adding dobutamine to switching to adrenaline if the patient is not still on. And in this guideline, they give a very free ticket to you, or rather pass to you, to use the vasopressors peripherally if you are taking time to get a CVP line, not delaying the drug. Because we all know CVP access can be time consuming, requires specialized equipment, training, and all sort of things. So you are allowed to use the vasopressors without even having a CVP. But remember, when you use vasopressin peripherally, it should be administered only for a short period of time and into a vein very proximal to the antecubital fossa. And no evidence to support the superiority of dobutamine over adrenaline, remember that. And the next is to implement the source control as soon as medically practicable. So here we are, relying on your radiologist to remove the focus, maybe ultrasonically or imaging and non-invasive techniques, or your surgeons to remove the focus, so something to be done. In 2016 guideline, this is not spoken about that much. Now they have given another high priority to this. So what about the upper one bundle? Ladies and gentlemen, still the factors which is in the upper one bundle is there. Even though having some limitations, we are not going to take, or they did not take the other one bundle out, but they have some limitations of the usage. Will that finish the question? We all know sepsis is a heterogeneous condition and not all interventions will work in all patients. Accurate markers of the sepsis response are not yet available. And this selection process is not straightforward. Although the type of microorganisms is important, even though we diagnose in our antibiotic choices, and some differences in host responses to different microorganisms may exist. I'm sure if microbiologists are in this audience, they might agree to this. And the patient's clinical phenotype can be different based on clinical characteristics and organ dysfunction patterns. And outcomes and measures of host response varied according to the phenotype. So can we go just like this, having guidelines? I was searching for a picture to fix it into this dilemma, and this is the closest I could get. Don't you think it is like this? The protocol, policies, and guidelines, even though use evidences to find the best treatment, may lead to homogeneous care. And this actually offers a framework when basic experts are lacking. With so much variability and complexity, treating a condition like sepsis requires a personalized approach to care and need to adopt a more individualized approach to care. And this is not only you and me. This is being said by world experts, and few of them, Jane Louis Vincent and Mervyn Singer, are the key pillars of the sepsis discussions over years. And their paper or the theme on equilibrating SSC guidelines with individualized care has brought up to the limelight. One size does not fit for all. So the equilibrating SSC guidelines with individualized care will advocate the clinicians to move from a mass approach to a more logical approach tailored to specific patients. Consider the clinical implications of the underlying disease, chronic health status, and physiological results. And remember, this one size does not fit for all concept all the time. And we need a more loose structure, and you need to think physiologically. Balancing the SSC guidelines with individualized care is the word now from here downwards I'm going to use for this team. And they recommend individualizing the initial fluid resuscitation. No single formula can be applied to all patients as fluid requirements vary substantially. Recommended individualizing the type of intravenous fluid. Recommend the monitoring of chloride levels of if saline solutions are administered. You don't jump into the balance, you can use the normal saline. The problem is with the chloride, you can check the chloride. Measures to guide the fluid resuscitation, and they recommend our old thinking of individualized fluid using the dynamic challenges like pulse pressure variation or stroke volume variations and so on. And you should recommend a multimodal approach to assist the tissue perfusion, including the mental status, urine output, peripheral perfusion, and blood lactate levels, taking into consideration the physiological reserve of the patient. Living with this sepsis with the patients, you all know the importance of all these very clinically obvious parameters. And they recommend the individualize the blood pressure as well, because 65 may be too high for some patients. So you individualize it. The optimum level may be higher in patients with history of hypertension, atherosclerosis or CKD, or lower in younger patients without previous vascular problems, in those with chronically low arterial blood pressures. And you are jumping them up to 65 might itself will jeopardize the patient. So you need to individualize. They have recommended to individualize the initiation of vasopressor therapy, of course, and the fluid. They are talking about two things, like preloading may be considered in less severe cases, but co-loading to go in parallel to vasopressors should be preferred in case of life-threatening hypertension or low diastolic arterial pressure. So they are more a little bit onto the 2016 guideline. If I take other therapies now, here on the two schools of thoughts I'm going to take at once. Should we use steroids? Should we use corticosteroids? Something that over the years debated on sepsis is one such is steroids, because then when they analyzed the meta-analysis, they found most of the data suggested to use the steroids on this arrow says, it's from the forest graph, and the meta-analysis favors the use of steroids. And when an ongoing requirement for vasopressor therapy is there, suggests using IV corticosteroids. But when are we going to use it? Is it a blanket statement? No. So when to start corticosteroids? In 2016, they did not recommend if adequate fluid resuscitation and vasopressor therapy were able to restore the hemodynamic stability, if you remember. But in here, they say it is suggested, this is a common guideline, SSC guideline, suggested that it is commenced at a dose of norepinephrine or epinephrine if it is going more than 0.25 mics per kilogram per minute, at least 4 hours after initiation. Then you go for steroids. And the dose, as we all know, is 200 milligram per day, which is a low dose. And you can go for 50 milligram IV 6 hourly. And the optimum dose, timing, initiation, duration, all remains uncertain. And the 3 trials, which we all know, adrenal, Vanish approaches, all these use different patients, groups, and durations. And we are still not very sure about what we do, but at least they have given this remark. And that is the upgrade from the weak recommendation. So here you go, use the steroids, but sparingly. And in the individualized care team also recommended to use it in an individualized manner, of course, certainly. Immunoglobulins for sepsis or septic shock suggest against the use of intravenous immunoglobulin because patients may have evidence of hyperinflammation or an immunosuppression. So you don't know which quality, which category the patient is. If you're using this interesting and very important weapon wrongly, you are making the patient worse. So it suggests against the use of it. And also its cost limits the feasibility in Sri Lanka. And for adults with sepsis or septic shock, they recommend initiating insulin therapy, and the level is 180 and 144. We all remember, you all agree. They didn't give the lower mark. We thought it's 110. We thought it many. Now it is well said, 144 to 180. And the guideline with the individualized care, they recommend involving the senior colleagues and consultants, especially since guidelines are mostly useful for non-experts in settings of the house officers. And the teamwork, communication, and multidisciplinary teams are essential aspects. And one of the most principal recommendation is to seek for guidance from other colleagues. And that is by MTT and giving the credibility to all the other parties whom you want to manage sepsis, like microbiologists, hematologists, and all physicians, everybody. And the individualizing ICU admissions, the timing, the recommended individualizing timing also, and they should ideally be within minutes, but we all know the time limit cannot be applicable to all the patients, and it may be influenced by the level of care available in the ward, the availability of the ICU, the physical status of the patient. So the individualizing team won on this debate. And the goals of care, I mean, you just heard an interesting topic on ethics, and we need to discuss the goals of care and prognosis with patients and families over no such discussion. And they suggest addressing the goals of care early, within 72 hours of your patients being admitted to the hospital. However, in our country, we do know that we have limitations of ICU beds, it might change. And for adult survivors of sepsis or septic shock, recommend the assessment and follow-up for physical, cognitive, and emotional problems after hospital discharge. I've been trying to organize a post-ICU clinic for a long time now. And we need to improve this aspect with clinics, discussion groups, etc. And what to individualize, we have been talking about it, and it is all said. And they said 20 things to individualize the care, which I'm not going to go in, which included to the discussion, and how to analyze the progress. You should not forget, you need to collect the data. We just saw the Asia being there. Did we see Sri Lanka being there? No, because we don't have data. We don't collect data as to fit into this high quality comparative data analysis for the purpose of quality improvement at all levels, like ICNAC and ICU surveillance systems. So the KSM president is here. These are the things we should do, right? Okay, organizing these systems of collecting data and giving it to the high quality data to the world. We are sitting on data. Aren't we doing all these things without having it on the papers? What if we also had given the evidences to them? We are missing the bus. Not only that, we need to take this message to the grassroots level. Otherwise, no point of knowing all these it needs to be taken very quick look. The training programs from the colleges covering the entire country for all the sectors, healthcare workers, sepsis screening, all these are happening. Government is, and we have called a month, we discuss about it, papers, TVs, everywhere. And in Sri Lanka, and Ganesha and Indika is here, the emergency departments are flooded with patients like that, and how to apply your bundles is needed to be spoken about, triaging, how to put in all these things. And in the wards, the Muse course is used in general. And then in Sri Lankan setup, what to do, sepsis standard operating procedures, bundles need to be taught, where Siddharshi and all my other colleagues are being involved so much of doing it, and early identification. Measuring the blood lactate, we love not to have the blood lactate because in Sri Lankan setting, we don't have sometimes these things. So we love the new changes in the guideline, hats off to the guideline. And then the optimize the ED setups. We have optimized the ED wards. We have improved the specialty and the administration of the guidelines in the higher levels. We have improved, and so many things being done and can be done. And we need to advise the authorities to keep what we need, like RRT facilities and things like that online. And about the mean blood pressure targets, again, we have used so many measures to correct this. And the ICU bed availability in Sri Lanka is, we just still have 720 rather ICU beds. Before the COVID, we have 615. We just have improved to this. When I say ICU bed, it includes all the things like facilities of monitoring and everything, not just bed. So we are there. So it's inadequate. Ultrasound machines, everything, we are still there, and we need to move forward. And anyway, things like capillary refill time and all we are using. Even our national guidelines on dengue, we love to have this. So we are there somewhere. Antimicrobials, of course, we don't have any buffer stocks in Sri Lanka. So when they say you can move for another 3 hours to give it, we have time to get the stocks here. So in other words, I think this guideline is made for Sri Lanka because we are in that zone. We don't have sometimes, but sparingly, use intelligently, applying the guidelines in Sri Lankan setup is easy. And starting off vasopressors peripherally, how many times? If I just ask you all to hands up, most of you, almost all of you would have stood your hands up to say, yes, we have used it peripherally. How many times we do? Have we ever secured it by a guideline? No, now you are. And immunoglobulins, we all know it's so expensive. So when somebody comes and say it's not in the guideline, we will not go through it. Procalcitonin, highly costly thing we are not using. And the ICU system in Sri Lanka is a semi-open system with multidisciplinary approach. We welcome all of you inside from that door, and we encourage MDT, and that's what it should be. And the recommending the goals of care, that's what I told you. We still need to improve this aspect with clinics and discussion groups and all these things. And ladies and gentlemen, yes, we can take it to the grassroots level. If we take it properly to the grassroots level, you can bloom the grassroots as well. Also, Chairman sirs, I always have this thing in my mind when I read the guidelines back and forth and back, and we all agree, you will all agree to me, are we moving backwards? Probably looks like. We started with SIRS and we moved, we came to Q-SOFA, now we go back. We start with corticosteroids, we say move, we go back. We start with normal saline, move, we go back. Are we going backwards? I'm not very sure whether one day we will end up with 2004 guideline again. Thank you very much.
Thank you very much, Madam, for your informative lecture. And we have running behind the time. So anyway, we can allow 1 or 2 questions to be asked in this forum. Madam, 1 question from me. And always we encourage the clinical assessment of the patient and clinical judgment as a main parameter of the response to treatment. And this guideline talk against procalcitonin management of sepsis. Is that correct?
I couldn't get your. So we go by the clinical assessment and we don't.
This guideline talk against the procalcitonin.
Yeah, they say not to use it to diagnose sepsis. That is completely out. Even in 2016 guidelines is very clearly said not to use it to diagnose. Probably for the antibiotic stewardship, you can use procalcitonin and to assess the patient's improvement, but don't waste your money to diagnose it. That's what they say. this guideline says. Not to
Can we-
use it
can
to
we use-
diagnose.
Can you use to monitor the patient?
Yeah, you can use it. But sometimes, we say procalcitonin not diagnose karan and all. That's what they say. I mean,
Thank
it is basically very nicely looked into the low and the middle income countries. I'm simply wish for the next guideline committee Sri Lanka to participate one day with our evidence. If you do it properly, if you collect evidence, if you do some studies and publish and go to the meta-analysis of these studies, in no time, Sri Lanka also will be a participant of this guideline committee. Thank you.
Next person task is to hand over the token of appreciation, the certificate to our presenter. And I would like to invite Dr. Harith Timalratne to hand over this certificate to Professor Vasanthi Pinto.
So I take it as an honor to get it from you.
Thank you, Madam, again for your participation.
Settled. Thank you very much, sir.
To present tokens of appreciation to chairpersons, let me cordially invite Professor Manjula Attikala, President of Kandy Society of Medicine. Professor Derana Pranava. Dr. Ravi Veerakon. Thank you, sir. As we conclude the plenary lecture, we mark the end of the morning session of second day of 44th annual academic session of Kandy Society of Medicine. There are few announcements to be made. Lunch will be available at the fourth floor. Poster presentation will take place in Hall B during lunch. Two important symposium on a very timely topics will start following lunch at Hall A and B in 45 minutes. You are kindly requested to return on time to keep the program running smoothly. You can also visit the trade stores located in Hall B during lunch. You are kindly requested to stay with us until 3 p.m. to witness a very interesting medical debate. Thank you.
A very good afternoon to all of you. Welcome back. We are to start the Symposium 11, that is on image-guided therapeutic interventions for the enhanced patient care. To chair this session, since we are quite behind our original schedule, without further ado, I would like to invite our chairpersons onto the stage, Professor K.B. Galkatia and Dr. Chaturanga Kapetiagama.
Thank you. Good afternoon and welcome for this symposium number 11, image-guided therapeutic interventions for the enhanced patient care. So I think Chaturanga and myself as two surgeons, we are going to sit and listen to how you all are going to replace us. But anyway, without any doubt for better patient care, there's no doubt about that. And let me ask Chaturanga to introduce the first speaker.
Our first speaker in this symposium 11 is Dr. Lekham Gay, and she's an intervention radiologist in National Hospital Colombo, and she has a lot of experience in this area, and he has trained many intervention radiologists, and some of the trainees are also here. I think it's very glad to, she's a person from Kandy and not a stranger to Kandy. Welcome, madam, and your talk is on endovascular treatment strategies for intracranial aneurysms, the timely topic. Over to you, madam.
Thank you, Dr. Chaturanga, for those kind words of introduction. And I don't know, generally, nearly always I get to talk on post-lunch sessions. It's nice to be back in Kandy and be in the KSM sessions. Now, over the next 20 minutes, I'll like to talk about a brief outline about the cerebral aneurysms, why we have to treat those, and different treatment methods available by endovascular means and the outcome. Now, etiology of cerebral aneurysms vary, like with all other aneurysms. There can be endothelial damage, and some aneurysms arise at the branching points of arteries, and there can be damage to the vessel wall or weakness of vessel wall. Some are associated with connective tissue disorders. Some aneurysms are related to infections. There can be post-traumatic aneurysms as well. By morphological classification, there can be saccular aneurysms, broadly divided into two, and fusiform aneurysms. Now, the most dreaded presentation of cerebral aneurysms is rupture, bleeding, and with subarachnoid hemorrhage. And like here. And some of these patients can present with pressure symptoms. This is one of our patients who had a very large aneurysm with a wall thrombus, and there is you can see pressure here, and this is the appearance of the aneurysm as we were trying to embolize that. And some of the aneurysms can be incidental, found when imaged for
related or unrelated symptoms. The aim of the aneurysm treatment is we have to remove the aneurysm from the active circulation. Now, why these need to be treated? Because as I said, the rupture of these can have, disastrous consequences. Do we have to treat only the ruptured aneurysms? What about the unruptured aneurysms incidentally found? And the debate is there for treatment of ruptured and unruptured aneurysms. Traditionally, the treatment of aneurysm started with surgical clipping, and then with the development of endovascular treatment, I think we have, if the facilities are available, if we have all the necessary hardware and devices, most of the aneurysms can be treated now with endovascular treatment. But I have to say here that still surgery is a good option for some of the aneurysms in brain. When we plan the treatment method, the aneurysm morphology plays a significant role, and the age of the patient and the associated comorbid conditions. And naturally, obviously the skill of the operator, and more the patients, they learn about these things and they compare the different treatment methods, and patient also sometimes they wish them to be treated by endovascular means or by surgery. And there are relative contraindications. Now, however much attractive the aneurysm is for endovascular treatment, if we can't reach it, if the vascular access is difficult or unfavorable, we can't treat it. And so are allergy to contrast media and coagulopathy. These are all relative contraindications. Now, as I said, the aneurysm morphology, the neck, whether if it's a narrow neck, we can do simple coiling. If it's wide neck, like here, then when we try to coil the aneurysm sac, the coils can prolapse into the parent vessel. So we need to prevent that. So therefore, we use other devices to prevent that. And sometimes there can be branches rising from the aneurysm sac, and the state of the parent artery and anatomical variants sometimes play an important important role in decision making. Now, this is a narrow neck aneurysm rising from the posterior communicating artery. This is amenable for simple coiling, standard coiling, whereas in comparison, large aneurysm into which a length of the ICA, internal carotid artery, is incorporated, this giant aneurysm cannot be treated in standard way of coiling. And this is another example of aneurysm with two lobes and a branch rising from the aneurysm sac. The most commonly used embolic materials are detachable coils. These are detachable either electrically or mechanically. And then the newly introduced devices are flow diverter stents and other devices like whip devices. Now, I have already touched those. The simple coiling, where if the aneurysm neck is favorable, we advance a microcatheter into the this doesn't work. All right, it's working. So we have put a microcatheter into the aneurysm sac, and through which now you can see the coil is extruding into the sac, and under fluoroscopy, appropriately the sac is filled with coils, and then each and every coil is detached. And this is a PCOM artery aneurysm, which I have shown earlier. this is the coil mass that is seen. At the end of the coiling, the aneurysm sac is eliminated from the vascular tree, but you will see there is continuation and normal opacification of the posterior cerebral artery. That is the optimum, goal that we have achieved. Balloon assisted coiling, when the aneurysm neck is wide like that, to prevent aneurysm, the coils dropping back into the parent circulation, and to keep the coil mass here, we insert a balloon across the neck, and while we are inserting and manipulating coils, deploying coils in the sac, we insert the balloon, and at the end of it, the balloon is withdrawn from the circulation. This aneurysm, wide neck aneurysm arising from the left lateral wall of the distal basilar artery, it's rising at the PCA SCA junction. The aneurysm is wide neck. The left left SCA is rising from the aneurysm neck. And we have here, this is the wire of the balloon catheter that we have parked across the aneurysm neck. These two dots denote the balloon, and with the use of another catheter, microcatheter, we have filled the coils into the sac, and this is the end result. The aneurysm is occluded, and the left PCA, SCA, the basilar artery, all are patent. Now, when sometimes we can't take the balloon out. We have to use stent assisted coiling, especially if we have to complete the coiling without keeping a residual neck. This patient, 38-year-old man with subarachnoid hemorrhage, CT angiogram, two ICA, internal carotid arteries are there. The A1 segments, this fuse to form the anterior cerebral artery, the azygous trunk of the anterior cerebral artery. This is a normal variant. That's why I initially mentioned some normal variations influence the management, and an aneurysm is arising from there. And both the bilateral pericallosal arteries and the callosomarginal arteries arise from the aneurysm sac. And the idea is to keep a stent across the one pericallosal artery and protect the neck, and through the stent there will be normal flow maintained into that pericallosal artery, and then protecting these two also we coil the aneurysm sac, and this is at the end of it. This is the stent and this is the coil mass, and this is the end result. The aneurysm is occluded, all the other branches are filling. Now, relatively new method is flow diverter stent insertion. Now, this is used mostly for large neck aneurysms and giant aneurysms, where sometimes when we do coiling, the aneurysms can regrow. Here what happens is a special stent, a flow diverter stent is placed across the aneurysm neck, which redirects the flow along the parent artery, and gradually the aneurysm sac, the flow inside the sac gets sort of stasis, and there will be thrombosis. With time, the stent surface acts as a scaffolding for the neo-endothelialization to take place. The image quality is not very clear. I apologize for that. This again, a flow divert insertion we did, large giant aneurysm arising from the ophthalmic segment of the internal carotid artery. We have put some loose coils into that, and this is the flow diverter in position. And you already see there's a level in the level of contrast in the aneurysm sac. Stasis is setting in, and it may not be, maybe even only the radiologist can see this. There is that is the flow diverter, and this is the coil mass. Now, With simple coiling, balloon assisted coiling, when we fill the aneurysm sac with coils, there will be immediate blockage of the aneurysm sac, but with flow diverters, it doesn't happen. Sometimes it may take months, 3 months, about 3 months for the complete occlusion of the aneurysm. This 59-year-old man, there is mainly posterior fossa, subarachnoid hemorrhage. 3D angiogram shows dissecting aneurysm in the distal vertebral artery. And now that vertebral artery, that segment is diseased, and some favor reconstruction, but both methods, I mean, we can close that also with occluding the artery with coils. That's what I have done here. There is, with coils, I have occluded the artery. But the important thing here is we should not go too much deep into the basilar artery. We have to preserve the basilar artery. This is at the end, the left vertebral artery up to pica, it's filling and distally occluded with the aneurysm. And the right vertebral run shows, I mean, fortunately, the nature has given 2 vertebral arteries, and you see that the posterior circulation is supplied by the right vertebral, and the coil mass ends here without protruding into the basilar artery. Now, this is one challenging case we had, aneurysm at the origin of the left pica artery, but you will notice that there is narrowing of the parent vessel just proximal to the aneurysm. So difficult access. So what we had to do is I went from the opposite vertebral artery from the at the origin of the basilar, directed the catheter and the guide wire into the left vertebral, and the aneurysm was approached and coiling was successfully done. And this is this uses the principle of flow disruption. This is, to my knowledge, this has not been used in Sri Lanka. It's been used in India and and in the developed world, so-called. And this is especially useful for aneurysms like at the basilar tip aneurysm, aneurysm at MCA bifurcation, or aneurysms at ICA bifurcation, where if we have to, rather than using 2 stents to protect these arteries, it is easier. And this device, the web device, is introduced into the aneurysm sac, and then it is expanded, deployed, and it is detached, and thrombosis sets in. I'll be very happy and proud to say, except this, all the other slides we had, it was all from our experiences and the work we have done at the Neurotrauma Center Angiography section. Like all treatment procedures, this coiling or treatment of endovascular treatment of aneurysms is not without complications. Aneurysms can rupture during the coiling, embolization. We keep sometimes maybe 1 or 2 microcatheters, more devices inside the vascular system, and that can lead to thromboembolic complications and vasospasm. And sometimes coils don't want to stay where they are intended to be. They tend to prolapse and sometimes migrate. This is one of the complications we had. A 62-year-old lady with intraventricular bleed and some parenchymal bleed on the right side of the cerebellum, and she had a pica aneurysm. While trying to do the advanced diagnostic catheter, while we were trying to do the diagnostic run, there was accidental inadvertent guide wire related dissection of the vertebral artery. So I had to, it was a nightmare. I had to advance the microcatheter and the wire into the pica through the diagnostic catheter, and then the coiling was done. The coiling is successfully achieved. There was this dissection, chronic dissection of the vertebral artery, and there's normal distal run in the pica. This patient attends our clinic follow-up runs. She had in the MRI a few infarcts, but the posterior circulation is maintained from the other vertebral artery. She's happy and she's quite all right. Didn't have any neurological deficit. Now, this patient, I have shown earlier the same patient's images. Now here, you will see there's a small filling defect here. That is a thrombus. And what we did was, when we detected that, advanced a microcatheter into the clot and gave absiximab intra-clot injection. And this is the post-absiximab run, and there is the clot is no longer there, and all the arteries are filling nicely, and there is good flow. And the patient recovered well, no neurological deficit. Soon after the procedure in the angiography room itself, the extubation was done, and the patient is being discharged from hospital today. And this is ophthalmic artery aneurysm. At the end of the coiling, the end of the coil prolapsed into the internal carotid artery. And I was waiting for some time, and it was stable. It didn't move further. So she didn't have any thromboembolic complications. She was put on aspirin. Anyway, she has hypertension, and for that she's on aspirin. And no problem. I mean, she went home, and she too is attending our clinic post procedure follow-up. And the patient and the family are very grateful to us. They brought us Kirivalu Alua also. And this is the a regrowth I have shown now, large acom artery aneurysm. We have coil, you notice that there is a large coil mass, but it has, the neck is filling again. So the follow-up is important, immediate follow-up as well as the long-term follow-up. The protocols vary according to the procedure you have used. And then now, for example, stent-assisted or flow diverter use needs contrast MRA, whereas for simple coiling, we can use time of flight MRA. The follow-up periods can vary from institution in institution also. It can be at 6 months, 12 months, and especially flow diverters, we follow up for 5 years, and they regularly and dutifully they attend the clinics. Now, goal of endovascular treatment, it has to be effective. The treatment has to be effective, and it has to be safe to the patient, and we must try and achieve, maintain no disability or the minimum disability. And it is our duty to make the patient and the family aware of the post-procedure care, and that there are regular follow-ups, how they have to behave. Sometimes they have to take dual antiplatelets for some time, and then we switch on to a single antiplatelet. And the most important thing is, if the patient and the family are happy, we are also happy. You will see this 17-year-old girl came, when she came, she was sort of like a log. And then see now how she is. She is from very far, but she comes for follow-up, and see how happy. All our patients are very happy. And I think during this short time limit, I was trying to share our experiences at Neurotrauma Unit, National Hospital of Sri Lanka, and the work we have done. And and I hope that this will benefit all of us. And I thank the organizing committee of Kandy Society of Medicine 2022 for giving me this opportunity to present our work and some of it. And this is all teamwork. I am so grateful to the staff at Interventional Radiology Unit Neurotrauma Center for their continuous support. And I am so thankful to the consultant anesthetist, the neuro anesthesia team, in National Hospital of Sri Lanka, I want to make a special mention about the lead consultant anesthetist, Dr. Manjula Kulratna, and her colleagues and the junior doctors. They are all excellent and they are very good. And at any time we call, I mean, when the suddenly a patient gets some problem at 6:45 in the morning, also they are there. And even in the night, we can call them. And I mean, they have saved many patients. And I am so thankful again to consultant neurosurgeons, not only in National Hospital, but the consultant neurosurgeons in Sri Lanka. We get referrals from Kandy, Badulla, Anuradhapura, LRH, Karapitiya Hospital. And a special mentioning of thanks to Dr. Kandelwal and Professor Vivek Gupta, who helped. They are from India, and they have helped me with so many advisors, and they are always open for me to get advice when I have a problem. And I am so thankful to you for your kind attention. And this is our team, and this is Professor Gupta. Thank you.
Thank you, Indra, for that excellent presentation. And actually, it's really skilled work giving life to patients and their families. And next speaker is Professor Bhadra Hivitarana. Let me introduce her, who actually doesn't need an introduction. And when I see this, Bhadra has actually been president of so many associations in Sri Lanka. One day I told Bhadra what is left over is to be president of Sri Lanka. That's the only one she has not done so far. And also, with the board of study, and she pioneered the department of anesthesia, the radiology in the faculty, and also starting the light health radiology in spite of so many obstacles, and it just trained so many graduates. And nothing I admire Bhadra is that our generation, we had no access to these minimal access techniques during our training, and after becoming consultant, we had to go through a lot of learning curves, burn out actually our lives for this, and then opening the pathway for the juniors to take on from you. Thank you, Bhadra. Without taking much time, let me invite you to did your speak.
Thank you, Galkati. Anyway, you have given me so many names. He used to say you're not an interventional radiologist, only you are an invasive radiologist, because I used to invade the half of the hospital to expand our department. So anyway, and about Indra, she took you to the sort of top of the body, the head. I'm sorry, I had to pull you down to the legs and into the veins. And always Indra and me, we have been sort of doing quite opposite things. And only thing we do is we agree to disagree. So Indra, and I am very happy when you left to Colombo, I think I was sad, but now I'm very happy. You have done a great job to this country and to the to our sort of majority poor people. Anyway, so my topic is, as you can see, endovenous interventions. And let me dedicate this lecture to this 94-year-old lady, professional from overseas. So we have expanded our services beyond the waters. So she's our 240th and the oldest patient we have managed with endovenous laser ablation and ultrasound guided form sclerotherapy. And you can see her leg as she came, and it was pouring with exudate and bags of fluid. Now this is the leg after 3 months. Isn't that rewarding? Anyway, venous pathology, you know, it may be acute as in deep venous thrombosis or maybe even pulmonary embolism. But on the other hand, it can be a chronic disease with significant morbidity with chronic venous disease. And the management strategies of venous pathology evolve rapidly because of the endovenous interventions. So these are, this is a list of endovenous interventions, but I'll be mostly dealing with the chronic venous disease. So this story of ugly, aching, pigmented and swollen legs with ulcers, chronic venous disease. So it is either due to truncal venous reflux at junctions, saphenofemoral or saphenopopliteal, or it's horizontally perforator incompetence. It may lead to venous stasis and stasis dermatitis, or these ugly legs with horrible ulcers, and even you can see the skin grafts and several interventions and badly pigmented legs. So this is the very sad story of the legs which I was sort of taken into. And any disease has a sort of categories. So when we treat them, we need some guidelines. So CAP categories categorize the chronic venous disease into 6 categories from 0 to 6, and mostly the C5 and 6 are the C5, 6 groups gets the treatment. That is agreed world over. But sometimes we do treat other patients too. So what are the current endovenous treatment strategies we have for chronic venous disease? Thermal ablation, either laser or radio frequency, or ultrasound guided form sclerotherapy. So why it has become very sort of appealing? Because it requires no operating theatre or general anesthesia. So our colleagues are very happy, surgeons and anesthetists. So we can free operating theatre resources and obviously low cost and immediate post-procedure ambulation. Patient immediately gets out of the bed and starts walking. So what is the current evidence? There are so many: American Venous Forum, NICE guidelines, Alberta guidelines. There are so many guidelines. So I selected the simplest thing which I follow in our department. So once somebody has confirmed varicose veins and truncal reflux, first thing we offer is endothermal ablation. So if endothermal ablation is unsuitable, I will tell you where it is unsuitable, and offer ultrasound guided form sclerotherapy, or if both are unsuitable, offer surgery. I'm sorry, I'll get here. If incompetent varicose tributaries are to be treated, consider treating them at the same time. So there are a lot of reviews on this subject, and there's a comprehensive review, and they have shown that endovenous laser ablation is a safe, durable treatment option, and it remains a key component of the standard of care for the treatment of chronic venous insufficiency. Then the question comes, laser or RF ablation. There are a lot of papers on this, and the one I have selected, it shows EVLA procedure may be superior, the laser to RFA, not because that is available for us, but RFA complication rate they have found less, and immobilization and patient satisfaction and time to return to daily activities much superior to RF ablation. So what do we do, and what happens in EVLA, endovenous laser ablation? This is direct thermal injury where the venous segment with truncal reflex is ablated. So it is non-thrombotic occlusion. We get all the blood in the venous segment we want to treat out of the venous segment by doing several maneuvers, and we treat the endothelium and leading the endothelial denudation and leading to collagen retraction and fibrosis. And this is the laser fiber we use. There are so many fibers, and this is the 940 nanometer wavelength fiber we are using. So this is a diagrammatic representation. The laser probe is inside the vein, and this is the heated area where there is thermal ablation, and it gets denuded and occlude the vein, and later on the fibrosis sets in. And it has been shown by several authors, and in this review, as you can see, the success rate is above 90%, and in this review, it revealed 92% success rate. Irrespective of the technique that you use, there are so many different wavelengths, different volumes and different energies, but whatever it is about 90%. So when to do and when not to do. So we need to select our patient doing a color Doppler ultrasound scan. It should be more than 500 milliseconds reflux duration, and it should be symptomatic severe. I told you C5 and C6 CAP groups, and at times we do for cosmetic reasons as well. And when not to do, that is also important, because we need to look for anatomical factors of veins. Vein has to be either should not be less than 4 millimeter or more than 9 millimeter. I have had 2 patients who failed in with dilated veins, but recently when I read, some centers, they do even to 12 and 14 millimeter veins as well. And very important, the vein should not be very close to the skin surface, should not be less than 3 millimeters. Then acute DVT, local anesthetic allergy, these common things. And this is an important scenario, peripheral arterial disease with chronic limb ischemia. We do get quite a combination of these two patients. And because after the laser ablation, we need to put the compression dressing for 1 week, because this peripheral arterial disease can get aggravated. So we need to look for that fact as well. And of course, coagulopathies for any intervention. So meticulous venous mapping is a gateway to success. So we take a lot of time, maybe once or twice. We do meticulous venous mapping, look for SFI or SPI, look for anatomy, variations, course of the great saphenous vein, short saphenous or their respective saphenous spaces, and presence of venous aneurysms and intersaphenous veins, and the diameter of the vein and the depth on the skin, as I said before, and look for deep venous pathology, either DVT, either acute or chronic, and deep venous incompetence. This is a very important area most of us forget, because sometimes the pathology may be due to the deep venous incompetence. So patient has leg swelling, and when you scan the ultrasound scan of the superficial venous system is normal. So patient, so you have to be vigilant about this. And avalvulia, that is, some people are born with this, so it is a problem. You need to look for. And you should be very well conversant with the thigh and calf perforators. And mind you, there are many unnamed muscular perforators, which gives a lot of problems, sometimes in isolation or sometimes after blocking all these common perforators, they end up, opening up these muscular perforators. So this is the technique that we adopt. Earlier on, we used to put a sheet. Now, of course, we don't. So we put the laser probe below knee axis most of the time. And top of the probe is just about 2 centimeters below the saphenous junction. And the very good landmark is a superficial epigastric vein. So we keep it about 1 centimeter below. And so this is the good tumescent injection around the vein, so much so that you don't see the venous lumen. You see only this white dot, that is the laser probe. So you should get all the blood out of the vein. And so this is ablation in progress. You can see the color, and you pull the laser probe, ablating 1 centimeter at a time. Then this is our experience. We have done so far 240 limbs with mostly long saphenous. So no general or spinal anesthesia, and all were day cases, and majority belong to C4 category. And we presented our experience in 2019 in a conference paper. And we had 99% success at that time. And we have had a couple of complications like cellulitis, superficial thrombophlebitis, but didn't have any pulmonary embolism. Yes, then I will take you to the perforate incompetence. So these people have sort of a lot of pigmentation in and around the ankle and the lower calf. So they have swelling and pain. So there's acute ulcer. And after the treatment, the ulcer heals quite within a week or so, the ulcer actually heals. So this is the perforator, which is dilated more than 3 millimeters. So this is the color Doppler. So actually this is before the reflux. So with the reflux, you can see the reversal of color flow. So this is a very suitable vein for perforator injection. So it is a minimally invasive procedure, and current recommendation for C5 and C6 groups. And it could be done for even isolated calf perforate incompetence or along with truncal venous reflux after treating with endovenous laser ablation. And this I have told already. And it has got a good venous, good outcome, which is checked on venous clinical severity score. So how to perform this? So we directly inject sclerosant into the incompetent perforate under ultrasound guidance. I think surgeons, they do inject into the superficial veins, if I am not mistaken. Most superficial portion of the perforator vein within 1 centimeter of its origin. We use a fairly small needle, 23-25, and 1.5 ml foam sclerosant, and compression for 1 week. And immediate post-treatment ambulation. I usually do the calf perforators. Usually I don't do the Boyd's and Hunter and the dots. So this is one such case. Actually, almost all our trainees have sort of mastered this technique. This is the last case we did. Actually, first year trainee did this injection. You can see we put the needle inside at the proximal end of the perforator, and we first inject saline, and once we are happy with the correct flow, then we inject the sclerosant under ultrasound guiders. Throughout the technique, we observe the flow of sclerosant. So this is our experience. Again, we presented at the same year as a conference paper. We did that time 136 cases, and 55% of them were cockatoo perforators, and I had 96 success rate. And we had few complications, but never had DVT or pulmonary embolism, which is, very well known complication, because you know the perforator is leading to the deep veins, and none got skin necrosis. So next, I will take you all through to the venous thrombosis. DVT is a life-threatening disease, a dreadful complication. The pulmonary embolism leading to, and we are doing anticoagulation. I'm posing this question: is this enough? It is efficient in reducing thrombus propagation and pulmonary embolism, but does it contribute to clot lysis, reduce post-thrombotic syndrome? No. So this has been disturbing me, actually, this post-thrombotic syndrome. I see a lot of patients coming with post-thrombotic syndrome because we are very happy. We give heparin and we treat them, stop the propagation of thrombus. But they get a lot of complications with severe morbidity, lifelong morbidity. And sadly, I think we are not addressing this problem locally. So these are the common outcomes: swollen legs forever and chronic leg ulcers. So shouldn't we have paradigm shift from just anticoagulation to thrombolysis, thrombectomy, and clot retrieval? Actually, I have not succeeded in this because of the infrastructure we have not been able to purchase so far. So what can we offer for post-thrombotic syndrome? Techniques of reducing thrombus burden, catheter-directed thrombolysis. I have done a couple of cases, catheter-directed thrombolysis, but percutaneous mechanical thrombectomy yet to do. Then techniques of assisted recanalization like venous stenting. Then thromboembolic disease, venous thromboembolic disease, the IVC filter placement to safeguard them getting pulmonary embolism. So we do it in selected patients, and availability of retrievable filters is an achievement because we used to put a lot of filters and we could not retrieve them. Now we are happy that we get retrievable filters. And indications for IVC filter placement getting more and more refined. So our hands are very tight. We can't, even if we get requests, we have to filter them and put the filters. So this is transjugular approach and this is transfemoral approach, two different patients we have put in our hospital, and these are the guidelines. So classic indications with venous thromboembolism, when there's absolute contraindication for anticoagulation or complication of anticoagulation resulting in cessation of therapy or failure of anticoagulation. Or on the other hand, you have relative indications, proximal large free-floating proximal thrombus, or massive pulmonary embolism, chronic pulmonary embolism, or poor cardiopulmonary reserve, or poor compliance for anticoagulation. And there's a separate group, even without evidence of venous thromboembolism, you can do in certain patients like trauma patients with high risk of thromboembolism, surgical procedure in a patient at high risk of thromboembolism, and medical conditions with high risk of like protein C, protein S deficiency. Yes, then another area that we treat peripheral venous malformations. So more or less same technique form sclerotherapy we do, but we use double needle technique for safety. So this was a young girl, came with very extensive calf varices, including the calf muscles. So this was the venogram, and you can see one needle is sitting there and doing the venogram. Then after that, you can see the double needles. Our second needle is also going in, because as we inject the sclerosant, we have to see that the sclerosant and the contrast is coming from out from the other needle. Then we stop it, because we never want to achieve 100% ablation or occlusion of the system. Usually we achieve about 75% at a time. Then venous stenosis and occlusions. This is very interesting condition. I think you all are aware, May-Turner syndrome. I think this is a misfit of our body. The right common iliac artery blocking the or compressing the left iliac vein. So you can see this venous stenosis there. So it has been treated with stent across the stenosed left iliac vein. You can see the beautiful flow afterwards. Then varicocele embolization, we find it very difficult to get patients for this condition, but we managed to get one patient once for a workshop. So patients with suffered little first to perform colored Doppler ultrasound, as you can see here, dilated venous channels, and there is a coil placed, and proximal to that, you can see this the glue. So this was, I mean, very successful and very easy procedure. But unfortunately, we don't get many patients. I don't know what about the others' experience. Actually, this is not my territory, but I thought I want to give a message, because this patient is a 47-year-old female, came to my casualty, I think a week before, with a severe vein of Galen venous thrombosis and straight sinus venous thrombosis. I think these venous interventions, this is the way forward. I'm quoting experience from another center. So you can see this extensive superior sagittal sinus thrombosis, as you can see in this filling defect. And after the treatment, you can see usually there is a flow wide, but you can see the very high signal in the superior sagittal sinus. Now you can see there's no signal. And so this is the DSA. So you can see the filling defect, and after the treatment, it is not there. So I think this is where we should move in venous interventions, but I will invite my colleagues, because I have decided not to touch the brain for good reasons. Thank you very much. Thank you for your attention.
Thank you very much, Madam, for that excellent lecture. And I wish you all the best for your future, your plans of expanding the services in Teaching Hospital Peradeniya and serve the community much more. And I hope whatever the achievements you want to achieve, like the cerebral veins one also before your retirement, I hope you can do it. May I invite the next speaker? Is not a stranger to us. He is Dr. Sampath Gurugahagoda. He is going to talk to us on radiological intervention in emergencies. He's a very experienced intervention radiologist, a colleague, and not only that, he's a schoolmate of mine, I mean, senior colleague. He's anytime he's available, and he's helpful in many ways saving our patients. So I'm not going to talk to you on your CV, Sampath, because you have shown your work, and that is the most important CV. It's over to you, Sampath.
Yeah, thank you, Chaturanga, for that introduction. Okay, so good evening, everybody. So my topic is radiological interventions in emergencies. It's a fairly broad topic. So with the recent advancements in imaging modalities and endovascular treatment techniques, IR has become increasingly popular and often less invasive option for treatment of a number of medical and surgical emergencies. So I thought of discussing the topic in few cases. So this for lower GI bleeding. There's a 79-year-old male recently diagnosed colon cancer, presents with sudden onset bright red blood per rectum. On arrival, he is tachycardic with blood pressure low. His extremities were cool and active hemorrhage is noted on rectal examination.
So although endoscopy remains the primary diagnostic and therapeutic modality for treatment of GI bleeding, there is an increasing role for interventional radiology, particularly in patients with refractory bleeding. Unprepared bowel or brisk bleeding may limit endoscopic visualization during colonoscopy, preventing localization of bleeding and therapeutic interventions. In these cases, angiography via CT, nuclear scintigraphy, or endovascular angiography may enable clinicians to identify the source of bleeding. Like endoscopy, endovascular angiography is both a diagnostic and therapeutic intervention and remains an effective alternative for lower GI bleed that is refractory to medical and or surgical interventions. So oral contrast should be avoided in patients who will undergo angiographic interventions, as this can limit the diagnostic ability. Endovascular access is obtained through the common femoral artery, and when a bleeding vessel is identified, arterial embolization is achieved with coils or PVA particles. Complications include bowel ischemia, non-target embolizations, arterial injury, including dissections, urenerisms, and vasospasms, which are fairly rare. So this is that patient. You can see the angiogram we have done. You can see the bleeding point here. It's a delayed picture of the same patient, and we have inserted some coils. So this is a post procedure CT where you can see the coils and the colonic mass with no further bleeding. So the summary, what happened was patient was resuscitated. His vital signs were normalized, but he continued to have bleeding. An emergency CT angiography revealed active extravasation from a branch of the superior mesenteric artery, secondary to local erosion from his colonic malignancy. After discussion with gastroenterology, colonoscopy was deferred given the early very likely of poor visualization due to ongoing bleeding. Active extravasation from the iliopolic artery was confirmed on angiography, and bleeding was stopped with coiling. The patient was ultimately discharged on hospital after 5 days for the oncology follow-up. So this is a trauma case. It's a 23-year-old male with no significant past medical history, presents after high-speed rollover motor vehicle accident. GCS was 15, heart rate 100 with blood pressure 110/80. Had some headache with abdominal pain and seatbelt sign across his abdomen and chest. So where could be the possible injuries? There are number of places, injuries we can intervene, like the liver, spleen, kidneys, and pelvic trauma. So management of abdominal pelvic trauma has advanced over the past century to favor non-operative management strategies in patients who are otherwise hemodynamically stable. The standard of care for individuals who are unsuitable and or have peritonitis remains urgent emergency laparotomy. However, non-operative strategies including angiography and embolization have emerged as important options in hemodynamically stable patients. Arterial embolization is effective in the management of hemorrhage from solid organ injuries and pelvic fractures. So if you look at the liver is one of the most commonly injured solid organs as a result of traumatic injury. Studies have demonstrated success both in terms of mortality and morbidity in non-operative management of hemodynamically stable patients with grade 3 or 4 hepatic injuries. According to East Practice Management Guidelines, angiography with embolization is a level 2 recommendation for patients who transiently respond to resuscitation. Specifically, transarterial embolization may be indicated in patients with active extravasation demonstrated on CT imaging or clinical signs of hemorrhage. Different studies have shown a high primary arterial embolization success rate ranging from 80 to 90% for hemodynamically stable patients with contrast extravasation on CT. Common complications of TAE include liver necrosis, gallbladder ischemia or necrosis, abscesses or liver failure. Some studies have demonstrated success of another important indication for TAE, TAE after emergency laparotomy with secondary hemorrhage. So this is a case with It's a CT scan of a patient with liver trauma. We can see the leak in contrast here in the liver, and the leaking sites identified in the DSA, and the sites are blocked with coils. Other injury, the other commonly injured organ is a solid organ is the spleen. Similar to liver, spleen is also one of the most commonly injured solid organs. And level 2 is guidelines suggest angiography should be considered for AST grade of greater than 3 injuries, presence of contrast blush, moderate hemoperitoneum, or evidence of ongoing splenic bleeding. Additionally, level 3 recommendations suggest use of angiography as an adjuvant to non-operative management in patients with risk of delayed bleeding and as an investigative tool for identification of vascular abnormalities. Some studies evaluating angioembolization have shown success in preserving splenic function and controlling hemorrhage. Complications of splenic embolization include major complications: splenic infarctions, abscesses, contrast-induced insufficiency, splenic cysts, and minor complications, with major complications as high as 13.6% and minor complications or 34%. While there is still debate on the advantage of splenic embolization, high success rates have been reported following these level 2 guidelines in the non-operative management of hemodynamically stable patients. So this is a case of splenic hemorrhage on the CT. You can see the hemorrhage there in the DSA with the coiling afterwards. So this is another patient with splenic contrast extravasation into the spleen due to the trauma with the successful embolization with coils. Other solid organs is the kidneys. The kidneys are commonly injured from blunt and penetrating trauma. Angioembolization has demonstrated success, specifically in renal stab wounds. Level 3 is guidelines suggest use of angioembolization in non-operative management. So further research is needed to differentiate the type of patients and injuries that would benefit most from his techniques. So this is a case of renal bleeding blocked with coils here. So the common thing is the pelvic trauma. Patients with traumatic pelvic fractures resulting in hemorrhagic shock have a high mortality rate, reaching 50% in those with open pelvic fractures. While venous hemorrhage is more common, arterial hemorrhage is more likely to lead hemorrhagic shock. Angioembolization has 34 to 100% success rate in controlling hemorrhage in patients with hemorrhagic shock secondary to pelvic trauma. According to his guidelines, angiography may be helpful in controlling arterial hemorrhage in patients with pelvic fractures who are hemodynamically unstable without any other source of bleeding. One study suggests the hematoma more than 500 milliliters may be associated with arterial injury necessitating angiography. Angioembolization most commonly occurs for the following vessels: internal iliac arteries, branches of internal iliac artery, superior gluteal artery, obturator artery, and internal pudendal artery. Depending on the injury complex, bilateral embolization of the internal iliac arteries may be required. The most common complications of angioembolization include wound breakdown, infection, gluteal muscle necrosis, and nerve injuries. So this is a case of pelvic arterial bleeding and successfully blocked with coils. So this is the same patient at the CT scan. You can see the bleeding blocked with the coils. So in our patient, after the primary and secondary surveys were completed, the patient was taken to CT. He was found to have grade 3 splenic laceration with signs of active extravasation and left side rib fractures. Underwent angioembolization and was admitted to the surgical ICU. Was monitored closely post-procedurally. His vitals and hemoglobin levels stable. Was discharged from home 4 days later and was doing well on the follow-up. So, pulmonary embolisms and DVTs. Madam Batra spoke in detail about the venous embolisms and managing the endovenous complications. So I just touch on this part. This one patient presented to us. It's a young female presented to us with left swelling, lower limb swelling with immobilization about 1 week. She was a bit depressed after some abortion. So, and Doppler revealed lower limb DVT. So we actively did the thrombolysis. We sent, as my madam described, we sent a catheter from the popliteal vein up into the external iliac vein. And TP infusion was sent, and we reviewed the patient after 24 hours, and we got the good patency of the vein. So they were successfully recanalized on the follow-up, and the follow-up CT shows evidence of May-Turner syndromes, and it was later managed with the venous stenting. So this part also I can skip. I think Madam described this part as well about the IVC filters. This one, another one we can. This we have not done this in our hospital at the moment. This is a catheter-directed thrombolysis of pulmonary embolism, right? Pulmonary thrombosis. So this CDT involves the infusion of thrombolytic agent intravenously adjacent to the clot burden through a percutaneous transcatheter. There are several possible complications from CDT from pulmonary thromboembolism. Most complications are secondary to increased risk of bleeding. One of the most common and most feared complication is a hemorrhagic stroke, potentially leading to devastating outcome of the patient. So this one we can see the pulmonary artery thrombi here on the bilaterally, and the catheters have sent through. After that, TB infusion has been sent, and they have opened up the pulmonary arteries, both pulmonary arteries here. So another presentation is a aortic stenting for leaking aneurysms. So one patient with presented with hematemesis, he has a history of previous 2 similar minor episodes, and CT scan showed the aortic arch aneurysm eroding into the esophagus. So this was the aneurysm at the origin of the left subclavian artery. So this was successfully stented with the aortic stent. You can see the stent here. So completely blocking the aneurysm there. This is the stent in the CT scan. The patient had a stormy post-procedure period in the ICU due to a chest infection and recovered, and with no further hematemesis. So there are so many other emergency interventions which it might take another maybe 1 or 2 hours to describe everything. So I just touch upon some of things which is in the strokes. We can do thrombectomies for large vessel occlusions, and we manage the AV fistulas. When there are block, patients come with urgently. When the patients come with fistula blockages, we do the venoplasties and stenting. And for the urinary tract obstructions, we do percutaneous nephrostomies for the relieve the obstructions. And for the patients with acute biliary problems like the acute biliary obstructions and sepsis, we do the external and internal biliary drainages. And for the severe epistaxis, we can do endovascular embolization. And massive hemoptysis, we do bronchial artery embolizations. And in postpartum hemorrhage, we can do uterine artery embolization. And some patients come with spontaneous retroperitoneal hemorrhage in patients who receive anticoagulation, we can do the embolizations. And type B dissections and dissenting aortic aneurysms, we can do endovascular stenting. And we commonly do a lot of ultrasound guided and CT guided intra-abdominal and intrathoracic abscess and collection drainages. And we help the clinicians in difficult arterial and venous access. Sometimes urgent lumbar punctures when they're obese patients or technically difficult patients, we use fluoroscopy. So new emergency interventions are continuously added to this list. So we have to always keep up with the other part of the world as what is the new interventions coming up. So this is a small appreciation we got from our hospital. This is, we had a Kaizen project with all the hospital units presenting their projects for the sort of a competition. And we was shortlisted for the final 14. And out of the 14, we came out first. So this should go to our staff, my dedicated staff. They always eager to work. And thank you, Adam. They all eager to work, and they never say any. I mean, you know what? When you work in the hospital with other category of staff, they somehow try to block the things rather than doing the things. I am very fortunate to have such a staff in our unit, and half of the work should go to our Madam Indra Lekamge, who is the pioneer in starting the unit at National Hospital Kandy. She has done, when I came there, she has done all the work there. So she has done, I think she has single-handedly done every work there. I think you got just a cemented floor. We have built up the entire intervention unit at the Kandy Hospital. So thank you, madam, for all the work you have done. Okay. Thank you very much.
Thank you, Sampath. The only take-home message for me from your presentation is that in future we'll need more radiologists and only few surgeons for just for sentimental value. And next speaker is Dr. Jeevani Udupila, concerned radiologist. And Jeevani, I think rather introducing you to a known audience, I think I will make a remark, if you don't mind. Just a few days ago, Jeevani came to theatre with some CT images. And it was a patient whom I referred to her with some liver lesions for ablation. He had a weak heart and a weak liver. And she had ablated most and she had just one left over. And she asked me whether I could do that. And I said, okay, Jill, I'll do a laparoscopy and try to burn it. And after she went, my coronaries asked my brain, why did you accept that? Why didn't you let her do that as well? But then my brain replied that I'm a surgeon. I have to maintain my hierarchy and the prestige. Next day, the patient's son came and met me. And then he said, yes, Dr. Jeevani wanted me to do this. The only thing he asked me, doctor, can't you ask her to do this? So this is the reputation that you're building up. That's great, actually. So you're going to talk on the same type of thing, thermal ablation of tumors and microablation.
Thank you very much, your kind introduction, sir. We never take your place, don't worry, sir. So I'm going to talk about actually the thermal ablation of tumors, the microwave ablation, which is a novel technique. And it is a minimally invasive method of treating. And that is where the thermal energy is used to kill the tumor tissue. It could be either malignant or benign. And the two common methods used for this thermal ablation are microwave ablation and radiofrequency ablation. There are various arguments are going which one is better, but in the literature they say this novel technique microwave ablation is better, but still the research outcomes have showed that both more or less same. But microwave ablation has some of the advantages over RF ablation, which I'm coming to in a little while. And the advantage of this minimally invasive thermal ablation technique is we can destroy the tumor tissue while preserving the normal surrounding tissue. If you're going for a surgery, I mean, you have to sacrifice some normal tissue as well, other than the peritumoral tissue. Here, the normal tissue loss is minimal. The advantages of this thermal ablation minimal invasive technique compared to the surgical techniques, this is reduced morbidity and mortality, and compared to the overall procedural cost, this is low. And it is suitable for real-time image guidance and ability to perform ablations in an outpatient setting. So minimal hospital stay, same day or next day, we can discharge the patient. And another thing is you can combine this treatment with other treatment modalities as well. For example, I mean, as I mentioned, now I have done the microwave ablation. The tumor has recurred after some time, and it is in a, that tumor I will show you in a little while, in a very the place that it's not very easy for me to access. It is touching the stomach wall. So now sir is going to do the laparoscopy and remove the residual part only. So that we have combined the thermal ablation and surgery together, the outcome is better for the patient rather than going for an open surgery. And it is repeatable. If you find it is recurring, again you can go and do the ablation. And it is less painful compared to surgical scar. And the overall outcome is patient can go back to the normal activities very quickly. So when I talk about the microwave ablation, it's a recent development in the field of tumor ablation. This technique allows a flexible approach, either percutaneously, laparoscopically, or surgically you can do it. With image guidance, you place the antenna within the tumor and then we ablate the tumor directly. The microwave ablation technique compared to RF ablation, it has a cooling system. The advantage of cooling system is it prevents overheating of the insertion track. So this is our microwave generator. We can see here. And depending on the tumor, we can set up the settings. And this is the microwave antenna. Here you can see two connecting tubes. That is for the internal cooling system. And here you can fix the cable from the generator. And we usually use the 14 gauge antenna for liver and renal tumors and 16 gauge antenna for the thyroid. And this is the schematic diagram showing how the cooling system is running. And this is what happened when you are ablating the tumor. This is the tumor, and you are ablating a tumor and a peritumoral tissue. Finally, the ablated area like that, including the tumor and peritumoral normal tissue. So just to show where these microwaves are there when they are the electric magnetic spectrum. And what happens when the microwave generator generates electromagnetic microwaves that will agitate the water molecules in the surrounding tissue, that will create the friction and heat among the water molecules, and that will cause the cellular death via coagulative necrosis. That is the pathology behind the microwave ablation. So what are the advantages of microwave ablation or RF ablation? So this novel technique this technique can keep consistently high intratumoral temperature compared to other thermal ablative techniques. And the large volume of tumors also can be ablated, and ablation time also fairly quick. And there is no heat sinking effect. What is this heat sinking effect? When the tumor is closer to major blood vessels, what happens? The flowing blood will cool the tumor, which is heating. Then it will prevent further heating and it won't keep the high intratumoral pressure. But the advantage is microwave ablation. The mechanism will, it has no heat sinking effect. So that is one advantage over other thermoablative techniques. So these are the places that we can use microwave ablations: primary and secondary liver tumors, primary and secondary lung tumors, renal and adrenal tumors, bone mets, benign thyroid nodules, benign breast lesions like fibroadenomas, uterine fibroids. So there are few complications. The pain is the main complication. We can give some analgesics, and infection is another complication which is not very common, but we can treat with antibiotics. And the hematoma, that is also not very common, and skin burns and damage to adjacent structures. Except the pain and infection, I haven't come across other complications during my short period of experience. Usually we perform under conscious sedation. Sometimes we have to give general anesthesia because sometimes some procedures are painful. So example, if the liver lesion is closer to the capsule, it will be painful. And throughout the procedure, patient is monitored, and this is done under strictly aseptic condition, similar to a surgery. And usually we infiltrate local anesthetics to the access site and into the deeper tissues. So with the aid of ultrasound or CT, we localize the tumor and then we place the antenna within the tumor directly. Then it will attach to the microwave generator. Then the microwave is emitted from the generator through the unexposed non-insulated portion of the antenna. So one of the common use of microwave is for the liver tumors. So liver resection is the ideal treatment for the liver lesions. Even the small tumors, it's difficult to do the surgery. I mean, sir must be aware, because these patients having a lot of comorbidities and the liver is also not functioning properly. These patients, the thermal ablation is the ideal treatment. So we have limitations, like we can't ablate all the tumors. Only the less than 4 centimeter size tumors only we can ablate. HCCs and liver metastases are usually ablated by the microwave ablation. So again, similar to general technique, do it under conscious sedation, ultrasound or CT guidance, we localize the tumor. If the patient develops pain during the procedure, we give some analgesics. And then we locate the antenna within the tumor centrally. That is very important. We have to keep the antenna centrally within the tumor because only elliptical area is ablated. The ablation time depends on the size of the tumor. Usually it's between 2 to 12 minutes. And when you are withdrawing the tumor after ablating, we ablate the tract to prevent the bleeding complication as well as tumor seeding. Sometimes we can't access percutaneously all the tumors. Then our colleague surgeons help us to take the liver down. They open and do the surgery, and then we directly, with the aid of ultrasound, we are ablating the tumors. So this is this one I have done recently. This patient is not a suitable candidate for the surgery, and tumor is also quite big, close to 5 centimeters. But I discussed with the surgeon, he wanted me to go ahead and do the ablation because that was the only treatment option available for him. And here you can see in the first picture, this is the tumor and this is the antenna. It's in the centrally, the tip of the antenna is in the lower edge of the tumor. When you start ablating the tumor, we see this echogenic cloud-like thing is appearing within the tumor. Gradually it occupies the whole tumor like this. This is at the end of the procedure, the tumor will appear like that. So this is the patient I have discussed with the mentioned little while ago, and this is the patient I have done the ablation. Pre-ablation, this is a tumor, CT, this is a contrast enhancing tumor. This was done after 3 months post-microwave ablation, but after some time, about 9 months after the initial treatment, again during the routine screening, we have found there is another small area was enhancing and it was very closer to the stomach and was touching the stomach. So it's going to take that residual part laparoscopically. This is another lesion in hepatocellular carcinoma. You can see it is high up in the right lobe. It is just below the diaphragm. It's very difficult to access percutaneously. And actually we have, the surgeons have moved the, open the stomach, the abdomen and move the liver lower, move the liver, and then we could access the tumor. And this is the post ablation after 6 weeks. The CT shows there's no enhancement. This is how we have done that procedure. So this is in the theater. my colleague is helping me. We have a handheld ultrasound scanner. So we have directly kept the ultrasound probe on the liver, and this is a cirrhotic liver. You can see the coarse appearance of the surface. And this is the ultrasound guidance. We have located the tumor, and then we have placed the antenna like that. This is finally, that is how it was very closer to the surface. That is the appearance of the post-ablative tumor. And post-procedure follow-up, immediately you follow the patient in the ward with close monitoring. Like day 2, like we do the full blood count, liver functions, and inflammatory markers. Antibiotics use is controversial. I mean, some people, this is your preference, but I usually add antibiotics because these patients are having a lot of comorbidities. I don't want any superiority infection for these patients. There's a triple phase CT we do for as follow-up investigation, 6 weeks, 3 months, and 6 months, and afterwards annually for 3 years to see whether there are any recurrences. Microablation can be done for the benign lesions like breast and thyroid. Now the breast, because of the advancement of the imaging, a lot of breast lesions are found out, and the patients are, they want to do something for the breast lesion. Once it is confirmed it's a benign lesion, still they want to do it. Sometimes it's a cosmetic reasons, or sometimes it is bothering them. So this is one of the very good option for these patients who doesn't want to go for any surgical intervention, because there's no scar, and you don't have to wait in the hospital for a long time. This is a day procedure. So again, we are doing it under ultrasound guidance. We first do the biopsy and confirm its benign nature, then only we proceed from there. Under local anesthesia, we access the tumor, and we do a special technique called liquid isolating the region, or we call it hydrodissection. If the lesion is closer to the skin surface or in the deeper tissues like pectoralis major muscle, we can separate the tumor. Then you don't want to get an unwanted effects, problems. You can remove or separate the tumor from the skin or the pectoralis major muscle. Then we use this moving shot technique that is different to the liver ablation, where liver ablation throughout the procedure, we keep the antenna within the liver lesion. But here we do it unit by unit, like we go from plane to plane and unit by unit. There is no specific time. Once the whole tumor is ablated, we stop the procedure. And in addition to that, in the breast, it is very closer to the skin. We apply ice pack in between to prevent any skin burns. This is ultrasound appearance of the fibroadenoma of young girl. And this is how we separate the tumor from the superficial skin. Here you can see the needle. We have put a needle, and we have put some saline. Then we inject some saline, then tumor will separate from the skin. Here again we put the needle deeper to the tumor, fibroadenoma, and separate from the underlying pectoralis major muscle. And this is how you do the ablation. You start from one plane, from one edge, and when it is ablating, you will see like cloud-like thing is appearing. Then you gradually withdraw the needle, and then it will appear like that. Then you put it into a different plane and do it like that. Once the whole tumor appears like that, we stop the procedure. So that is how we do it with the ultrasound guidance with the aseptic conditions. Here we locate the tumor and place the antenna. This is how we keep the ice pack in between to prevent further damage to the skin. Again, complications, pain, hematoma, and skin burns. But only I have no experience in hematoma and skin burns in fibroadenoma ablation. Only pain, that is also only some patients they get pain. Same day, they can go back. Usually we follow up these patients with ultrasound 1 month, 3 months, 6 months, and 12 months. If there's a poor response in 3 months, like we expect tumor to reduce in 50%, like if there's no reduction, we can again repeat the procedure. So there's some literature shows there's like 93% reduction in 24 months. Like I have my personal experience, like after 1 year, about 85% reduction I have noticed. So again, benign thyroid nodules also microwave ablation can be done. And if the patients are having the indications for ablation is increase in size, causing in symptoms or cosmetic concerns. The advantage is this minimally invasive technique is no iatrogenic hypothyroidism, no scar, and compared to the surgical procedure, cost is less. And again, literature shows about 80% reduction in 1 year time, the thyroid nodules. The technique is also similar to breast technique, but here we do 2 FNACs. One is prior to the, before we are giving appointment. Once it is a benign one, we are planning to it, and on the same day before we do the ablation, we take another FNAC. And again, outpatient basis under local anesthesia we do it. And liquid isolation, again, very important here as well to prevent the important structures in the neck, like carotid artery, and then trachea, esophagus, laryngeal nerve from the thermal engine. So again, we use the moving shot technique. Unit by unit, we are ablating. And once the whole nodule is covered by echogenic area, we stop the procedure. This diagram shows how this transismic approach, and unit by unit we are ablating. This is how we are doing it, and this is the tumor, and with the needle, when it's ablating, it will appear like that. Complication, the recurrent laryngeal nerve and hematoma, that is also not very common, about 3.5% like. And then we follow up again with ultrasounds 3 monthly, 6 monthly, and annually. And the same time, we are doing the thyroid function test as well. Prior to the procedure as well as after the procedure, we are doing it. Parathyroid adenoma also, we can ablate with microwave. So this is the prior to the ablation, this is the ablation, and this is after the ablation. Lung also, primary and secondary tumors we can ablate. So when you're choosing a candidate, it's a multidisciplinary approach. All the surgeons, the pulmonologists, oncologists, anesthesiologists, radiologists, they should get together and choose the patient. Ideally, lung lesions about less than 3 millimeter size is the ideal size for microwave ablation. There are certain indications and for the microwave ablations, inoperable stage 1A non-small cell lung carcinoma and oligometastatic colorectal cancers are the main indications. There are some other indications also, multiple and synchronous non-small cell carcinoma and inoperable non-small cell carcinoma in other stages, and oligometastatic lung disease from other tumors as well. That is also similar to the general technique. Pre-procedure, we are doing the pre-procedure biopsy and confirm it. Then with the aid of ultrasound or CT, we localize the tumor. And then if the tumor is closer to the pleura or the mediastinum, we can make an artificial pneumothorax and separate from the pleura or the mediastinum to avoid damage to the adjacent structures. Antibiotic, again, personal preference. This is a small lung CA colon, 5 millimeter size metastatic deposit here. With the CT guidance, it was ablated. And after the ablation, usually you get a ground glass appearance, which is bigger than the size of the tumor. That is a normal appearance. With time, it will shrink and fibrosed. The complication, main complication is the pneumothorax. And because of that, actually, we are not ablating the trachea as well in the lung microwave ablation. And pain and fever, infection, bronchoalveolar fistula, other rare complications. Again, we follow up with the CT 3 monthly and first 3 months, and then every 3 monthly for about 2 years. Renal tumors also, microwave plays a role. Renal tumors, very similar to the technique as the liver tumors. These are ideally for less than 4 centimeter size tumors are ideal for this microwave ablation. Here we don't do the biopsy beforehand. We are doing the biopsy on the same day. With same track, we are putting the microwave ablation antenna and we'll ablate the tumor. Again, CTO ultrasound guided access. Track ablation is done to prevent the metastatic deposits along the track. This is a small renal cell carcinoma marked by the arrow. This is a CT guidance access to the tumor, and this is the appearance post-procedure. So likewise, we are doing for the benign as well as malignant tumors. The complications of the kidney, of course, we are doing the malignant ones. The complications of these renal tumors are bleeding, like perirenal hematomas you can get, psoas hematomas you can get, then the ureteropelvic obstruction, and injury to the nearby structures. So hydrodissection is very important. If the bowel or very important structure is closer to the tumor, you can put another needle and put some saline and separate the tumor from the close by structures. And 3 months and 6 months annually, first 3 months and then 6 months annually, we follow up this patient. So microwave ablation is done for the benign as well as malignant tumors, and it's proven it's beneficial, and volume reduction for benign tumors is it's very significant, and the malignant tumor shows some successful ablation. Thank you very much for everybody. I would like to take this opportunity to thank my 2 great teachers. Actually, it's a great day for my life. I'm in the same podium with my 2 great teachers, Madam Lekamge and Madam Heva Vitarana. Actually, Dr. Lekamge is the one who showed me the pathway to the interventional radiology. She's always guiding me and supporting me. And Badra Heva Vitarana, Madam, you are always encouraging me to find new things and go for adventurous things and accept the challenges. And Dr. Gorugagoda, you are always supporting me because most of the time we don't have enough hardware to carry out our day-to-day procedures. He's always there to extend his helping hand to me. Thank you very much, my colleagues and madams, and thank you very much for the audience.
Thank you very much, Jeevani, for your elaborative lecture on microwave ablation and thermal ablation. I'm pretty sure that you will expand your services more and serve the community in Kandy. So as we are running out of the time, we might stop for the moment to proceed for the next lectures. So may I ask Professor K.B. Galgatier to deliver the token of appreciation and the certificates to the resource persons. Madam Indra Lekamge. Badra Heva Vitana. Dr. Sampath Gorugagoda. Dr. Jeevani Udupi. So on behalf of Kandy Society of Medicine, the President and the Council, I thank you very much for all 4 speakers doing the justice for the patients, as well as working with surgeons like us and helping all out to save patients' life. Thank you so much.
Thank you, sir. Please bear with us for a moment. I would like to invite Dr. Tilak Abesekar, Senior Consultant Physician, to hand over the certificates of appreciation as well as the tokens to our chairpersons of this session. Please come on stage, sir. Thank you, sir. With that note, we mark the end of the 11th symposium and the final one of the 44th annual academic sessions of the Kandy Society of Medicine. Next, we are awaiting a quite interesting session, that's the debate. So please bear with us for a moment.
Ladies and gentlemen, now we have gathered for one of the most interesting events of today's function. Today, we will be witnessing a debate on a critical topic that is relevant to all of us in the field of medicine. When it comes to in search of knowledge, there's one-way communication, two-way communication, there are formal discussions. And debate is considered as to be in the epitome of formal discussions. Let me invite the chairperson of today's debate, as well as members of the debating teams. The topic for today's debate is withdrawal of medical treatment. Should it be legalized in Sri Lanka? Should it be a medical decision or not? As the moderator of this debate, we have a person who needs no introduction. She is Professor Vasanthi Pinto. She currently serves as the Dean of Faculty of Medicine, University of Peradeniya, and also she works as the Chair Professor of Anesthesiology and Critical Care in Faculty of Medicine. Madam, you may please take your seats. And let me now invite the members of the two teams. For the proposing team, we have Dr. SMM Nias, Dr. Buddhiga Dasanayaka, and Dr. Champa Rattatunda. You may please come forward and take your respective seats. And opposing this motion, we have Professor K.B. Galkatia, Dr. Dinesh Fernando, and Dr. Sayuri Pereira. Now I would like to hand over the control to our moderator, Professor Vasanthi Pinto.
This, J.
Mic kicker. Mic for me. No, it's okay. I'll go ahead. I'll make it here now. Mic.
J1.
Okay. All right. Most awaited moment for the whole KSM session, I believe. All the very best for both teams. Yes, as my very pleasant compere said, it's a very interesting moment to know not one-way communication, but two ways, and over that, debates. And we have our President Councillor today with us as well. I will introduce him later. All right, for the rules, before I explain the topic to the audience, let me tell you the rules. Do you know which team are you? Are you the proposer or the opposer? Very good. I'm just checking because it seems like it's little change up there. All right. Okay. So the topic here today, a withdrawal of medical treatment should be legalized in Sri Lanka. That's the discussion that, or rather debating that you are about to witness. A withdrawal of medical treatment should be legalized in Sri Lanka. And this particular topic is being proposed by this team on my left. And the team on my right is going to oppose this. So they are going to say, no, the withdrawal of medical treatment should not be legalized in Sri Lanka. So we will give you 7 minutes to the two heads or other team leaders and 6 minutes each for the other members. And we come back to the leaders again to have 7 minutes each. And audience, be mindful and always be attentive because the judges are going to be y'all. So y'all are going to judge this. And Samantha is going to, our President Councillor, Dr. Mr. Samantha Ratwate, will going to give you an account of the legal points. Okay, let's start. The first, the leader of the proposing team, a withdrawal of medical treatment should be legalized in Sri Lanka, Professor Dinesh Fernando, who is the professor in forensic medicine. As a person I know, debating is his passion. Am I right? Yes. But when I think a while, why he has selected this topic, I just realized he must be planning to widen his client base. Am I right, Dinesh? Over to you for 7 minutes.
Thank you, Madam. Withdrawal of medical treatment should be legalized in Sri Lanka. That is the topic, and that is the topic that is here. Withdrawal of medical treatment in one of the most emotionally, ethically, and legally complex and challenging aspects of end-of-life care. As our ability to prolong life increases, so does the necessity to address these issues. Thank you, KSM, for the opportunity to do so today. Let us therefore define our topic of debate. Now, what we propose is that in cases that there is no hope of recovery, where the patient is being kept alive by medical treatment, prolonging the inevitable by medical treatment, that it may be withdrawn. Please note, we do not propose the withdrawal of care. We do not propose the withdrawal of care. Medical care should be continued to ensure the comfort of the patient, who should be free of pain, while we allow the natural course of nature to run its course. We propose that medical treatment, which is futile and burdensome, be allowed with the consent of the next of kin, or better still, if the patient has already made an advance directive or a living will, which will be elaborated in a little while. He does not wish to be kept alive when there is no likelihood of recovery. He can give this advance directive earlier, at the time when he is not in pain, when he is clearly competent. This would be an informed joint decision between the healthcare team, the patient, and the next of kin. The decision to die with dignity and respect should be given to the patient. Now, those of you here today, especially those in ICUs, like our Madam Moderator, may be wondering what this debate is all about. This may be happening on a day-to-day basis. You may be making these decisions. You may be withdrawing ventilation. However, the question remains, is it legal? That is a gray area. If you practice active euthanasia, which means that you actively terminate the life of the patient, whether it be voluntary, involuntary, or non-voluntary, it is clear. According to our penal code, section 296, it amounts to murder. And if you are convicted of murder, the punishment is death. If it's reduced to culpable homicide not amounting to murder, it can extend up to 20 years. Now, what we're talking about here today is not actively ending the life of the patient. What we are talking about here today is when every avenue has been exhausted, every option has been exhausted, there is no hope of recovery. The patient is terminally ill. The patient, the next of kin, the treating physician, all want to discontinue this futile treatment to prevent the prolonging of this intractable suffering. Can it be withdrawn legally? It is not clear. Can you be charged with murder? Possibly. If you look at some cases that have occurred in Japan, noted for harakiri and the honor of killing yourself, there was a case where a 58-year-old patient, the endotracheal tube was removed on request from the patient's family. The doctor was later charged with homicide and convicted of homicide. Another case, 2000 to 2005 in Imizu Hospital, 2 physicians withdrew artificial ventilators from 7 terminally ill patients in their 50s to 90s at the request either from patients or their families. And thereafter, the police charged them in 2008 for murder. And closer to home, in India, there was a case of Aruna Ramachandran Shanbhau, who was in a persistent vegetative state for 38 years. And then it went to the judge of the Supreme Court after a long legal battle. And finally, they approved, the court approved to withdraw treatment. And now in India, with court approval, you can withdraw treatment. You may have heard of similar cases in USA, the Terry Schiavo case, where she was in a persistent vegetative state for 15 years. And then in UK, the Bland case in England. Now thereafter, after that case, the GMC and the British Medical Association published documents, guidance for doctors on withdrawal and withholding care. In Sri Lanka, the Sri Lanka Medical Association have published a document. And in that they say, it is understood that the practice of some of the guidelines contained in this document would require amendments to existing laws and introduction of enabling legislation. It is the expectation of the SLMA to lobby the relevant competent authorities to enact necessary legislation to give legal recognition to these guidelines. So it's not only us, it's the SLMA that is wanting this to be legalized. Do we wait for one of our colleagues to be charged and prosecuted? Or do we learn from the experiences from other countries and be proactive and have a legal framework with necessary safeguards to respect the patient's autonomy? The first principle of medical ethics, which second speaker will now elaborate.
Thank you very much, Dinesh. Yes, now your formidable opponent. When I saw he's going to oppose this, I was surprised. Being a vascular and a transplant surgeon, he must be having a good reason behind this. But recently, he went for a treasure hunting. Who knows? He may have changed his mind after his marriage. Over to you, Dr. Buddhika Dasanayake.
Thank you very much, madam. So, Chairperson, Madam, adjudicators, educated members of the proposition and members of the House. So, good afternoon. It is the view of the opposition that withdrawal of medical treatment should not be legalized in Sri Lanka. So, before I talk more about why this should be the case, let me also, like the proposition, start with certain documents. We are well aware of the 2021 SLMA proposal on withdrawal of care being legalized, which stems from the 2014 British Medical Council papers. And just after that, in 2015, there was this instance which was documented and published in The Guardian newspaper in the UK, which I'll relate in short. So a blind teenager with a brain tumor was at the center of a UK court case, because in February 2015, after the BMC came up with this, the doctors argued that this 18-year-old had no more than 2 weeks to live, and that active treatment, including chemotherapy and brain surgery, was futile. And if the heart was to stop beating, there should be no resuscitation. So based on this evidence, the High Court authorized the hospital trust to discontinue the treatment against the patient's wishes, against the parents' wishes. The parents went to court, but the decision was to withdraw care because, according to expert opinion, the child had 2 weeks to live maximum. The mother says, I'm fighting for my child's life. He is sick child. He is coping. He is not dying. But the court decided otherwise based on expert opinion. The article is not from February 2015. The article is from June 2015, when the child is still alive. 3 months later. And that made the writer of this article review the question of how correct are doctors in their judgments and prognostications. The Lockerbie bomber from the UK again was released from prison because his terminal prostate cancer, according to the experts, would give him only 3 more months of life. He was alive 3 years later as a free man because he was released from prison based on medical opinion.
So this led to a set of questions, which again was published in the BMJ as a review of survival predictions of terminally ill patients. And this large study showed that doctors' predictions were correct to within 1 week in only 25% of cases. 75% of the time, expert medical opinion is wrong. If not anything else, this alone should make it clear what a dangerous path the Leonard proposition is trying to lead us towards. But there is more, much more. Over the course of the next 30 minutes or so, we, the opposing team, me and my colleagues, will be explaining why withdrawal of care is unacceptable for several reasons. Starting with number one, it's extremely paternalistic to assume that we as doctors know everything. Like I just mentioned, we can be wrong. Our errors can lead to consequences that we do not foresee, and we cannot, in good conscience, be paternalistic about someone else's life and decide that not only do we know the patient's disease condition and how it should be cured, but we also know the patient's needs. That is wrong. The patient has the right and the prerogative to decide, not us. Secondly, I'll explain why ethically, morally, and constitutionally also, this is a wrong concept and why it should not be therefore legalized. Because if there is no ethical basis, no moral basis, and no constitutional basis, it cannot be legalized. Then also, my colleagues will be talking about how this has a large potential of being abused and misused, both in critical care settings as well as hospital settings, and how lack of resources and training and supervision can make end-of-life decisions like this extremely dangerous. Then we'll also show how this violates patient autonomy as well as the Hippocratic Oath. We'll talk about how in a resource-limited setting, there are plenty of alternatives to withdrawal of care, just like printing a PDF in a paper limited setting instead of printing out all your notes on paper like the proposition has done. There are plenty of alternatives if you do consider them. And then also we'll talk about how inappropriate it is to implement this in Sri Lanka just because there are precedents set in other countries, how we need to have homegrown solutions to our own problems. So that will be kind of the scope of our discussion. So I'll stop with a few points that I mentioned before. First, paternalism. I mentioned how very paternalistic it is, how outdated it is to assume that we know what is right for a patient. The Sri Lankan constitution does not allow for taking a patient's life either voluntarily or involuntarily. It's either homicide or manslaughter, and that means that there is no constitutional ground for legalizing this. Also, there is no ethical and moral ground. For example, let's talk about a transplant setting. A motorcyclist meets with an accident, brain dead. If the patient is dead and you harvest organs, that one death will lead to about 6 or 7 lives. The liver can go to 2 people, 2 kidneys, heart, lungs, perhaps pancreas. So just because resources are limited and we want to save more lives, should we recommend that people go around without helmets? You are saving 1 life, you are expending 1 life, you are saving 6. Obviously, the answer is no. And for the same reason, withdrawing care for equity or for the greater good is a completely wrong concept. And so we want to make that very clear. I think I'm coming to the end of my 7 minutes. I'll let the rest of my colleagues continue this discussion. Withdrawal of care, medical care should not be legalized in Sri Lanka. Thank you very much.
Thank you, Buddhika, for giving a really good debating points for your proposing team. Don't you feel that your heads are exploding? Who do you want at this time? A psychiatrist? Good. I'm sure, being the wife of the KSM secretary, you should be having, definitely you should be having a good debating qualities. And this invitation is for you, our charming lady, to debate with a sweet but sharp voice the second speaker for the proposing team, Dr. Sayura Pereira.
Good afternoon, everybody. Chairperson, Madam, learned members of the opposition, and learned members of the House. Let me start by stating the obvious. As far back as in 1789, the great writer and scientist Benjamin Franklin said that the only two certainties in life are death and taxes. And centuries later, we solemnly nod our heads. Dealing with mortality is difficult. Yes, but we must be mindful not to get carried away with the notion that life is infinite. Life is very much finite. Now, before I get bricks thrown at me from the opposition, let me reiterate that we're not taking this lackadaisical, complacent attitude of saying patients are going to die anyway, so let them die. No, that is not what I'm saying. What I'm saying is that we, as a fraternity of doctors, we need to serve the needs of our patient. And we must not fool ourselves, let alone fooling our patients, into thinking that we are demigods. You know, we can make people live forever. Nowhere in the world, even in the most developed countries with the most developed technology, the best of medicine, have they been able to make people live forever. Now, falling short of that, falling short of the fact that we can't make people live forever, we strive to provide the best medical welfare from cradle to the grave, which, as we know, is the hallmark of modern civilization. And we are guided here by a set of moral principles by which a doctor must conduct themselves, and these are known as medical ethics. Now, it is pertinent to comprehend here that despite my opposition hurling various derogatory comments with regards to the morality and the lack of ethics in withdrawing medical treatment, let me show you how medical withdrawal of treatment aligns itself with the principles of ethics, contrary to the popular belief of my very learned members of the opposition, who seem to think that we need to keep the patient alive at all costs for as long as possible. Now, the leader spoke of autonomy. Now, autonomy is to respect the decision of the rational patient and respect the rational informed consent. My leader spoke that the lack of an advance directive in Sri Lanka is very much a pertinent factor here. The opposition spoke of a case of a child whose treatment was withdrawn by a group of the treating clinicians, and how the patients were aghast and were so upset that this treatment was withdrawn without the consent. We're talking of a minor here, and when it comes to a minor, the next of kin, the informed consent of the next of kin is very much valid. Perhaps it didn't happen in the UK, but we are very much asking for it to happen in Sri Lanka. The second pillar of ethics is beneficence. What is beneficence? The obligation to provide benefits and balance the benefits against the risks in the best course of action, which is in the best interest of the patient. When you say the best interest of the patient, it means the best interest of the patient, not the best interest of the practicing clinician. Now, where is the beneficence in letting this patient, where treatment is futile, you want this patient to go on and on and on, suffering and suffering? What suffering are you causing for not only the patient, but for the immediate caregivers? They have to run from pillar to post, pawning their jewelry, pawning their lands to buy medicine which is not available in the government sector. The passion to keep life going on no matter what. They seem to be so ardently committed on that. But are you so compassionate to save the life of a 12-week-old fetus? Isn't that also a life? Right? Are you so passionate about that? We deem it futile and we do not resuscitate a 12-week-old fetus. The most pertinent pillar of ethics, justice. justice is very much practiced and it is exemplified when it comes to the withdrawal of treatment. Otherwise, you will be limiting access to so many other patients who rightfully have the duty to be cared under our guidance. Now, coming back very briefly to what was mentioned, that medical withdrawal of treatment violates the laws of the Hippocratic Oath. The Hippocratic Oath, set 400 years BC. In these changing times, where robotics are doing surgeries and transplantation is happening, it seems a little redundant to be swearing by ancient Greek gods before you embark on your treatment procedure. And in the time of Hippocrates, women were not allowed to even practice medicine. There was a separate oath then created for women to practice. So we would all be out of jobs if we simply stuck completely to the Hippocratic Oath. And the oath does not mention about vegetative states or unnecessary suffering or pain. And these issues were non-existent in ancient Greece. So why are we wasting time talking about these today? I rest my case. Thank you.
Thank you, Sayuri, for keeping in time. You all agree with me. A woman can't be handled by a man. So I'm going to invite another woman for this, another woman who has a giant personality, even though surrounded by microbes. So we are going to take you away from your comfort zone, Champa, from microbes to people. And with your strong and intelligent argument, let me invite Dr. Champa Ratnatunga, please.
Madam Chairperson, members of the proposition, members of the House. Let me start with a few simple truths that I think the proposition has missed. Hippocratic Oath, 400 or 4,000 years old. Truth remains truth, whether it's prehistoric or not. That does not change simply because technology changes. You were talking about doctors not being gods. Agreed. As Buddhika pointed out, doctors don't know everything. They are wrong more than half of the time. So if a patient's consent, if the relative's consent is based on false information or not current information, or doctors who are not up to date or don't know what they're doing, then their consent could always also not valid because they are making decisions on things that are not in their best interest. It may not be intentional, but nevertheless, that is the truth. And if we look, and they were talking a lot about, the conceptual framework of why they think this should be legalized. Let me talk about practical realities about why this should not be legalized in Sri Lanka, right? Let's talk about misuse of power. All of us have given calls and got calls saying, give that patient a bed that is a known patient to me, knowing full well that some poor fellow is going to be kicked out of the bed and my patient is going to be put in. Now imagine, right? That was me or my parent or my child, and the situation was life and death. Imagine how much stronger the demands are going to be. Imagine how much more powerful the demands could be if this was a politician or rich and powerful businessman. When the demands for in resource limited settings like ICU beds, ventilators are requested, and as they said, the terminally ill patient is seen as a demand on resources rather than a life, then you open the door to make decisions that are wrong for the person, but these are now justified and protected by a legal framework. In resource limited settings, which is where this decision must be made of whether we are going to legalize this or not, citizens are not all equal. The demands, the resources are not distributed equally. It is the vulnerable who gets sacrificed first. Who are the vulnerable? It is the elderly patient who is on a ventilator, who can't communicate and has no next of kin to give consent or object on their behalf. It is the orphan, say the boy Buddhika was talking about did not have parents to fight on his behalf, right? It is the orphan who is going to look after them, who genuinely has their best interests at heart. It is the marginalized communities, right? Who already have people who are prejudiced against them. In this world, where transplants are getting more and more, right, in this country, right? What if the rich and powerful need organs and these are the demands? I'm not saying these are legal, right? But these are the realities that we must deal with in this situation, right? So, and we are giving permission We are giving opportunity for such things to happen because doctors can abuse this power. The relatives, as they say, can abuse this power, not because they genuinely want the patient to stop suffering, as they say, but because it is too expensive for them, this is too much for them, or they are going to gain from the will, or for other ulterior motives. How are you going to test all these things? You can't practically do this. Or it could even be a cover-up for malpractice. You don't know this, right? Let's see, let's take ICU settings aside for a moment and say that in Sri Lanka, all ICU settings are wonderful and, according to protocol. What if this happens in the periphery, right? Patient comes semi-conscious, end of life, terminally ill, and the MO there thinks, right, drain on resources. I also have to go for my PP at 4 o'clock, right? And decides this is not something that I can manage, because in a way that would not, you talk to the patient and patient is semi-conscious, talk to the relatives also in a way that says, yes, this is the best course of action for anybody. Who is going to suffer from this? The doctor? No. Doctor gets rid of the transfer requirement and the complex management requirement and all the complications are lost. The system? No, because now it's cheaper. It is easier, less bed occupancy. The patient? Well, possibly also, no, patient is dead now, no, so patient is also not suffering, right? So the day we become those patients, that is the day that we will actually start understanding. Now, let's say that this is happening as the proposition says in the ICU setting, where, as many people have written, and actually even Madam Chairperson has written, right? There is talking to the patients. If the patient is not competent, there is talking to the relatives, telling them about the pros and cons of treatment, and taking them through the decision-making process, counseling, revisit the decision, multidisciplinary team, ethics committees, and so on and so forth, right? As the proposition is saying, let's lead this up to a dignified death, right? In reality, in our ICUs, do you think we have the training, the manpower, and the time to do all this every time this becomes necessary? You have 2 or 3 MOs, right, for 10 to 15 patients. If you have 30 minutes to communicate with the family, that would be, a plus. So if you want this to happen in a best practice scenario, then you have to make the investment in training people in this kind of communication. Now, doctors are notorious for not wanting to communicate even in the best of times. Imagine this kind of communication, which requires sensitivity, empathy, listening, right? You need a massive investment in the training of how to communicate with these kind of people. So this is not a quick decision that will, give you an ICU bed. This is an investment that will take time. And this is a process that can open the doors to massive amounts of misuse in this country. Now, beyond all of this, right, I will say this and stop. Look at who we are. We are the KSM with doctors debating doctors with doctors listening. Medical legal experts, psychiatrists, surgeons who requires ICU beds, research immunologists on the side, right? We are, who is the real stakeholder here? Us, yes, we have an interest, but the real stakeholder is the person whose life is at stake. Where is their opinion on this? The publications don't show this. The publications are all on doctors' opinions on this. The weight of opinion, the weight of the dialogue is in the wrong hands. We will understand this someday when we are in the ICU, can't communicate, and the light at the end of the tunnel is gone. And the doctor has permission to pull our plug. Thank you.
Thank you very much. Wow. I'm glad that I selected 2 women to each side in one go. Yeah. Today is a day of surprises. And you're going to listen to the coolest man on earth, I think. I have had experience of witnessing his long hours of surgery. No food, no water for your poor anesthetists and the other doctors. And for you try your best, a huge effort to save these patients and give at least 1 month. For a change, you're going to debate to withdraw. Always brings intelligent arguments. I'm not going to say who wins, but let us listen from Professor K.B. Galkatia.
Thank you.
Proposing the topic.
Thank you very much. Okay. Now, this withdrawal of medical treatment, legal aspects, and Dinesh very well explained. There are a lot of ethical issues and psychological factors which I have to explain. And after 2 such experts speak, I don't know why Arinda picked me to talk and he's nicely relaxed there. So I thought I was also relax, sit and talk. Now, I guess that is because I am a clinician with a lot of gray hair. And now it's nearly about 40 years I've been working. But those days, it's okay. So actually, at the beginning of my career, this problem was not there. Like the withdrawal, it was not a hot topic, but now we are even debating with our good friends. Why is this? Now, what I have witnessed over these 40 years, during the latter half, in this new millennium, the critical care has improved a lot. Understanding pathophysiology, there are a lot of experts, and also due to technology of monitoring and also organ support. Now, at the beginning, we had only ventilation, but even the ventilation, the machines have improved a lot of modes, and cardiac support from only inotrope drugs to mechanical devices like intra-aortic balloon pumps, pacing, and also renal support, nutritional support, and microbiologists recommend a lot of antibiotics. So the critical care has improved. It saves a lot of patients, no question about that, but adding a huge amount of costs to the health sector. And whatever you argue, some of these ICU patients, they will not survive whatever treatment we give because they die of their disease. So it's a question whether we should continue the treatment and let them have a suffering which is unknown to us. They can't communicate with us, and suffering to the relations. And also, I think one reason why Arinda picked me is because I'm a person who is in the interface, sandwiched between the patient, the distress relation, the law, and also the society. How does the society get affected? Because these treatments are very expensive. And if it's in the private sector, the patient's family has to pay. Sometimes they are distressed with this. But if it's the state, government hospital, state pays, but of course, it's from the society. So we have to be fair by them. So there's need for withdrawal of treatment if it is not going to be effective. Now, actually, there was a rule saying that you can't make personal comments, but because it's me, I can tell. When my father was 89, got a stroke, they want to ventilate. I said, no, you just sedate him, because that's why my father was wanted actually. And also yesterday I met a surgeon in the corridor at Peradena. I can't mention names, but he was nearly crying. I asked why. He said, my weapons, I didn't get a ICU bed. No one's smiling to identify, but anyway. So, but now the other thing is, now you say the doctor's decisions are not always all right and there can be errors. I have no argument on that, but we are taking another step ahead. What we say is this should be legalized because these patients have no capacity, mental capacity, sorry. So there has to be a proxy. So if it is only the physician and the relation going to decide, then there can be a bias, maybe to prolong or sometimes dangerously even to withdraw early, like say organ donation. So there may be many issues. So the proxy has to be the law, because legalizing means that you have just legalizing doesn't mean it says, okay, when you in the physician thing, you can withdraw. No, nothing like that. There are so many acts like Mental Capacity Act, prolongation of care, and there are a lot of laws and bylaws and a lot of things. And in this decision making, just a lot of team should come in, not just one person going to decide or not just one relation. And also, I think the legal experts should come in when these decisions have been taken, because the laws and bylaws and all that, it's complex and complicated, and it's like working with in-laws. So sometimes we will need a lawyer to explain what this is. So mind you, these two things. One thing is it's withdrawal of care. In some people, we may decide, no, we are not going to withdraw. It's a sensible decision that we have to make. But when it is necessary to do, I think there is justice by the patient and the family and the relations, because the person may go on for about 1 month and die. And we look at as one death only. And we think, okay, we did everything, but we couldn't save. But during that 1 month, we would have missed so many deaths unknown because of lack of ICU beds. There are patients dying without lack of ICU beds. It's not a secret. So it may be a person who dies, who is the only breadwinner for small children. We are only looking at the ICU patient. We are not looking at the people who are waiting to come to the ICU, die without a bed. Thank you.
Thank you very much, Professor Galkatia, for keeping it to the time. And it is usually very difficult to argue with Professor Galkatia by experience. One of the few should be, of course, our Dr. Nias. So, Dr. Nias, I didn't select you to match with your opponent by the number of gray hairs. But with your strong arguments, always wrapped up with humor, we have chosen you to oppose his points. An ethical versus surgical battle. Come on, Dr. Nias.
Thank you very much. With much ado, I'm a bit confused now after Professor Dinesh Fernando and Professor Galkatia, two eminent professors, whether they were talking for us or for them. Because this is after all a debate, eh? Yes, and I'm sure there is eminent lawyers in the audience. And I know you all are seated behind. Please come in front. No, we are not going to withdraw here. Come in front. First, do no harm. There's no question about it, madam. Do no harm. That is what is Hippocrates' oath, or common sense also tells that. It is 17th century. Premium non nocere was the word in Greek. But later on, they transferred into English. In 245 AD version is, I will abstain from all international wrongdoing and harm. That is what we are practicing. That is what we are expected to practice. And we should do so. And we name that as a Hippocrates oath. And there's no other oath replaced it yet. So, we better stick to that. Second thing is, treat the patient at your hand. Don't wait for the next patient. Don't think about the other one. Such as Professor Galkatia stopping halfway through the surgery and doing another surgery on the other side. Or, it's not going to happen. We have to look after the patient at hand. And carry on if we have done well, and do it well also. And having done that, if you have resources and time and things like that, do the next one. That is what is normal, and medical paternalism should be considered very seriously. Resource limited. This is resource limited. Who has limited the resources? And in Sri Lanka, the administrators have limited the resources. And I am born in Sri Lanka. Was it my choice? I could have born into a resource limited country. So limiting resources should not be considered by the medical fraternity. We are there to treat the patients. Resource limiting is a concept given to us by our rulers right throughout. And we should fight against that, not to bring a law because we are resource limited people and we do this. Are we fair? Common sense. Then prolonged suffering, our opposition was talking about. Yes, prolonging the suffering. Isn't it subjective? The suffering? That's a very subjective matter. And that is subjective for the patient. And some of which we have no way of assessing. So, and prolonging the suffering depending on the knowledge that we have. And the knowledge, as Professor Galkatia, my good friend, told, it is evolving. We are getting knowledge more and more. Just before we started, we learned a good lesson about microwave therapy to secondaries in the tumor in the liver. So we can go on learning. When I was a student, myocardial infarction was treated with morphine. Now it's not the case. So knowledge in ourselves, we are still learning. Have we finished learning to make it a law to withdraw treatment? We are still learning. So my point is, we are still learning. We have not achieved, and the countries are learning. And the countries which have given law, also some states have given and some states no, because they don't agree. And the states have given leaving the finances or administration or their laziness or something like that. There are so many other causes for them to pass these laws. And the relatives knowledge, as their professors are there, we are here, and we are arguing. Why this debate is all about? Lack of knowledge, isn't it? So how can we expect our relatives, non-medical people, to know the knowledge? And there is old age and young age and withdrawing thing, that life is life. Please don't withdraw my because I am older than you all, and don't withdraw treatment because I pay quite a lot of tax. And yes, you all want a card to, madam, I can show you. And see, gold taxpayer's card. So I pay quite a lot of tax, and you are not there to withdraw treatment. And and don't consider age is the elderly may be very experienced, like Abhishek sir and all. Sorry to mention, sir. And the young one may be living longer. That is a different thing. But human being is human being, young, old, and it's very important. Existing protocol, and there are existing protocols. Who made this and why? And mind you, we are going to make it a law. Maybe Punude, maybe in Colombo. Are we ready? This is making it a law. That is law abiding, and then it becomes a law for the whole country. Anuradhapura and Kotmale, everywhere they should be working. So we are not ready yet, if at all. And we have to have quite a lot of argument into this, knowledge about this. No, we are not. And example of a recovery of a patient, one patient was given to say that, patient is going to die, you all religious treatment, and I have recording, madam, I'll show you after all these things. So may I suggest to you, there's an important communication bias in this, and if you want to withdraw treatment, as Champa said, you can communicate in such a way and then withdraw the treatment. There's a big communication bias we should. At the end point, let me end. Please increase resources, increase the manpower, increase knowledge, increase space, increase equipment, increase kindness, increase willingness. Most importantly, increase human feeling. That is what we should do rather than withdrawing, making it a law, withdrawal of care. Thank you very much.
Thank you, Dr. Nias. Buddhika, since this is a debate, opposition leader has to speak next. And you must be armored with all your arguments for your final round. Buddhika, you must now show Api Thamai Hondatama Kale. Over to you, Buddhika. You got 7 minutes.
Thank you, madam, for reminding us again that in a resource limited setting, so many errors can occur in management, such as Apitamai Hondatamagale. So that's exactly what we are talking about here. Let's talk a bit about what the proposition has said so far, and then circle back to summing up what we have argued against so far. So the first speaker started by talking about this being withdrawal of care being tantamount to murder if current practiced, and brought up a couple of case scenarios. Well, yeah, if you break the law, you get punished. That's fine. That's what we are arguing about. He also said that if you're convicted of murder in Sri Lanka, the punishment is death. We have not hung a person for decades. The country is trying to progress towards preserving as much life as possible. And we are now arguing about legislating against that and for letting people die. So that is a bit of a tautology in itself. The second speaker seemed to suggest that because the patient's relatives are going from pillar to post for looking for medicine, because medicine is not available in the government sector, we should pull the plug and end their suffering. Perhaps one day we may all feel like that. But honestly, that is not a thought that we should be entertaining at all at medical practitioners, and let alone think of legalizing. Also, I really cannot understand how the proposition first therefore argues that it is humane and humanitarian to withdraw care, and then says that it is a cost-effective solution for releasing pressure in ICUs. You are either humanitarian because you are thinking about the patient, or you're thinking about economics. You cannot be both. And as a doctor, it would be better if we leave economics to the administrators and decide on preserving life, which is our main objective. So I think there's a bit of a mix-up in the arguments that the proposition have brought up there. Then to quote directly from the proposition, the decision to die with respect should be given to a patient. That is, that it should be a voluntary choice of the patient, whether the patient wishes to die. I'll circle back to how dangerous that is in my closing remarks. Just remember that thought. The decision to die with respect should be given to the patient, and it should be the patient's voluntary decision. So before circling back to that, we'll just discuss in brief the arguments that the opposition have, the proposition have brought up. They have tried to explain that this is the humanitarian way to go. We've clearly proved that it isn't. They've tried to argue that this is the cost-effective solution for a resource-strained economy. We've shown that it isn't, and you can't mix cost-effectiveness with humanitarianism. And also that there are plenty of alternatives, as Dr. Nias pointed out, to taking the cost-effective or cheap solution and killing the patient. And also, the patient has the right to decide, and that it's the patient's prerogative. Yes, it should be, and patients, anyone instinctively wishes to live. So let's circle back to that before we turn to the summary of our arguments. The last thing that they said was, that we talked about, was the decision to die with respect should be given to a patient. Yes, that's fine. But as we pointed out, suffering is a subjective thing, and also it is a situational thing. All of us might say that we want the plug pulled on us and that we want to die if it comes to that point. But are we going to feel the same at that point? Let's just take a simple example. It's a voluntary decision to jump into a river, no? If you want to end life, right? But don't you gasp for air at the last moment? Does anyone jump into a river, want to kill themselves? And can you imagine someone just letting the water in and killing themselves like that? No, you would gasp for air at the last moment. It's the same thing even when a patient makes an advance directive that they want the plug pulled on them, or they want ventilation. They will struggle, they will suffer. And for us who consider ourselves healers, to go along that pathway with legal backing, it's, I think, ethically wrong, because we know full well that that is going to be the end result. And so for that reason also, withdrawal of care, I think, should not be legalized. So to sum up what we have said so far, we have talked about how paternalistic it is from a medical practitioner's point of view to decide that we have the right to decide on these things. We also that ethically, morally, and constitutionally, that this is not something that should be legalized. Champa has shown how much prone to abuse and misuse this legislation would be in a system like ours. We have shown how the lack of resources and training in making these decisions can be really detrimental if something like this is legislated for. We have shown how it violates patient autonomy as well as the Hippocratic Oath. We've talked about plenty of alternatives to this. And we've talked also about how inappropriate it is to implement this in our country just because there have been prior precedents set in other countries. And yes, where do we go from here? where do we draw the line? That's a dangerous road that we are opening up. And it's something that from a medical practitioner's point of view would be better left closed. And finally, Champa has also pointed out that the real stakeholders here are society, and arguments like this, debates like this on closed doors without the real stakeholders having a choice do show how dangerous withdrawal of care being legislated on is, because it is people like us, not the people who are going to suffer the consequences, who are debating this here. So I would like to close by saying that I think we've made it pretty clear that withdrawal of medical care should not be legalized in Sri Lanka. Thank you all for listening.
Thank you, Buddhika. That is for your closing remarks. And this has come back again to the proposing team. Dinesh, for sure, may arbude oba visin nirmane karana lattak nam no way. But since you have started it, you have to end it. Over to you, Dinesh.
Thank you. Actually, I don't think that I need to say anything more, because some of the points that we were making has ratified by the opposition. Now, when listening to them, we were actually struggling to think what they were saying. I was reminded of Spain and the famous bullfights. There you get huge big bulls with sharpened horns and a matador. Now here I found a point here and a point there and a lot of bull in between. So therefore, I may not even need to use my 7 minutes, because at the moment I think we have actually established our case without any doubt. And what they were saying were going over and over, round and round, the same things being repeated. So, Dr. Nias, since you have explicitly in this forum said that you do not want treatment withdrawn, it will not be done so, because you have made a clear statement denying your consent. Now, as we said earlier, it is only people who have given their consent and given an advance directive that they do not wish to be on life support systems that we are going to remove. About misuse of this, exactly what we are trying to stop. Why does society, civilized society, have rules and regulations so that this misuse won't happen? Now, kicking people out of beds may not be so good, but can you equate that to Vasanthi here removing a ventilator and running with it to Champa's somebody? That will not happen. But if you think that is going to happen, if you think doctors are so callous, if you think doctors are so inhumane, then we need legislation for people like you. This has to be within a framework, a legal framework, like the Human Transplantation Act, which was in 1987, with much debate at that time. This act is being used by people like you. Why? Because it has a very strict framework. There is a consent that has to be given, and the consent has to be given in writing to the Director General Health Services. Then there is a council composed, including JMOs and other people from the DG's office, to see whether this system works properly or is abused. Because when debates were conducted before 1987 on this, there were people like you who said that people will be selling organs, that doctors will be opening patients and taking kidneys and selling it. Did that happen? Why didn't it happen? Because of the legislation. Because there is strict guidelines. There is a framework which we are working under. If there is the framework, then everybody knows the framework and to pull the plug just to satisfy Champa. Because she will be accountable for it. ICU beds. Our moderator will say that there are 2.4 ICU beds per 100,000 population. And because you think that this misuse may occur, even though there is legal framework, you are going to deny so many patients. Our first speaker said that one patient, you can get 7 other patients alive. Exactly what we are trying to say. Because of the Human Transplantation Act, which was opposed by certain people. Now 7 people will live a good life because of surgeons like you who will do the transplantation, and this one patient will get so much benefit in heaven by donating his organs. Cornea transplants have been going on for years. How many people can see because of cornea transplants? If there were people opposing every step of the way, these people would not have had those corneas. Think, what is the good a doctor can do? Are we going to tell our own people that you are scum and that you are going to misuse this system? No. If an advance directive is legalized, the patient, when he is competent, will give the advance directive, and this can be used when the patient is incompetent, when he is on a ventilator, and when it's futile. There is no point of prolonging care. He also says that 75% of the medical diagnoses are wrong. What are we all doing here? We should go home. If we can't diagnose 75% of the time, we should not go to doctors if we are 75% of the time wrong. So I personally don't believe that. We may be wrong, we are not gods, but 75%, then patients should not be coming to us for treatment, and my practice should improve by leaps and bounds. Unfortunately, I don't envisage that that would happen because our treatments are improving. And then about the other point about, treatment options going on, and like Jeevani said, the ablation, yes. But in Sri Lanka, by the time these treatments are developed, not only the patient's grandchildren also will be dead. Just try and go and fill your tank with petrol today, how long you have to wait. So trying to wait for these magical cures to come is not going to happen. So I really don't see any argument. What we propose is legalizing of something that actually may be happening now, and to give some safeguards so that it will not be misused or abused. Thank you.
Thank you very much. And that ends this very heated argument. And I'm sure, ladies and gentlemen, you all were really put into thread to decide which team to win. And to give the legal background, we have invited the President Councillor, Mr. Samantha Ratwati, whom I'm going to invite to the stage. Until Samantha is going to get himself settled, Samantha, we have nominated them as the judges. So this is the time until you come and settle yourself here. Okay, so we are going to ask you to vote. But remember, you cannot think about there being your friends or you all support some ideas on your own. It has to be, no need of a secret. You're not going to put the life support on the secrecy anyway. So that's okay, don't worry. So, so forget about your own argument or your own idea behind this argument. And it's simply the how the debate went off and how they battled it over to their proposed or the opposing ideas. Isn't it better to get a vote? Hands up. Yeah. Okay.
So, yeah. So let me now, are you all ready for the moment of truth? People who thinks a withdrawal of medical treatment should be legalized in Sri Lanka, the proposing team, please hands up. Okay, you need to count, I think. Yeah, please. Somebody should count. 1, 2, somebody. Decide 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20. 20 plus 18. Okay, yes. And the opposing team, y'all heard the beautiful battle of the opposing team. Yeah. Yeah, hands up people who thinks. Yes, they opposed it so well. Let me see the hands. Count again, Samantha. Anura, can you count? Yeah, I did count this side. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18. 18 and 20, tie. Oh, that cannot be. 18 and 20, now I counted. So, you all both won an unbelievable 20 and 18, 18 and 20. So, it's obvious, isn't it? Because everybody is in dark when it comes to this topic. And this will show the importance of you, Samantha. Over to you. Thank you very much, ladies and gentlemen.
Thank you, Professor Vasanthi. Am I also permitted to sit and talk, or you want me to get up? No. Right. I think before we start, it's best that we count the total number and see, because maybe anyway. I don't think there is any role for a lawyer to play when such, when medical experts have argued on, I would say, touching on the ethical aspect of it, the moral aspect of it, and the obviously based on very rational arguments, whether there is any room for a lawyer to say anything. Well, I would say, I believe why you wanted a lawyer to come here is probably if you were to decide that withdrawal of medical treatment is all right, though it is a tie now, it was all right if you had decided. Well, just in case you do get into trouble, to see whether there is a way of getting out of jail. That probably was the reason why most of you may have wanted me to come. Now, you see, unlike in the medical profession, in the legal profession, we deal with, at least legislation, we deal with a lot of definitions. So then it's very easy. I wouldn't want to say anything about the arguments for the proposition or the opposition, because you all have voted and it's equal. So therefore let it be that. But I will just say how the legal profession or the legislature gets over their problems is by clearly defining what they would like something to be interpreted as. Whatever the real interpretation may be, they define and say, this is what we mean by this. Then, of course, you get the lawyers coming in and saying that that is not what is actually said there, but it is something else. And then you go on. That is, but nevertheless, eventually a definition comes out. Now, I would like to talk about, because I was asked to talk about the legal background to this. There is, as I think Professor Fernando pointed out, you see, suicide, committing of suicide, in our ancient times was an offense in the sense, obviously not to the person. You wouldn't punish the person once he's dead. But in our ancient system, if somebody committed suicide, the whole village was punished. There was a reason for that. That is because they thought that there was something wrong with society, and that is why that person wanted to commit suicide. So in our Niti Niganduwa, that is there. But in the current laws, if a person commits suicide, suicide is defined for the purpose of creating another offense, which says aiding and abetting somebody to commit suicide is an offense. Then, as you all know, of course, murder culpable homicide, not amounting to murder, all those are offenses and they have consequences. Now, you see, these consequences are also defined, not like, you see, they are also very, they would say so many years for this, so many years for that, or it is by some other kind of, say, death. Of course, it's in the statute book, though it is not carried out, it is yet there. So it's unlike what you all were saying, like, it's unlike economics now. Some people say, because you are talking about the currently vogue topics, I would say it's not like economics where you say, some people say float the dollar, float the rupee, and then when it is floated, where the same people say, why is it that the prices are going up? So it's not that. The law is quite different. You have the consequence also given. The consequence is also defined. So because this 1987 Act was referred to, I can, if you like, show you how cleverly this has been done. I hope it's all right, my using a printed paper. I have it in the computer also too. I didn't realize that some people are sensitive to this. I have it in the computer also if you want. I can. I mean, you see, there is some, obviously you all probably have read this, but there is something. I actually, Dr. Pinto, I have made this note. Since it's only 10 minutes, I'll give a printed form for those who want to, can photocopy and give, and I'll also email it to you. I made a small note about the various authorities in different countries. You see, in all these countries, very quickly I will tell you, in all these countries, they have once again defined something called voluntary euthanasia and involuntary. Once we knowing this, involuntary euthanasia. There is no problem in those countries because these are also legalized. You see, now we are talking of a situation of an involuntary euthanasia. Involuntary euthanasia, your debate was with regard to that, or I would say a passive kind of euthanasia, where you get the doctor. Was that the topic? I was when you started, it was not quite clear to me, but then subsequently somebody clarified and said, no, that is not what you are referring to. First, the patient, according to them, that's what I realized. According to them, first the patient must consent, and then the doctor's thing comes in. But either way, what I wanted to point out was this cleverly worded section. You would have already seen this. You have, I think the doctors would have helped in drafting this. You have defined what is meant by death also. So there is, if you really want, a legal brain to tell you how you can avoid being convicted for murder, you see, there is this irreversible cessation. Of course, there's a typographical error, there's a typo here, but irreversible in the section itself in the internet, the irreversible cessation of functions of the brain may be determined by the prolonged absence of spontaneous circulatory or respiratory functions. That is part of the definition of death. Now, when that determination of prolonged absence of spontaneous circulatory or respiratory functions is made impossible by the use of artificial means of support, the irreversible cessation of brain functions shall be determined by any means recognized by ordinary standards of current medical practice. You must be knowing this. I presume all of you would have seen this. So, if you ask a lawyer, he would easily tell you, you just define this. You just say that, you see, it is now somebody is in life support. It is therefore impossible for you to determine how he would not have respiratory functions or circulatory functions. That means you can't, because you can't withdraw medical treatment. But of course, you can easily say, under the currently understood or determined means recognized by ordinary standards of current medical practice, his brain is dead. So if you do certify that, then I suppose, Professor Fernando, you escape. You might help your lawyer to assist you to escape a prosecution. So that this is how it's worded. Maybe it has to be interpreted, but this is how it's worded. So even now, if you really want to withdraw medical care, you can work it in the reverse. You see, you can work it in the reverse and say his brain is dead according to the current medical practice. If you were to say that, well, I suppose you can. Now, with regard to, you have told me to stop in 10 minutes, but I have printed this out so you can actually, I have explained the position in the United Kingdom, France, and actually this was not done by me, it was done by a junior. And you have gone and invited who is a lawyer who is not a criminal practitioner. When Dr. Article wanted me to come, I told him this, but nevertheless, in your cleverness, in the cleverness of the doctors, you have invited the civil lawyer who wouldn't know much about criminal law. So that's why it's like, asking Professor Vasanthi maybe to carry out a surgery. So anyway, this is the best I can do. What I can tell you is that as far as the current law is concerned, there is an offense called assisting somebody to commit suicide. It's an offense. Actually, killing is also an offense, or that murder is also an offense. Murder or culpable homicide, not amounting to murder, is also an offense. And the way you can get out of this is, the only way that you can get out of this is by saying that somebody's brain is dead. As to how that is done is left to your cleverness. That is, if you really want to do this, if you really want to withdraw based on the existing law, that is how you could do it. Well, if you don't want to, you will have to say the brain is not dead. So that is basically. Then of course the position in the United Kingdom. Each of these countries, now Professor Fernando was referring to India. India's the legal system is different. So their legal system allows the judges to create laws in certain instances, but ours doesn't. Our law can only strictly interpret. The judges can strictly interpret. That is why in India, this judgment that Professor Fernando referred to, I have given that also. They say why you must not confine yourself to the English law standards, because India is such a vast country and the circumstances are very different. So therefore, they have interpreted it this way. Those are the comments with regard to the law I can make. And so that will be all. Thank you very much once again for inviting me. Thank you.
Thank you, Samantha, for an interesting roundup of the law behind this important topic of the day today, because this involves my work day to day. And this is open for any questions from the audience. No, please. Yes, Saman, can I just give him the mic, please? Okay, good. It's very nice.
Yeah, I think out of everything that the opposing team talked about, one very important thing is the bias factor. Now, for instance, when I raised my hand for that side, the opposing side, I think I'm very biased because I'm for withdrawing treatment. So when it came to the debate, they may have won, they may have done better, but I was always mentally, I was on that side. So I was always thinking what they are saying is better argument. So
would you like to change your vote now? Because when I said not to, you cannot be biased.
Yeah. Well, the question is, can we ever remove the bias factor?
It is not, yes.
No, I don't think we can ever be removed. So they may have won, they may have debated better, but I was with them from the beginning.
Oh, right.
So,
you got another vote.
Right?
It's a passive vote.
So I think the bias factor they were talking about is something very important that we have to be very careful about.
Thank you, Saman, being so truthful. But I'm afraid as the chair here now, I'm going to count your vote to the other side. Because he
No, that's okay. And actually, there's one person who actually didn't vote. I'm not very sure now he's there. Because of course, maybe because of the, because he was little scared to raise the hand. And this is none other than Dr. Professor Arinda Dharmapala. He didn't vote. And he's disappeared because he knew when I twice looking at him, he's so sharp to note that I'm going to tell something about him.
He has 2 pictures of his.
Oh.
His born on either side.
So it's as someone says, it's so biased. And I told you all, you cannot.
Going to overpower the 2 pictures.
So now you all arguing with each other. This is the reality, ladies and gentlemen. When this question was put on the table to be handled by us as the intensivist, the last minute decisions, this is the question. It can be somebody else's somebody. And we are always biased with somebody. And I do believe your legislation on the black and white paper, even though Buddhika doesn't like it, will give us the answer on this. So ladies and gentlemen, another question or question 1 or 2 we might be able to handle.
So I would like to hear from Abhishek, sir.
Can we give the mic to sir or madam, please? And I'm sure, madam, you had some lot of questions in the morning from the ED physicians about this type of same topic, and I felt your words at that time saying that you might get a chance to listen from a lawyer.
Since I didn't get the proper answer,
correct,
I think I withdrew.
You can ask the same question if you want to by him.
You know the question, you can ask.
Okay. No, it's not related to this. He actually was asking about that. She was asking about the advanced directive in the morning, and the speaker said that it may be changing, and they might not be able to go by the same advanced directive which had been given earlier. Then she was telling, what if the patient is in a condition where he cannot be given his consent or discussion to redo, and what is Arinda? We were waiting for you, Arinda. Arinda, we were waiting for you. We realized that you didn't vote, and we are going to take your vote as the final vote to decide which team wins. Arinda, you can choose your teacher or your wife. All right, so Arinda's vote, ladies and gentlemen, has gone to that side. So let me have the winner then today. The opposing team wins. Thank you very much, Arinda. We are not surprised if you don't come for tomorrow's work, because and surely they are going to give you the food tonight, so don't worry about the food. But I'm very sorry about this. I mean, I will definitely report you back how he looks tomorrow morning. Thank you very much. Any other questions? So let us all give us a round of applause to both teams having a wonderful debate.
Thank you very much, everyone. I would like to invite all of you to please remain seated for a couple of minutes because we have to hand over certificates of appreciation to you all. It was a very intense debate with a lot of insight into the topic, and I'm sure behind every clinician and academic, we were able to see how talented they are when it comes to public speaking. So why don't we give another round of applause to them? In order to hand over the certificates of appreciation to the 2 teams, I would like to invite our moderator today, Professor Vasanthi Pinto, and our resource person, Dr. Samantha Ratwatte. Firstly, I'd like to invite the members of the proposing team, Professor Dinesh Fernando, Dr. Sairi Pereira, and Professor KB Galkatia to receive their certificates. Now I would like to invite the members of the opposing team, Dr. Buddhika Dasanayaka, Dr. Champa Ratnatungal, and Dr. S.M. Niyas. much. And I'm sure you all enjoyed the moderation that was done by Professor Vasanthi Pinto. So in order to hand over a certificate of appreciation as well as to Dr. Samantha Ratwatte, I'd like to invite Professor A. Martigala, the President of Kandy Society of Medicine, to please come forward. Thank you very much, sir. So with that, we have concluded not only the debate, but actually the 44th annual academic sessions of Kandy Society of Medicine. So thank you very much, and we will see you tonight.
As a concluding remark, I would like to thank all of you for the presence here today, as well as we had very fruitful 2 days of workshops, orations, etc. And mostly by listening to what happened now, I think, I don't know whether we have created a culture of very good culture to debate and discuss about our issues, current days issues, in a very objective manner. If we bring that to the hospitals and etc. to the society, I think that would be very fruitful. So I think I'm happy about that. Thank you very much, and we'll meet tonight. Thank you.
So while the photograph is being taken, one more announcement. Tea will be served downstairs. You may have tea and then proceed to leave.